I request all the delegates to occupy the front benches, please. Good morning, Dr. Shankar. Dr. Shankar, I request you call upon Dr. Shankar. Please come to the stage. Good morning, everyone. So we're gonna start the session now. So because there is certain delay with the crowd and as well as the presentation, so we are already running late by half an hour. And I would request all the delegates to move forward to the front rows. And each session is going to be for 20 minutes, and there is going to be a buzzer at the end of 17 minutes. And try to keep your questions at the end of the session. And we would like to invite the chairpersons for the first session. It is Dr. Tulsi Ram, Professor, General Medicine, SWIMS and Consultant Physician in DBR Hospital. Please come to the dais. Please welcome Dr. Venkat Sivakrishna, Head of the Department, Cardiology, Amara Hospital. I request Dr. Hari Krishna to grace the stage. Infectious diseases, SWIMS. And I'm going to invite myself. I'm Dr. Varun, Consultant Head of the Department, General Medicine, Amara Hospital. I request Dr. Hari Krishna to invite the chairpersons, faculty, speaker, and
Good morning, everyone. Dr. Shankar Vallapu is the Senior Consultant and Head of the Department of Critical Care Medicine in Amara Hospital, and he has 3 book chapters to his credit, and he received APJ Abdul Kalam Award by ACT Now, an NGO, and he is the editorial member of Critical Care Communications 2025, and his areas of interest are ventilator, POCUS, and invasive procedures in intensive care. Now I request Dr. Shankar Vallapu to start his session.
Slides, please. Okay. There is some technical delay. 1-2 minutes. Good morning, everyone. Myself, Dr. Shankar, Head of Department Critical Care Medicine, Amara Hospital. A warm welcome to all the delegates. Today, the whole day, we are going to discuss about sepsis, as sepsis is the leading cause of mortality and morbidity in the current scenario. Most of the hospitals, ED and ICU, face difficulties due to sepsis. So, you can say one of the common cause of mortality is a sepsis. So, in coming 20 minutes, I'll be discussing about sepsis once the slides are ready. So, my topic is sepsis guidelines from Surviving Sepsis campaign. అట్లా తీసుకోవద్దని చెప్పు, లాస్ట్ అని చెప్పు. అది ఏంటంటే సైన్స్ సైన్స్ అలో చేయండి, పర్లేదు పర్లేదు, సైన్స్ అలో చేయండి, పర్లేదు, ఓకేనా, పర్లేదు, అలో చేయండి, అలో చేయండి, 1 2 మెంబర్స్ అలో చేయండి, పర్లేదు. నేను ప్రాబ్లమ్. It's going to take 5 more minutes, it seems. Kind.
Hi everyone. So before Shankar sir goes for guidelines, I have a small question. How many of you seen a patient with fever directly coming to you without taking any antibiotics in your clinic? Can you raise your hands? Really? Without any antibiotic? So there's only one hand raising in the entire group. That means we don't see any patient without taking some 3 to 4 days of antibiotics. So that is where it is important to learn about these guidelines.
Thank you, Hari Krishna sir, for nice introduction. So I'll be starting our session now. Please, slides, please. Full screen, it's okay. So my topic for coming next 20 minutes would be Surviving Sepsis Campaign Guidelines. So from 2021. So my objectives are, we'll talk about burden of sepsis, sepsis definition, guidelines, what are changes from 2016, and post-sepsis syndrome. So sepsis is very common. 1 out of every 20 to 25 patients in the hospital has sepsis. 40% of ICU's revenue is spent on sepsis management. It is highly prevalent, treatment is costly, difficult to diagnose. If it is delayed in the treatment, there is it can cause death. So sepsis is a medical emergency. So sepsis, if delayed or diagnosis is delayed or treatment is delayed, it can cause increased length of stay and increase the cost of patient treatment. So you can see 40 to 50 million deaths per year. One of the 5 deaths in worldwide is due to sepsis. So it is a number 1 cause of death in hospital, number 1 cause of hospital readmission, number 1 cause of hospital healthcare cost. So in recognized sepsis, every second counts. So coming to definition, in 2016, a new definition came for sepsis. It is defined as life-threatening organ dysfunction caused by dysregulated host response to infection. The organ dysfunction can be represented by an increase in the SOFA score of 2 points or more, which is associated with in-hospital mortality of more than 10%. So you can see there is sepsis 3. It includes suspected infection plus SOFA score. So it indicates it is a mortality indicator. So coming to septic shock. Once if you don't identify patient with sepsis, it can lead to septic shock. So septic shock is defined as a subset of sepsis in which profound circulatory, metabolic, cellular abnormalities which leads to increased mortality than sepsis alone. So septic shock can be identified in patients with persistent hypotension requiring vasopressors to maintain MAP of more than 65, lactate level more than 2, despite adequate fluid resuscitation. So before 2016, there was severe sepsis was there. Now from 2016 onwards, it was redundant. So there are only 2 components now. Still we are getting in some patients they write as severe sepsis. So we don't have word of severe sepsis now. We have to use either sepsis or septic shock. So sepsis clinical criteria, infection with SOFA score. In SOFA score, there are 6 organ systems involved in which PF ratio, if it is decreased, that indicates score 1. The patient requiring vasopressors for our hypertension, 1 point. Decrease in platelets, 1 point. GCS, decreased GCS, 1 point. Increase in bilirubin, 1 point. Increase in creatinine or oliguria makes 1 point. So out of the 6 points, if there is more than 2 or equal to 2, that indicates sepsis. So this sepsis is triggered by infection, which leads to uncontrolled inflammation, leads to immune dysfunction. So the final common pathway leads to endothelial dysfunction with microvascular thrombosis, can lead to hyperperfusion ischemia, can lead to organ dysfunction, ultimately if you don't intervene early, lead to death. So as I said, if you diagnose sepsis and treat early, it leads to 10% mortality. If you don't diagnose at the late stage of sepsis, if lands in septic shock, the mortality can be up to 40%. If it leads to MODS, the mortality is as much as more than 50%. So to handle sepsis, in 2002, surveillance sepsis campaign was initiated in Barcelona by ISCCM. So the first guidelines were started in 2002, and from 2004 onwards, every 4 years, there is an update in the sepsis campaign guidelines. The last update was in 2021. Next update supposed to be in this year. Maybe we are waiting for the next update. So the major changes in the patient management in the recent time was in 2018, the bundle approach. Previously, the patient care for sepsis management directed over 24 hours, that is 6 hours bundle, 24 hours bundle. Since 2013, it made up to 3 hours and 6 hour bundle. But latest, since 2018 onwards, they felt that sepsis is a medical emergency. You have to treat sepsis as early as possible, like any other MI, any CVA like that. So it then came into picture of 1 hour bundle, which will be discussed in the next topic. So there are 5 components here. One is you have to measure lactate, remeasure if it is more than 2. Obtain blood cultures before administration of antibiotics. Administer broad spectrum antibiotics after taking cultures. You have to resuscitate as early as possible with 30 ml per kg. This is also, there are some updates over here. We cannot give 30 ml per kg for all the patients. So it has to be guided for the patient requirement. If the patient doesn't maintain pressures, BP, you have to go for vasopressor. The target is 65. So the surveillance sepsis campaign guidelines has given a statement. They say that these guidelines are formed to help the clinicians. They won't strongly recommend that. They say that it will help you clinicians to take a decisions. So they said that it cannot replace clinician decision making capability when presented with a unique clinical variable. So always clinician decision making capacity is given superiority over the guidelines. So the experience is superior to the guidelines. So it is suggested or recommended. So they have used different process to develop the guidelines. So they talked about 6 topics, in which first one is screening and resuscitation, infection, hemodynamics, ventilation, additional therapies, goals of care and long-term outcomes. And they grade each guideline as a strong, best practice statement, or weakly graded, or no recommendation. So if the most of the people involved in the studies agrees for the statement, it is strongly graded. If around 66% of the people agree for it, it is weakly graded. If less than that, or there is not much people opting for it, they may have against recommendation, or if the people oppose it, they have against the guidelines. Coming to screening and initial resuscitation, the first and most important is they suggested to have a standard operating procedures for any treatment. Like MA has a protocol, CVA has a protocol. So this also should have a standard operating treatment for procedure. Previously, they were telling that, so we should have an improvement program for sepsis, and in any sick patients, any acutely ill presenting patients should have a screening program for the sepsis. The second one is, before 2016, there was one recommendation was there. There was hype given for QSOFA. After 2016 and 2021, they said that QSOFA is not superior over the existing SIRS or NEWS criteria. 1 second. There is some technical glitch here. So in 2021, previously also there was a weight given for lactate. They always suggest that lactate should be measured if you have suspicion of sepsis, but it's a weak quality of recommendation. But you should always look for the other cause of lactate elevation. So as it is a medical emergency, you should start resuscitation as early as possible. You should start resuscitation with the crystalloids, that too preferably over given preference for the balanced crystalloids. They said that you have to use dynamic measures to guide fluid resuscitation over static measures. They suggest decreased serum lactates during the patient treatment or not using lactate serum alone. So they suggested using capillary refilling time to guide the resuscitation as an adjunct to other measures of perfusion. So they suggested to target MAP of 65. They recommend not to target higher MAP because it has more side effects. If the MAP is less, it has underperfused organs, it has that too. So then, if you don't have any you don't find any cause, then also you have to give antibiotic within 3 hours. So next coming to, they suggested against using procalcitonin. So if you have a clinical suspicion, so for initiation of antibiotic, don't use procalcitonin. If you have suspicion of sepsis or septic shock, you can directly go for having antibiotics. Don't get antibiotics used upon based on procalcitonin. So if you have suspicion of MRSA, go for MRSA coverage. If no suspicion, you avoid MRSA coverage. If you have suspicion for MDR organisms, you can start with 2 antimicrobial agents as an empiric treatment. If you have low suspicion, so you can go for only single antibiotic. If you have found an organism with some resistance pattern, with some sensitivity pattern, you can de-escalate to single antibiotic. So if you have suspicion of fungal, you can go for fungal coverage. If no suspicion, no fungal coverage. There is no recommendation on the antiviral agents. So they always suggest that we have to use antibiotics as an infusion, preferably beta-lactams and carbapenems. We usually give within half an hour, 1 hour. We should avoid that because they are time-dependent antibiotics. We should give maximum duration of antibiotic as infusion. Always think about PK/PD principles during specific drug properties. So you always look for any specific anatomical diagnosis and address it. As soon as you address the specific anatomical, like if you have some abscess in the abdomen, you drain it. So you can de-escalate the antibiotic over a period of time. If you have a suspicion of some vascular device, suspicion as infection, you have to remove it as early as possible. So you have to de-escalate antibiotic therapy. Don't you go for fixed duration. Like sometimes we say that we have to, some people use for 15 days, 20 days, not like that. If the patient is having clinical improvement, no fever for 1 or 2 days, then you can de-escalate the antibiotics. Coming to hemodynamic management. So initially you have to use for crystalloids. If the patient doesn't respond with crystalloids, you have to go for initiation of norepinephrine. There is against gelatin and starch. People, I think, still using gelatin and starch in the ICUs. We should avoid it. So there is a strong recommend against it. So these things again will be discussed in next session, vasoactive management and all. Coming to ventilation. So ventilation is similar to any other routine case. Like in ARDS patient, as we manage, we have to go for low tidal volume ventilation strategy. Target low plateau pressure of 30, higher PEEP over lower PEEP. So higher PEEP is recommended, similar to ARDS patients. Always go for low tidal volume, use traditional recruitment maneuvers. They are against increment PEEP. So you have to use traditional recruitment maneuvers. Similar to Urosepsis study, here also you have to prone for more than 12 hours. Use intermittent neuromuscular blocking agents over continuous infusion. When the patient fails routine strategies, you can go for VV ECMO. Additional therapies, they suggest using hydrocortisone if the patient doesn't respond on vasopressors, agonist polymyxin B immunoperfusion, other purification systems. We have a separate session in the evening by nephrologist in the evening. So restricted transfer strategy is preferred over liberal strategy, agonist IV immunoglobulins. So to avoid GI bleeding, you have to go for pantoprazole ulcer prophylaxis. You always think about VT prophylaxis. Don't use double prophylaxis, like some people use DVT prophylaxis, pumps and pharmacological. Always single thing is recommended, that too preferably LMWH. So if the patient has AKI, go for renal replacement therapy. No AKI, no replacement therapy. Target sugars less than 180. Avoid against vitamin C in the recent guidelines. Don't use bicarbonate because if the acidosis is due to lactic acidosis. You can give bicarbonate if the patient has less than pH 7.2 with AKI. So always try to feed the patient as early as possible, preferably within 72 hours. The main importance in the guidelines are given in the 2021 are long-term outcomes and goals of care. Because we treat the patient in the ICU with high-end antibiotics, high-end care and all. They are financially completely drained out. We discharge them. After going home, usually without finances, many people die at home. So you have to, in these guidelines, they have given importance to the long-term outcomes and goals. So sepsis survivors always has high mortality and morbidity in the coming months and years. So always screen for economic and social support. You should screen them. You should explain them. You should send to some other facility which has less cost. You should always think about economic and social support. Treating the patient and discharging here is not important. Their life is important. So you should think in that. So always involve the family in the decision making. And one important thing is we miss important medications in the previous admissions, previous OPs. They'll be having diabetic medications. So always have a proper medication chart, what they are taking from the beginning, what they have to use after going home. So that's called reconciliation medication. So you should always give information about the sepsis. You should tell them what can they get after discharge, what are the problems they can face, when to come back. So that's important. That should be mentioned in the discharge summary or explain them well. One more thing, important thing, everyone should develop a critical care transition program during ICU stay for flow transitions, shifting the patient from the ICU to the ward. You should explain to the ward people or ward doctors that what are the alarming signs. So when to shift the patient back to ICU, when to inform to the intensivist, when to inform to the consultant. These all things should be clearly mentioned in the program. So this same thing should be written as a proper handing over process. So always try to educate the family what is sepsis, what are things can happen, how severe it is. So these things are developed in advanced countries like this peer support, post-critical illness follow-up programs, post-hospital rehabilitation program. I think recent coming days, major hospitals are planning this. Even we are about to start this. So there is insufficient evidence for when to follow up the post discharge. So these are the common source of sepsis. You can see. So critical care is a concept, not a location. We cannot say that critical starts in the ICU. It frequently begins in the emergency department with our ED physicians intervention, and that continues in the ICU management. And so we should always think about sepsis clock like MI, anything. Sepsis at inception is difficult to recognize, but easy to treat. Left unattended, it becomes easy to recognize, but difficult to treat. So if you difficult to recognize initially, but treats early, recovery is good. If it is diagnosed late, the outcomes will be poor. So these are components of post-sepsis syndrome. Different organ systems like cardiovascular system, metabolism, inflammation, immune system, fluid retention. 2 more minutes. Cognitive changes, recurrent infections. So these all things a patient can have in post-discharge. So they have a lot of long-term effects. So except on few occasions, the patient appears to die from the body's response to infection rather than from it. So it is the response from the body which is killing the patient than the infection alone. So always stop the progression of disease. So stop sepsis, save lives. Thank you.
Please give a round of applause to Dr. Shankar for his morning session on sepsis. We would like to take the questions at the end of the session, and I would like to request Dr. Tulsiram to invite our next faculty.
Good morning to everybody. First of all, let me thank to Amara Hospital for conducting a CME, one-day CME on sepsis. The next topic is bundle approach and optimizing the resources by Dr. Srikanth. Is a MD, PDCC critical and a senior and HOD Department of Anesthesia and Critical Care. Presently he is working in the Aston Anadri Hospital, and his achievements are best paper for Neuro-ICU poisoning at the Jaipur, and its area of interest is sepsis, hemodynamic monitoring and ECMO. Srikanth will tell about how to optimize and a bundle approach. So he will tell about what is optimize and what is a bundle approach. Optimize means what is the sources that is available and how can we use the best of that sources. So with the availability sources from PHC to tertiary care hospital, from first approach to final approach, and bundle approach. This is very, very important in sepsis. So overall,
this is a complex and heterogeneous syndrome. It is one of the most common causes of death in critical care units. So, like in polytrauma and acute MI and stroke, early recognition and treatment is crucial for the management of sepsis and for the outcomes. So, definition is already discussed by previous speaker. So, sepsis is nothing but the early signs of organ failure due to infection, and septic shock is identified by the signs and symptoms of tissue hypoperfusion. So, for the tissue hypoperfusion, there is a central window and a peripheral window. So, in central window, you should have the disorientation of the patient and confusion will be there. And the peripheral window will always look for the cold, calming extremities and decreased urine output and 3D pulse, all these things. So, the bundle care, bundles are the group of evidence-based interventions which when implemented together produce greater benefit in terms of outcome than the individual therapeutic interventions. Care bundles are simple, uniform and have universal practical applicability. So, whenever patient with presented with sepsis and septic shock, you should do the same interventions in this bundle approach. Coming to the sepsis guidelines, Surveying Sepsis campaign is launched in 2002, and in 2004 they have first guidelines released which includes 6 hours and 24-hour bundles, and they are updated in every 4 years, and the recent one is the 2018 1-hour bundle. So in 2005 they have 6 hours resuscitation bundle and 24 hours management bundle. In 2013 they updated to 3 hours and 6 hours bundle, because sepsis and septic shock are medical emergencies. Whenever patient present with septic shock, you should act very fastly. Suppose patient come to the your ER ICU, if you act, suppose it is 6 hours or 24-hour bundle, so if you act evening, the patient, the outcomes will be not that good. So in 2018 they have came with 1-hour bundle. That is Surveying Sepsis Campaign Bundle 2018 update. So it includes the interventions are measure the lactate levels and remeasure if the initial lactate is more than 2 millimoles per liter, and obtain the blood cultures prior to the administration of antibiotics, and administer the broad spectrum that is appropriate antibiotics, and begin the IV fluids that is 30 ml per kg for hypotension or lactate more than 4 millimoles per liter, and apply vasopressors. So patient is hypotensive during or after fluid resuscitation to maintain the MAP of more than 65 millimeters of mercury. Here the time zero time of presentation is nothing but the whenever patient present to the ED and you recognize the patient in sepsis and septic shock, or whether the patient is suppose in the room or ward he developed the signs and symptoms of sepsis and septic shock, that is considered as time of presentation. So this is the strength of recommendations and quality of evidence for each element of the bundle care. Here the lactate levels have weak recommendation and administration of antibiotics and IV fluids have strong recommendations. Coming to the lactate levels, while serum lactate is not a direct measure of tissue perfusion, it can serve as a surrogate. So if the initial lactate is more than 2 millimoles per liter, it should be remeasured within 2 to 4 hours to guide the resuscitation to normalize the lactate in patients with elevated lactate levels. So these are the studies that evaluating the impact of lactate guided resuscitation. In 2010, Johnson study, this is a critical ill patients with lactate levels more than 3 milliequivalents per liter. They protocolized patients with decrease the lactate levels by 20% in 2 hours within the 8 hours of admission. So the findings are hospital mortality lower in the lactate guided resuscitation when compared to the control groups, but they have limitations. The decrease of mortality is not related to the lactate guided resuscitation. And in 2014 another study, Hernas study, they time to normalize the perfusion related parameters, that is central venous saturation and CRT and arteriovenous CO2 gap and lactate levels. They found that only 52% of the patients had normal lactate levels at 24 hours compared to 70% who attained the normalization of the perfusion parameters. Here the persistent resuscitation efforts directed towards the normalization of the lactate may not be appropriate. It can lead to increased fluid accumulation. So it can lead to venous congestion and organ failure if you target the only lactate levels. So whenever a patient present with septic shock, apart from your lactate, you should look for the other parameters of tissue perfusion like central venous saturation, CRT and PCO2 gap. This is another recent trial, Andromeda shock trial in 2019. They studied the resuscitation in the patients with normalization of capillary refill time, that is less than 3 seconds, and another group decreased lactate by 20% in every 2 hours. They found that higher mortality in the lactate guided resuscitation group and a significant reduction in the organ dysfunction at the 72 hours in the capillary CRT guided resuscitation group. So they have limitations, the sample size and difference in 15% mortality may be too small to achieve the statistical significance. Coming to the metabolism of lactate, glucose is metabolized to pyruvate, that is glycolysis pathway, and this pyruvate when enters the aerobic pathway, that is Krebs cycle, it is converted to acetyl-CoA by the enzyme pyruvate dehydrogenase, and in an anaerobic pathway pyruvate is converted to lactate by the lactate dehydrogenase. This lactate is again converted to pyruvate in the liver. This pyruvate is converted to glucose, that is Cori's cycle. This is a brief metabolism of the glucose and lactate metabolism. So in sepsis, mechanism of hyperlactemia sepsis, main mechanism of hyperlactemia sepsis is not due to tissue hypoxia, that is a late phenomena, mainly due to the decrease of pyruvate dehydrogenase enzyme activity. So another causes of is increased aerobic glycolysis and increase the catecholamines, endogenous and exogenous catecholamines that can lead to hyperlactemia. Persistent hyperlactemia is a poor prognosis. So whenever you interpret the lactate in sepsis and septic shock, you can see the type 1 and type B lactic acidosis. Type 1 is mostly due to tissue hypoxia, that is related to mostly any form of shock, and type B is due to liver disease or drugs and thiamine, mitochondrial myopathy, all these things. So this is the Andromeda shock trial already discussed. So this is algorithm for critical ill patients presented with increased lactate levels. Whenever patient with increased lactate levels, and look for the cause not related to the tissue hypoperfusion. So whenever seizures or DKA, that is increased glycolysis, that can lead to increased lactate levels. So another is you can check the abnormal perfusion parameters, CRT and central venous saturation and PCO2 gap. So in this case you can increase the flow and pressure, and again you can check the lactate levels. When the lactate is elevated and the perfusion parameters are normal, so you cannot target the lactate targeted fluid resuscitation. You can consider other problems and source control and you can remeasure the lactates in the next 2 hours. So next component is obtain the blood culture prior to antibiotics, and sterilization of cultures occur within few minutes after the first dose of appropriate antimicrobials. So cultures must be obtained before administration of the antibiotics. So at least you can take 2 sets, that is 2 sets of aerobic and 2 sets of anaerobic blood, that is total 40 ml you can take for the better yield of the bacterial yield. If you take 40 ml, the sensitivity is around 92%. If you take 30 ml, it is around 84%. 20 ml, the sensitivity and bacterial yield will be very less, that is 74%. So administration of antimicrobial therapy should not be delayed in order to obtain the blood cultures. So next intervention is administration of broad spectrum appropriate antibiotics. So empirical broad spectrum antibiotics with 1 or more intravenous agents to cover all the agents started immediately, and once you can know the pathogen, you can narrow down the antibiotics, and antibiotic stewardship is important in the high quality sepsis management. So antibiotic timing, whenever patient is sepsis with septic shock, definitely you can give the antibiotic ideally within 1 hour, and sepsis is possible without shock. You can look for the rapidly the infectious and non-infectious causes of shock, and in this scenario we can give within 3 hours the antibiotic. So when a patient with septic shock with high risk for MDR organisms, you can use the 2 antimicrobials with gram-negative coverage, and low risk for MDR organisms, you can use only 1 gram-negative agent. So these are the studies that time to treatment and mortality during mandatory emergency care for sepsis. They studied 49,000 patients, and the timing of early antibiotics and hospital mortality in sepsis. Another one is ED door to antibiotic time and long-term mortality in sepsis. So what they found that each additional hour of time from ED arrive to administration of antimicrobials associated with increased odds of mortality, and there is strong association in patients with septic shock. So mortality increase after 3 to 4 hours from the hospital arrival and sepsis recognition. They have limitations in these studies are risk of bias and inadequate risk adjustments. So these are another studies. So this is a broad spectrum antibiotic use and poor outcomes in community acquired pneumonia. This is a retrospective study. The failure to cover MRSA in patients with MRSA may be harmful, but unnecessary MRSA coverage in patients without MRSA also harmful. This is another nasal MRSA screening. If you do nasal MRSA screening, suspected MRSA pneumonia, reduced duration of empirical antibiotic, that is MRSA, approximately 2 days without increasing the adverse clinical effects. This is the timing of early antibiotics and hospital mortality in sepsis. They studied 35,000 patients, septic patients in 21 departments, emergency department to 2013 to 15, and the median time to administration of antibiotic is 2 hours. So in time from hypotension onset, if it's time more delayed in the administration of antibiotics, there is decrease in the survival fraction. If you go more than 36 hours, the chance of survival will be 10 to 15%. So same it is depicted in the this chart. After 4 hours, there is increase in the odds ratio of death. So this is the empirical decision making for antimicrobial therapy in critical ill patients. It is a recent study in 2023. So whenever you prescribe the empirical antibiotics, you can give the appropriate antibiotics. You should know the dose optimization, and you can know the pharmacodynamics and pharmacokinetics of the drugs and the patient's volume of distribution and augmented renal clearance, all these things, and you can know the site of infection and what are the most common pathologies, and also know the risk factor for the MDR organisms. And recently we have molecular microbiology like MALDI-TOF and biophytes. You can get the results within 2 to 6 hours and know the clinical severity. That is, if it's a high Apache and SOFA score, definitely you can suspect some MDR organisms. You can start the antibiotics accordingly. These are the risk factors for the MDR organisms, that is gram-negative and MRSA. So whenever you should have good knowledge about the resistant mechanism of the pathogens, so you can direct it accordingly. So this is AMDER classification, which includes A, B, C, D. So this is another update, 2023 update on the sepsis and septic shock in adult patients and management in the emergency departments. So coming to the other component, that is administration of IV fluids. Early effective fluid resuscitation is crucial for the sepsis-induced tissue hypoperfusion or septic shock. So you should begin the IV fluids, that is 30 ml per kg of IV crystalloids, and you can give complete this within the 3 hours of recognition. This 30 ml have so many limitations. So strong recommendation use of crystallized solution and sustained positive fluid balance during ICU stay is harmful. So after initial fluid resuscitation, you can always assess the fluid responsiveness. There are so many dynamic tests like passive leg resistance test and forced expiratory occlusion test are there. So this is early goal-directed therapy in treatment of septic shock. This is observational study, single center study done in the emergency department. So what they found is decreased mortality, 30% in the early goal-directed therapy when compared to standard group with 46% mortality. They have predefined goals, that is maintain the CVP around 8 to 12 millimeters of mercury and a MAP of more than 65 and venous saturation more than 70. So if you target this CVP around 8 to 12, patient may need more fluids and it will have deleterious effects. So again, this early goal-directed therapy is criticized by another trials like major trials like process trial and arise trial and promise trial. So what they found that there is no decrease in mortality in early goal-directed therapy, even they cause increased fluid accumulation in the early goal-directed therapy, and also increased blood transfusions and increased vasopressors used in the reverse study. So fluid resuscitation in sepsis, that is 30 ml per kg is a hoax, because some patients may present with cardiogenic shock, who is recovering from the cardiogenic shock with who developed ventilator associated pneumonia. So this 30 ml per kg may be harmful for the patient. Another CKD patients with necrotizing fasciitis, they came with shock. In this type of subgroup of patients, if you give 30 ml per kg within 3 hours, it can lead to fluid accumulation and harmful effects of the fluids. So always you can individualize the fluid therapy in different subsets of people. So whenever patient present with delayed presentation, if you give the fluid resuscitation, only 6 to 8% of patients are fluid responders. Another patients are non-responders. So these are the again the different trials comparing the crystallite, that is normal saline versus plasmolite. So this is how I personalize fluid therapy in septic shock patients. So apply vasopressors. Urgent restoration of adequate perfusion pressure to vital organs is a key part of resuscitation. It should not be delayed. So you have to maintain the mean arterial pressure of more than 65 millimeters of mercury. So initial choice is definitely the noradrenaline. Then if you are not improving with noradrenaline, then you can add the vasopressin. These are the another trials like Vanish trial and VAST trial. So use noradrenaline as a first line vasopressor therapy, and target of MAP of 65 millimeter of mercury, and consider invasive line, that is arterial lines. If the central line is not accessible, you can initiate in the peripheral line up to 6 hours. If MAP is inadequate, you can add the vasopressin. So if you suspect some cardiac dysfunction, you can add the dobutamine or switch to noradrenaline. So whenever patient present with septic shock, you should always have do the focus within 2 to 3 minutes. You can identify the LV dysfunction or any other cause of shock. You can see the RARV dysfunction or pericardial tamponade, and you can do the lung ultrasound. You can check the B lines and IVC, and it will take hardly 2 to 3 minutes. So you can after that you can proceed whatever interventions are there. This is how you escalate vasopressors and corticosteroid therapy in patients with septic shock. So whenever patient the initiation of vasopressors, you can, whenever the noradrenaline dose is more than 3.3 mics per kg per minute increasing, then you can add the vasopressin, and you can add hydrocortisone and fluorocortisone also. Whenever refracted to the multiple high dose vasopressors, you can consider the CRRT, methylene blue and other therapies. So what is the limitation for this bundle? So triage time is not realistic. So all elements need not to be completed within 1 hour. So most of the patients coming to ED with not present with organ dysfunction, they develop a later period of time. So unnecessary administration of antibiotics, and suppose patients with CHF and end-stage renal disease, you can, if you give 30 ml per kg of fluids, you can drown the patients, and fear of regulatory mechanisms. So summarize the sepsis bundle. Data strongly suggests early improvement associated with improved survival. So increased mortality associated with hourly delay in the management. So this 1 hour bundle is, you can viewed as a quality improvement opportunity and act as quickly as possible. So ideally begin in the first hour, may not be necessarily completed within the 1 hour. So sepsis and septic shock are medical emergencies. So you can measure the lactate levels and remeasure the lactate if initial lactate is more than 2, and obtain blood cultures before administering the appropriate antibiotics, and begin and give the IV fluids 30 ml per kg. Always you can personalize this one, 30 ml per kg. Suppose patients come with cardiogenic shock and other things, you can start with 10 ml per kg. And another thing is apply vasopressors if the hypotensive during or after resuscitation to maintain the MAP of more than 65 millimeters of mercury. Thank you. Will not wait for the adequate fluid resuscitation, and we shouldn't do the fluid responsive test also. In this time, maintain the MAP of, map of more than 65 is very important. So simultaneously we start vasopressor, that is noradrenaline, along with we will do fluid resuscitation.
And another
guidelines, no? So where do you want to keep corticosteroids in your practice, in your clinical practice?
So good question, sir. When the patient is not responding, if the vasopressor's requirement is increasing, so you can say 0.03 to 0.05 mics. The patient is requiring higher dose of, if the keep on dose increasing, sepsis worsening, then you have to start vasopressor, corticosteroids. So there is a strong recommendation, there is recommendations there, we have to use corticosteroids. So the dose is around 200 mg per day. It could be given as a single dose or in divided dose. Usually we practice 50 mg 6th hourly or 100 mg BD. So it is recommended if the patient requiring higher vasopressors.
One last question. So fluid, inotropes, everything in sepsis. So how do you manage a patient with a cardiogenic shock per se, who is having a severe LV dysfunction, or a patient with acute MI? Sometimes they can have sepsis. So this question is to both of you, Dr. Srikanth and Dr. Shankar. How do you manage such kind of patients where you can't give much fluid, you have sepsis? So how can you manage it?
Very interesting question, sir. Recently we had a patient with left MI present with cardiogenic shock, and he is recovering from the cardiogenic shock, and he shifted from the another hospital. He is already ventilated for more than 48 hours, and whenever patient coming to our intensive care unit, patient developed ventilator associated pneumonia. This is a very complex interaction whenever patient with LV dysfunction and sepsis and sepsis induced hypotension. Definitely whenever patient presented with sepsis induced hypotension, already cardiogenic patient recovering from the cardiogenic shock, and he develops sepsis, that is he developed VAP. Definitely we will give 10 ml per kg of fluid initially. Then we can assess the dynamic tests like passive like Gregson test, and we can see the whether the patient is fluid responsive or not, and other parameters you can check.
Thank
And
you,
we
thank
have
you, sir.
dynamic tests like passive like Gregson test, so you can check. If the patient is on ventilator, you can check the forced expiratory this one, and also tidal volume challenges. And if you have sophisticated monitoring, you can have cardiac output monitoring. So even with advanced hemodynamic monitoring, is survival if you do, only you can better understanding of the pathophysiology of the patient only.
Thank you, sir. So due to lack of time, I'm sorry to interrupt the session, and we would like to carry up on the questions for the lunch and networking meet, what we have after the sessions. And I would request Dr. Srikanth to stay on stage for a couple more minutes, and I request Dr. Tulsiram and Venkat Sivakrishna to hand over the memento for the faculty.
Sorry. Meanwhile, Shiva has asked a good question. So first decide whether the sepsis cardiogenic is a hyperdynamic sepsis or hypovolemic sepsis. That is a cold or warm sepsis. Then start the fluid resuscitation or inotropes. Cold sepsis, simple, maintain the map. Warm sepsis, go for inotropes. Very simple.
Thank you, sir. Yeah. I request Dr. Tulsiram and Dr. Venkat Sivakrishna to hand over the memento to faculty Dr. Shankar. I now request Dr. Hari Krishna to give the memento to Mr. Srikanth.
Request Dr. Varuna also to be a part of that.
I request all the chairpersons to be on stage, and I request Dr. Alok Samantha Ray to give the mementos to all the chairpersons. Please, sir. Dr. Samantha Ray, Alok Samantha Ray is head of department in anesthesia. Moving on to the next session. So I would like to request the next chairpersons for the next session. It is Mr. Vijay Kumar, MD Microbiology, SVMC Medical College, Tirupati. Dr. C.S. Praveen, MD Pathology, Consultant Pathologist and Head of the Department of Pathology, Amara Hospital. Dr. Sivakrishna Reddy, MBBS, DEM, MRCM, UK, Senior Consultant and Head of Department Emergency Medicine. Dr. S. Prakash Babu, MBBS, MD Emergency Medicine and SWIMS Tirupati. I request Dr. Prakash to introduce the first faculty.
The first faculty for this session is Dr. Prashanna Lasmi Kakarla, MBBS DNB DIPC, Assistant Professor, SV Medical College, Tirupati, Andhra Pradesh. Our achievements are President NB Gold Medal for DNB, BS Lakshmi Memorial Prize for Best Junior Faculty Paper. She has published 12 publications, Reviewer for Microcon 2023, and International Pathogen Research. Areas of interest HICC, AMR, Virology and Infectious Diseases. Welcome, ma'am.
Good morning, one and all, respected dignitaries on and off the dais. Today, I would like to discuss about advancing sepsis diagnosis, cutting-edge techniques, and mastering culture sensitivity interpretation. This will be my presentation outline. As already discussed, sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. It is the major cause of preventable morbidity and mortality according to WHO. And it presents as a clinical deterioration of common presenting symptoms in the community. Early detection and timely management are crucial. Whenever there is an infection in the body, the clearance of pathogens establishes immune homeostasis. However, when this is not achieved, there is an inflammatory cytokine storm and the pathogen gains access to the bloodstream. Then there is immune dysregulation, which is sepsis. In sepsis, there is an interplay of pro and anti-inflammatory mechanisms. And these further depend on pathogen factors like the species of the organism, load and virulence of the pathogen that is infecting the patient, as well as the host factors like age, comorbidities, genetics, and medications he is already on. So this was already discussed. There is a golden hour for starting empiric antibiotic therapy. However, empiric antibiotic therapy is not optimal. According to CDC, recently up to 50% of antibiotics used in acute care hospitals are unnecessary or inappropriate. There is a need for escalation or de-escalation based on proper culture sensitivity report as soon as possible. Bloodstream infections are of various types. It can be due to contamination, transient bacteremia or fungemia, and per se, bloodstream infections can be community acquired or hospital acquired. However, any of these can progress to sepsis. When we are talking about sepsis syndrome, what are we dealing with? We are dealing with bacterial infections, fungal infections, viral infections, parasitic infections, all together along with antimicrobial resistance. So these are the common causative agents of sepsis. As was discussed in the previous session, surviving sepsis 1 hour bundle highlights the obtaining of blood cultures prior to administration of antibiotics. And what are the challenges as a clinician? We say early recognition of sepsis is crucial, every second counts, but the signs and symptoms in the early stages are non-specific. It is difficult to identify. Also, Any delay in initiating empiric antibiotic therapy increases mortality. However, overuse of antibiotics leads to antibiotic resistance. So we need to strike a balance between these, for which we need fast diagnostic tools to rapidly document infection and adapt the treatment. There comes sepsis diagnosis. It is basically based on identifying the causative pathogen, assessing a patient's inflammatory response, and monitoring organ dysfunction. This can be done by clinical evaluation, laboratory diagnosis, and imaging studies. I would confine myself to the laboratory diagnosis of sepsis. For any infection, even today the gold standard is culture. However, in sepsis, 50% of cultures are negative. This can be because progression of sepsis probably does not require a live bacterium which actually triggered the immune response, or this was caused by a non-cultivable bacteria, fungus, or a virus. These may be the major causes for culture negativity in case of sepsis. Sepsis diagnostics are broadly categorized like this. We have standard methods, conventional and automated blood cultures. Then we have genotypic methods like MALDI-TOF, PCR, microarrays genome sequencing, and we have biomarkers. Importance of blood culture. Blood culture is still considered the gold standard for diagnosing septicemia. The standard workflow of a blood culture today is like this. On day 1, you suspect a bloodstream infection, obtain blood cultures, start the patient on empiric antibiotic therapy. On day 2, ideally you should be getting the gram stain report and adjust the treatment according to the report. Day 2 or 3, you are supposed to get the culture. With probable organism identification, you can confirm or modify the treatment. And finally, by day 3 or 4, you have the pathogen ID with antibiotic susceptibility. AST is available and confirm the treatment. However, this 3 to 4 day gap for getting a final AST report is problematic. This is where new age advanced techniques come into play. There is a syndromic diagnostic approach. By syndromic diagnostic approach, I mean the ability to test for a variety of pathogens in a single test. We have one patient sample, one comprehensive test, and results are available within an hour, and this may improve the patient management. And this is useful to detect unsuspected pathogens, underdiagnosed pathogens, to detect co-infections, and to detect resistance patterns. So when we compare conventional and syndromic testing gives you results within 1 day. You can get the predicted antibiotic susceptibility testing within a day. So under this we have the BioFire film array system, which is a multiplex PCR. It is an integrated system wherein you have a single pouch which has cell lysis, DNA extraction, then you have the first PCR, second stage PCR, and the melt curve analysis, everything done in the single pouch, and finally we get the melt curves. And the targets, because they are tested in duplicate or triplicate, the sensitivity and specificity of the test is high. So we have this BioFire blood culture ID panel, which can target 43 organisms. These are the list of organisms which can be detected, and the results are available within hours. And if you see, we also have resistance markers for major multi-drug resistant organisms. Another technique which was recently recommended by CLSI is the disc diffusion directly from a positive blood culture broth. This can be done where automated techniques are not available. This can be done for Enterobacteriaceae, Pseudomonas, and Acinetobacter species. The plate should be incubated for 16 to 18 hours after doing the routine antibiotic susceptibility testing. Only interpretive category is reported, zone sizes are not given, and separate breakpoints are available for reporting these results. This has high sensitivity and specificity. Again, this brings down 24 hours of getting the final AST report. Then we have direct and rapid AST, which is an MIC-based phenotypic antimicrobial susceptibility testing from positive blood culture samples. Here, we have a 96-well plate with dried antibiotics at various concentrations. We have CLSI or UCAS-based gram-positive and gram-negative panels which can be used. Time taken for result is around 4 hours. Then we have the next-gen sequencing. Next-gen sequencing, when combined with bioinformatics, we get the results very fast. Here, cell-free plasma DNA or RNA is used. Extraction step is omitted. Anaerobes, slow growers, viruses, everything can be identified with this technique. The data generated, however, still requires clinical judgment and supporting laboratory tests. But this is impeded by high cost and requires strict aseptic working conditions. So this is the workflow for next-gen sequencing. As you see, human reads are removed, which cuts down a huge amount of time. Then we have the future, which is microfluidics. It is the lab on chip. It is a chip-based detection of microorganism and AST. Microorganisms can be identified from positive blood cultures in a span of 10 minutes. However, AST requires around 3 hours. Now, we move on to the next topic, that is antimicrobial susceptibility testing. Here, these are the standards or guidelines given by Clinical and Laboratory Standards Institute, CLSI or UCAST. According to them, MIC is defined as the lowest concentration of an antibiotic that inhibits visible growth of a microorganism, and breakpoints are discriminating concentrations which classify isolates as susceptible, intermediate or resistant. We have various testing methods for AST, starting with broth dilution, which is the gold standard. We have agar dilution, disc diffusion, e-test and broth microdilution. So these are the definitions for susceptible, intermediate and resistant isolates. One term we should see here is the susceptible dose dependent, which implies the susceptibility of an isolate depends on the dosage regimen. You increase the duration, you increase the strength of the dose, the organism may be susceptible to that particular antibiotic. Then how do I select the best antibiotic? If we are performing disc diffusion, it is a qualitative method. It indicates whether an antibiotic is likely to be effective, but does not tell you the exact concentration of the drug that is required for treatment. And antibiotic with largest zone of inhibition is not necessarily the best choice, because breakpoints differ for different antibiotics. Here in the example given, piperacillin-tazobactam has a breakpoint of susceptibility at 25 millimeters, whereas for gentamicin it is 18 millimeters. Hence, always consider factors like pharmacokinetics, dynamics, patient condition, site and severity of infection, along with the cost of antibiotic while choosing an antibiotic. Then, what is the use of MIC? MIC is required in these scenarios, wherein antibiotics with high toxicity, for example, beta-lactams, aminoglycosides, vancomycin, etc., when multi-drug resistant or resistant microbial species are suspected, in some clinical situations where there is severe life-threatening infections, in special patient characteristics like ICU patients, renal insufficiency, obesity, elderly patients and cystic fibrosis patients, and in specific infection sites like meningitis, endocarditis and prostatitis. So we have the Vitek, which is an automated system which is everywhere available these days, and you also should have a Vitek MIC detection range guide along with your Vitek susceptibility report. This says the detectable MIC range lower than the susceptible breakpoint. For example, amikacin has a susceptible breakpoint at less than 16. However, Vitek can detect the MIC ranges of 1, 2 and 4 for amikacin. Similarly, for gentamicin, we have the susceptibility breakpoint is at less than 4 and Vitek can detect range of 1 and 2. To give you an example, this is a Vitek test report. It says amikacin MIC is 4, it is susceptible. Gentamicin MIC is also 4, it is also susceptible. How do I choose an antibiotic? Here, as I said earlier, amikacin has a susceptible breakpoint at 16. So if we see, there is a 2 dilution lower MIC for this isolate, whereas for gentamicin it is 4, that is the susceptible breakpoint. Here in this scenario, without any patient conditions given, it is better to choose amikacin. There is another entity called breakpoint to MIC quotient, which is given by susceptible breakpoint MIC for an antibiotic divided by MIC which obtained in automated system. This is also called as therapeutic efficacy report. An ideal value would be more than 4. However, when to overrule this concept? Whenever a drug of choice has low BMQ, for example, vancomycin versus teicoplanin for MRSA. Whenever we are planning synergistic therapies, we may overrule this concept. When planning PK-PD based dosing, when there is no choice, when we get reports where all the isolates are either intermediate or resistant, we choose piperacillin plus tazobactam and amikacin, even though the BMQ is lower. Poor benefit to risk ratio with a drug with higher BMQ, for example, renal toxic drug in a patient with low creatinine clearance, and sites where antibiotic is not concentrated. So, we said MIC is the gold standard, but still it has its own limitations. It is the time we need to obtain the AST result. We said it takes 3 to 4 days. And automated AST systems can give you faster results. However, the MIC given is not always an exact value. It always says less than this, more than this. It's not an exact value. And also there is an inoculum effect which should be considered. This means all the AST testing we do is at a standardized inoculum. We do not know whether the patient is harboring the agent at that inoculum. If the inoculum load of the organism is higher in the patient, that may still lead to treatment failure even when the report says the drug is susceptible. So these are the few limitations of MIC. And few points regarding antimicrobial resistance. When we talk about beta-lactam antibiotic resistance, we all know there is an Ambler classification system which classifies beta-lactamases into serine beta-lactamases and metallo-beta-lactamases. We have penicillinases, ESBLs, and carbapenemases. So, interpretive criteria for zone disk diffusion testing. When you have a third generation cephalosporin with a cephalosporin and clavulanic acid combination, this can indicate ESBL production. Cefoxitin resistance is a marker for AMC production. Cefepime resistance is a marker for co-production of ESBL and AMC. And resistance to all the beta-lactams and carbapenems tested indicates a pure metallo-beta-lactamase producer. These are few points which should be noted when reading antibiotic sensitivity reports, especially the disk diffusion method. However, when we have Vitek, it gives you an advanced expert system report, wherein you get all this ready-made. For example, if you see this, there is a beta-lactam resistance and the detected phenotypes are, it is probably because of impermeability to carbapenems as well as the production of carbapenemase enzyme. There is such report available with the Vitek, you can request for that. Pseudomonas aeruginosa interpretive criteria. Carbapenem resistance is a problem we are facing currently with Pseudomonas. And here, carbapenem resistance is usually not due to carbapenemase production, it's because of efflux and impermeability. There are different clinical scenarios as given in the table. If both imipenem and meropenem are susceptible, we say the strain to be wild type. Whereas, imipenem susceptibility with meropenem resistance indicates increased efflux pumps. Whereas, imipenem's resistance with meropenem susceptibility can be due to mutational loss of porins. However, if both the imipenem and meropenem are resistant, this can be a pure metallo-beta-lactamase producer, which is rare. So this is the guideline for carbapenem resistant organisms. We have carbapenem resistant Enterobacteriaceae together with carbapenem resistant non-fermenters, we call them CRO, that is carbapenem resistant organisms. This can be used as a treatment guide for ESBL plus AMC co-producing isolate. For a specific clinical scenario, we can use prolonged extended infusion of piperacillin tazobactam along with high dose amikacin or gentamicin. However, these patients may develop resistance during treatment in vivo with AMC inducers. Hence, be cautionate while using imipenem, amoxiclav or any clavulanic antibiotic combination. And never use tigecycline in gram-negative sepsis unless the primary site of bacterial seeding is skin and soft tissue infections. And never attempt monotherapy with colistin. CRE, if we have a phenotype like pan-XDR CRE, that is, it's resistant to all the carbapenems tested, and intermediate susceptibility to colistin and sensitivity to chloramphenicol, you can go ahead with an extended infusion of colistin with a high dose chloramphenicol. You can also try alternatives like Ceftazidime-avibactam and aztreonam. Finally, MRSA. All staphylococcus isolates are intrinsically resistant to aztreonam, ceftazidime, nalidixic acid, polymyxin B, and colistin. Cefoxitin or oxacillin resistance indicates methicillin resistance in Staphylococcus aureus. They do not respond to any beta-lactam inhibitor combinations or carbapenems. Vancomycin along with clindamycin will be the drug of choice. IV to oral switch can be done with linezolid after 2 weeks of parenteral therapy. Linezolid, tigecycline, rifampicin, however, are reserved drugs. Selective and cascade reporting is followed by microbiologists whenever we give antibiotic susceptibility reporting. Selective reporting, I mean a drug which can be used in a particular situation. For example, nitrofurantoin for urinary infections. That will be selectively reported for urinary isolates. Cascade reporting represents omitting the report of broad spectrum antibiotics when narrow spectrum antibiotics are susceptible. And a cascade reporting format should be formulated in-house in every hospital. Finally, a note on WHONet. This is a free software that was developed by the WHO for surveillance of AMR. Every laboratory can use this software. They can download and utilize it. And how will it benefit me, if you ask me? It gives you an understanding of local epidemiology of the isolates in your hospital. It can create and give you local antibiograms. It can tell you what is the antibiotic which you can use. It can guide your empirical antibiotic treatment decisions and also identify outbreaks in your hospital, as well as quality assurance problems in the healthcare setting can be identified. So with this, I would like to summarize the talk. Primary goals of any laboratory are accuracy and rapidity of test results. Time taken to initiate appropriate antibiotic therapy is an independent risk factor for mortality in bloodstream infections. Conventional microbiological culture methods, still considered gold standard, are time consuming. Hence, molecular methods are useful in emergency situations. However, laboratory validation is crucial even for molecular assays. MIC, which is the gold standard, has its own limitations. MICs of different agents for a particular organism are not directly comparable. Always a knowledge of pharmacokinetics and dynamics of particular antibiotic is essential before prescribing an antibiotic. Selective and cascade reporting encourage appropriate antimicrobial agents use. These are my references. Thank you for your valuable time, and thank you for giving me this opportunity to be a part of this elite group. Thank you.
Thank you so much, ma'am, Dr. Prasanna Garu, for her wonderful presentation. Now I request Dr. Vijay Kumar Garu to introduce our notable speaker.
Care in Amara Hospital, Tirupati. She got best paper and gold medal in East Zone Critical Care Conference, and her areas of interest are trauma care, hemodynamic monitoring, and infectious diseases. Thank you.
Good morning, everybody. Today I am going to present about mastering empirical antibiotic selection for optimal outcome. Empirical antibiotic therapy is used when antibiotics are given to a patient without prior information of the specific bacteria causing the infection, just keeping in mind the local epidemiology and the resistance patterns. Principles of antibiotic therapy. The following principles should be kept in mind before administering the empirical antibiotics. Antibiotics should be selected for maximal coverage initially. and over-aggressive therapy should be avoided to prevent the emergence of antibiotic resistance. Avoid using the same antibiotics persistently and select based on the probable organism involved in a particular outbreak. It is always good to follow antibiotic cycling, that is, by withdrawing an antibiotic for use for a certain period of time to prevent the emergence of resistance against the particular antibiotic. Questions to be asked before selecting antibiotic. Does the patient have fever? What is the cause of fever? It is infectious or non-infectious? And what is source of infection and organism responsible for the source? Is the antibiotic I choose is active against the organism? And following factors to be considered before selecting the antibiotic: patient-related, community or hospital-related, site of infection, as different sites harbor different organisms, organism-related, drug-related, and local antibiogram also should be considered before selecting the empirical antibiotic. Elaborating on each factor, in host factors, we should see is there any history of allergy, diabetes mellitus, any history of recent antibiotic use, previous hospitalizations in renal or liver disease, and the immune status of the patient. As we all know that neutropenic patients are prone for acute pyogenic infections and invasive mycosis. And patients with T-cell defect, they are more prone for chronic infections caused by atypical pathogens such as pneumocystitis pneumoniae, cryptococcal, and tubercular. And patients with a defect in humoral immunity, either it is acquired or congenital, usually infections are caused by encapsulated bacterial pathogens. For some types of lethal pyogenic infections, blunting the immune system is required, because sudden lysis of the organisms release highly inflammatory antigens into systemic circulation, which exaggerate the morbidity and mortality of the patient, such as in pneumocystitis pneumoniae, pneumococcal meningitis, and tubercular meningitis. Knowing different organisms causing infections in different sites is important before deciding the empirical antibiotics. Here we can see the different sites and different organisms causing infection at different sites. In central nervous system, we can see the Streptococcus pneumoniae, Haemophilus influenza. In urinary tract, we can see frequently seen organisms are E. coli, Protease. And in gastrointestinal, most common organisms are E. coli and Klebsiella. In drug factors, we should think about the spectrum, pharmacokinetics and pharmacodynamics. Does the antibiotic penetrate to the site of infection, pattern of resistance, toxicity, route, dose, contraindications, cautions, and interactions. This is the important chart which everyone should know. This chart shows the coverage of the antibiotics. We can see here in gram-positive coverage, vancomycin, linezolid, and daptomycin, they cover whole of the gram-positive including MRSA. Linezolid and daptomycin, they cover including vancomycin-resistant enterococci. Whereas in gram-negative organisms, including ESBL, is covered by carbamazepines, colistin, polymyxin, and aminoglycosides. Atypical organisms are covered by fluoroquinolones, tigecycline, doxycycline, and macrolides. How PK, pharmacokinetics and pharmacodynamics will help us in deciding the antibiotic selection. Lipid-soluble drugs, they have very good tissue penetration, which leads to high volume of distribution, and these drugs are helpful in soft tissue infections. And these drugs, they are secreted in bile, so that's why they are good in cholangitis, patients with cholangitis, and these drugs require liver dose adjustment. Examples are beta-lactam antibiotics, glycopeptides, aminoglycosides. Whereas water-soluble drugs, they have poor tissue penetration, they have high blood levels, so these drugs are useful in blood stream infections. These are secreted in urine, hence they are used in urinary tract infections, and these drugs require renal dose adjustment. Examples are fluoroquinolones, macrolides. The three important pharmacodynamic parameters to predict the efficacy of the drug. The ratio of maximum serum concentration to the MIC predicts the aminoglycoside efficacy. The ratio of area under curve by minimum inhibitory concentration predicts the fluoroquinolone and glycopeptide efficacy. The time above the MIC predicts the beta-lactam and macrolide efficacy. And in tissue penetration into the CNS is poor, so higher than the standard levels of antibiotics is required. Many drugs penetrate well into the kidneys with highest levels we can see is with aminoglycosides, fluoroquinolones, trimethoprim sulfamethoxyl and beta-lactams. Fluoroquinolones and trimethoprim sulfamethoxyl also have excellent prostatic penetration. Tissues with low oxygen tension and pH environment can inactivate the aminoglycosides. Daptomycin is not used in alveolar pneumonia as pulmonary surfactant inactivates it. Excellent diffusion into epithelial lining fluid is seen with clarithromycin, azithromycin, doxycycline and tizicycline. Fluoroquinolones and linezolid also have excellent bone penetration. Let's discuss the commonly encountered scenarios in our practice. Community-acquired pneumonia, the most common organisms seen in community-acquired pneumonia are Streptococcus pneumonia, Haemophilus influenzae and Moraxella catarrhalis. And the atypical organisms what we see is Mycoplasma, Chlamydia, Legionella. Viruses is SARS-CoV-2, influenza A and B. And criteria for ICU admission in these cases is there should be at least one major and two minor criteria. Any patient with septic shock requiring one vasopressor support for more than 4 hours and any patient with respiratory failure requiring ventilatory support with 2 of the minor criteria is admitted in the ICU. In ICU patients, we should screen for the risk factors of Pseudomonas. That is, the patient was on any chronic use of broad spectrum antibiotics, the patient has any structural lung disease as COPD or bronchiectasis, is the patient is on any corticosteroid therapy or immunosuppression. In these patients, we should start anti-pseudomonal beta-lactams like piperacillin-tazobactam, Cefepime, meropenem, imipenem, plus ciprofloxacin or levofloxacin. But we, in Indian scenario, due to the prevalence of MDR TB, we preserve fluoroquinolones. If the patient is having penicillin allergy, we should go for Astronome. And we should see for risk factors for MRSA, like patient had any recent influenza, neutropenia or hemodialysis. In these patients, we should add vancomycin or linezolid. If the patient has viral pneumonia, we should add oseltamivir is recommended. Ventilator-associated pneumonia, again it is early and late onset. Patients, if they are ventilated in less than 96 hours, if they are most commonly susceptible to drug-sensitive bacteria from patient's own oropharynx. The organisms involved are Streptococcus pneumoniae, Haemophilus influenza, MSSA and Enterobacter. Late onset is if the ventilated more than 96 hours, they are susceptible for MDR organisms from hospital environment. Organisms are Pseudomonas aeruginosa, Acinetobacter and Klebsiella. These are the MDR risk factors to be considered before administering antibiotic in the ventilator-associated pneumonia. If they are on IV antibiotic use in the last 90 days, if the patient is in septic shock, ARDS preceding the VAP, or more than 5 days of hospitalization prior to occurrence of VAP and acute renal replacement therapy prior to VAP. If the patient have risk factors of MDR organisms, yes, then we should see patient had any prior history of carbapenem resistant pathogen. If there is a prior history of carbapenem resistant pathogen, then we should directly start Ceftazidime-avibactam, meropenem verobactam plus vancomycin and linezolid. If there is no prior history of carbapenem resistant pathogen, then we can start meropenem or imipenem celastin plus vancomycin or linezolid. If there is no risk factors for MDR pathogens, then we should see for any history of colonization or exposure or isolation of resistant pathogen in the past. There is no colonization in the past, then we should go for piperacillin-tazobactam and Cefepime. In intra-abdominal infections, we most commonly see spontaneous bacterial peritonitis and secondary bacterial peritonitis. In spontaneous infections, usually are monobacterial, with the most common being E. coli and Klebsiella. Diagnosis is by ascitic fluid analysis where polymorphonuclear leukocytes, more than 250 cells, Patient with focal intra-abdominal inflammatory entities such as cholecystitis or diverticulosis should be treated for specific condition rather than SPP. Treatment for this community acquired spontaneous bacterial peritonitis is just the third generation cephalosporins, whereas nosocomial spontaneous bacterial peritonitis should be a broad coverage with the gram positive and negative. We can start with piperacillin-tazobactam. If we think that the patient is harboring MD or gram negative organisms, we should start meropenem. If there is any history of VRE in the past or evidence of GA colonization, we should start daptomycin. Secondary bacterial peritonitis is most commonly seen in patients with perforation, trauma and bowel necrosis. The organisms most commonly seen is E. coli, Bacteroides fragilis and Enterococci. In these patients, we'll start with third or fourth generation cephalosporins, metronidazole and amyloic acid. If there is a suspicion of Enterococci, we can start with ticoplanin or tigecycline. Complicated skin and soft tissue infections according to WSEES guidelines for management of skin and soft tissue infections. It is described as surgical site infections, non-necrotizing skin and soft tissue infections, necrotizing skin and soft tissue infections. As we go deeper into the skin layers, we can see more gram-negative and the anaerobic infections. Organisms we see commonly in diabetic patients in skin and soft tissue infections is Staphylococcus aureus, group B Streptococcus, anaerobes and gram-negative bacilli. In patients with liver cirrhosis, we commonly see with Klebsiella, E. coli and Campylobacter. Neutropenic patients, we can see Pseudomonas aeruginosa. Patient Clostridium perfringens and Clostridium septicum is the causes for the necrotizing fasciitis type 1. Group A Streptococcus and Staphylococcus aureus will cause necrotizing fasciitis type 2. Management of skin and soft tissue infections, it is a multimodal. Surgery plays the key role, followed by antibiotics. If the patient is in sepsis, we should initiate the broad spectrum antibiotic with ticoplanin or daptomycin and cefepime or meropenem. And if the patient is in shock, we should add clindamycin. If the patient is not in sepsis, then we should see, is there any signs of systemic toxicity? Like, is there any purulent wound discharge, or patient is a known MRSA colonization or coverage? If yes, then start targeting MRSA and beta hemolytic streptococci with vancomycin or daptomycin. If there is no signs of any systemic toxicity, then we can target only MSSA with oxacillin or cefazolin. In urosepsis, we see uncomplicated cystitis, complicated cystitis, pyelonephritis and urosepsis. The most common organism is E. coli. As the severity of the infection increases, we see the other organisms like Proteus, Klebsiella and Pseudomonas. UTI diagnosis is with dipstick test and urine culture. In urine culture, if it is more than 10 to the power of 5 of single urine pathogen, and in symptomatic patients, if it is more than 10 to the power of 2, shows bladder bacteriuria. Management of urinary tract infections, we should first see, are there any multi-drug resistant gram-negative infections? Factors are, if there is inpatient stay at a healthcare facility and use of a fluoroquinolone or trimethoprim sulfamethoxazole or a broad spectrum beta-lactam in the past, or travel to parts of the world with high rates of multi-drug resistant organism. If yes, then we should start piperacillin-tazobactam. If no, then we can start ceftriaxone. Treatment of complicated urinary tract infections, that is, patients is in severe sepsis or acute urinary tract obstruction, then we can start anti-pseudomonal or carbapenems, that imipenem or meropenem plus vancomycin. Bacterial meningitis, causes of the community acquired bacterial meningitis in adults are Streptococcus pneumoniae and Neisseria meningitis. More than 50 years of age or with cell-mediated immunity, we can see Listeria monocytogenes. In healthcare associated ventriculitis and meningitis, Staphylococci and gram-negative bacilli are the organisms we see. If in 20 to 50 years of age, common organisms, as we told, it is Neisseria meningitis and Streptococcus pneumoniae. The drugs of choice are third generation cephalosporins plus vancomycin. In more than 50 years of age, we'll see Legionella and aerobic gram-negative bacilli. Drug of choice is vancomycin plus ampicillin plus third generation cephalosporin. In post-neurosurgery cases, as we told, is Staphylococcus aureus or coagulase negative staphylococci. In this, we'll go for vancomycin plus Cefepime or vancomycin plus Ceftazidime. Conclusion, given the power of antibiotics to save lives, we being expert should know the judicious use of antimicrobial agents. As an expert, we should know when not to prescribe and when to de-escalate. In a nutshell, customize your empirical antibiotic based on the host factors, pharmacokinetics, dynamics of the drug, and the organism and the clinical situation we are dealing with, so as to prevent the unnecessary resistant patterns. References. Thank you.
Thank you so much, ma'am. Let's have a huge round of applause for both the speakers.
Because the detection rate is more, if number of sample is more, what is recommended for each patient, how many samples should send, because we have to send both aerobic and anaerobic and this thing, what is number of sample, recommended number of samples?
So ideal number of recommended samples is 2 sets, sir. 2 sets of samples are recommended. If possible, if you send more, it is good. As 4 sets can increase the diagnosis to up to 99%. However, it's not feasible, but the standard guideline says 2 sets should be sent, that too from different sites, each set from one site.
And in addition for that, 2 sets of sample, and each sample should be minimum of 10 ml. 10 ml of sample, 2 sets, which will come as, okay, 40 ml will be, need to be drawn from 2 different sites, which most of the time, preferably. Yeah, preferably before the administration of antibiotics. How about, does it change with any pediatric?
Yes, sir. Actually, there is a broth to blood ratio, sir, that should be followed. If it's a pediatric case, the broth volume will also be correspondingly reduced, and if it's a neonate, even 0.5 to 1 ml of blood can also be taken, but the broth should be proportionate.
Thank you so much, ma'am. Moving on, I request our chairpersons Dr. S. Prakash Babu Garu and Dr. Shivaramakrishna Garu to present a memento to our renowned speaker, Dr. Prasanna Garu, for her wonderful presentation. Let's have a huge round of applause, guys. Mementos, please. Dr. Prasanna Garu, Assistant Professor, Department of Microbiology, SV Med College, Tirupati. Thank you. Now I request our chairpersons, Dr. K. Vijay Kumar Garu, Dr. Praveen Garu, to present memento to our speaker, Dr. Radhika Garu, for today's informative presentation. I request all the chairpersons to stay back on the stage. An honor for me to call upon Dr. Pradeep. Dr. Pradeep Garu Birds to come on the stage and present a memento to our chairpersons in appreciation of their time, knowledge and valuable guidelines. Let's have a huge round of applause, please. Thank you so much to all the chairpersons and Dr. Pradeep sir. Without few more sessions to go. Good morning, Rama ma'am. Now I request all the chairpersons to come on the stage, starting with Dr. Anil Garu, consultant. Sorry, let's start with the inauguration before starting the third session.
Good afternoon, everyone. So, I would like to request Dr. Rama Devi. The dignitaries to the inaugural ceremony. May I request Dr. Rama Devi, Head of the Department Sleep Medicine and Managing Director, Amara Hospital, to kindly join us on the stage. Next, I invite Bhagyalakshmi, COO of Amara Hospital, to grace the stage. Please put your hands together for the man behind this event, Dr. Shankar Vallapu, Senior Consultant and Head of Critical Care, ISCCM Treasurer, Tirupati Chapter. Please welcome Dr. Madan Mohan Reddy, Managing Director, Madara Hospital, Founding Member, ISCCM Tirupati, and Pioneer of Critical Care in Tirupati. We are honored to welcome Dr. Lisa Sahu, DM Infectious Diseases, who has travelled all the way from Hyderabad to share the knowledge and grace the occasion despite her busy schedule. Thank you, madam. Please be seated. Ladies and gentlemen, good morning everyone. A warm greetings to each and every one of you. It is with great honor and deep sense of purpose that I welcome you all to Amara Hospital for the Combat Sepsis Conference 2025 in association with IISCM Tirupati, dedicated entirely to one of the most pressing challenges in global healthcare today, sepsis. I am Dr. Varun, Consultant Physician, Head of the Department General Medicine, and also the host for this event. On the behalf of the organizing committee, we extend our appreciation for your presence today. Every year, sepsis claims millions of lives worldwide. It doesn't discriminate by age, geography, or healthcare setting. Yet, for something so prevalent and often so preventable, it remains under-recognized, under-diagnosed, and under-reported. That is why conferences like this are not just important, but essential. This conference is not just about exchanging knowledge. It is about building a unified voice, a voice that can drive change in clinical practice, education, research, and policy. To our distinguished speakers, thank you for bringing your expertise. To our attendees, thank you for your commitment to improving outcomes. And to organizing committee, thank you for tireless work behind the scenes. Let us use this day not just to learn, but to connect, collaborate, and act, because behind every statistic is a patient, a family, a life. With that, I formally declare the Combat Sepsis Conference 2025. Let's begin together. Thank you. So now I request all the attendees to stand up for the prayer song.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि.
Thank you. Please be seated. Any event has to go through certain morals, and so we have to go first with lamp lighting ceremony. And I request all the ISCCM members to come upon the stage and start with lamp lighting. I request Tirupati chapter Aloka sir, Pradeep sir, Hari Krishna sir, Subbarao sir to please come on stage. I request Dr. Anand also to come, please be on stage. I request Dr. Arun Raja to come on stage. Thank you doctors. Thank you doctors. So now I would like to call upon Dr. Shankar, organizing chairman for Combat Sepsis Conference, to speak a few words.
A very good morning to the esteemed dignitaries on the dais, Dr. Ramadevi Governor Madam, our beloved Managing Director, Amara Hospital, Bhaglakshmi Garu, Dr. Madan Mohan Reddy, Dr. Lisa Sahu, and a warm welcome to our honored guests, delegates, faculties, and the other ladies and gentlemen. It's my pleasure welcoming you all to AHC Combat Sepsis Conference at our Amara Hospital, Tirupati. In today's conference, we have faculties, delegates from different parts of the state and also from Telangana, Tamil Nadu. We have registration from almost all states, including from Hyderabad. We have few guests. Our Department of Critical Care Medicine, with our management support, worked very hard to bring this conference to this stage. I am proud to say that we have a strong critical care department with advanced equipments and infrastructure, with 4 adult ICUs, pediatric ICU, neonatal ICU, with highly qualified intensivists. Each unit heading one specialized intensivist. Like we have medical specialist, neuro-intensivist, cardiac intensivist, and neonatal intensivist, delivering best possible care to the patients. At this point, I would like to say that we have proudly managed one patient with severe ARDS with H1N1 pneumonia with ECMO. She failed all the conventional management like prone ventilation, all advanced settings on the ventilation. So she was put on VV ECMO for 30 days. We faced a lot of difficulties in between managing patient. She had a lot of complications. We overcome with all of them, successfully discharged the patient. Now she is in good health. So she is very happy. She says that Amara saved my life. She has kept our photos in her house. So our main motto is to provide all possible services in the city. They don't want any patient to go to other cities. They say that if our management, if doctors request we need this service, they immediately provide. They don't look at the cost for the equipment, for the anything, infrastructure. So we have very beautiful infrastructure, very good management supporting us for all the things, whatever we need for the patient care. So why we chosen sepsis is already discussed before. So sepsis is one of the leading cause of morbidity and mortality in the current scenario. So with our distinguished faculties and delegates, so we learn more about sepsis and improve the patient outcomes in our ICUs. I thank Amara management for giving this opportunity. Thank you very much.
Thank you, Dr. Shankar. So now I request our COO, Bhagyalakshmi Garu, to have a few words.
Good morning, everyone. A warm welcome again to all distinguished faculty, experts from various institutes, hospitals, and our esteemed delegates, definitely our valued Amara family. Thank you very much for being present here, and it's my privilege to share the dais and thanking once again to the Amara management as well as with Dr. Shankar. So usually patients do say that, often they say it is a bad hospital, that is a good hospital. From their perspective, how did they arrive, or how they say which is good or which is bad? Let us look at the research. The research published from ICMR mentions that 86% of the patients considers hospital experience as a key factor to choose their healthcare provider. And 72% of Indian patients do refer Google reviews before coming to the hospital. And 60% of the patients, either from rural or from urban, still depends on word of mouth. And every dissatisfied patient shares their negative experience at least with 15 people and above, whereas satisfied patient shares their positive experience with 10 patients or lesser. And 72% of the patients do not return to hospital even we have great clinical experts and we provide best clinical service if they encountered bad hospital service. And this is the data given by ICMR and FICCI, and it is published. It is a patient perspective. If we look at WHO perspective, how they define best or good hospital, the data, significant statistical data shows every 4th patient dies not because of disease, they die because of medical errors, unsafe environment, created in the hospital. And the worst part, 50% of them are preventable. And this is not for bad hospitals. The data established even the best hospitals in the, not just in the world, across the world, not specific region. But India, we have not reached to the state where we can publish our data, measure our outcomes. So, lot to go. And again, if we talk about our own perspective, healthcare providers, we refer often either US or NHS UK because of their cohesive clinical governance and clinical practice guidelines as a best practices or for best hospital to compare, to adopt the best practices. So, at the end, what is the contributing factors for all these things? A clinician always a good, definitely would have studied, competent, privileged, but clinician always strives to give the best care to the patient. But the outcomes do not depend on just on the clinician. We all know about that. It involves nurses, technicians, radiographer, radiologist, emergency medicine, and so on and so forth. At least 72 healthcare providers do involve, including maintenance, housekeeping, so on and so forth. 72 members do involve in providing the care from admission to discharge. And each of them would have come from different backgrounds, different cultural settings, different literacy levels, different understanding, and different emotional status. But all together, when they are providing care to the patient, and their habits definitely impact the patient experience as well as clinical outcomes. Thus, we at Amara Hospital aims, and their vision and mission focuses, our vision and mission focuses to benchmark Amara Hospital along with best of the centers in the world and creating a safer care within the hospital. And Amara Hospital currently functions with 200 beds and scaling up to another 100 beds within a month and 5 modular operating rooms with the best infection control practices, because how we measure our infection control practices is that our modular theaters built with HEPA filter, and it is not just built, we are measuring regularly with periodic manner. For 0.3 micron air quality testing is being done, and DOP testing is done, as well as we look for daily monitoring of temperature, humidity control, creating a safe infection control prevention inside the theater for our surgeons and patient. And well-built CSSD with ETO and plasma sterilizers. And if we look at our infrastructure, our Amara architecture and design and medical planning definitely contributes therapeutic process and patient healing, and as well as the technology added complementing the Amara Hospital for preventing errors like pneumatic chute system, where reduces the time to reach the sample from one station to another station. So lab processing time is reduced there. Not just lab samples, but also drugs are being transferred from one station, pharmacy to patient care areas within seconds. Thus, the dispensing delays, medication administration delays can be reduced and are being reduced. And as well, we are focusing mostly on continuous learning and development program, which is important, paramount in the hospital. Like every employee, be it clinician, be it nurse, be it other healthcare provider, will have regular number of hours that they need to complete within a year, so that the upskilling of their knowledge, upskilling of their competencies, so that standardization of the care processes we can bring in the system. As well, I would like to choose an example here, that the chairman himself, chairing the Mortality and Morbidity Committee, along with our Managing Director, Dr. Rama ma'am, and of course, all of you are aware, Dr. Shankar. 3 of them chairing the committee, screens every death, every morbidity, so that looking for opportunity and what are the learning points out of death and how to make this hospital safe for the patient. Is there advanced technologies? Is there advanced processes? Whichever, the clinical processes are built on a continual improvement way.
So professional bodies are, this acts as a professional building up body. Hence, I would like to summarize here, and sepsis is one of the program as a continual medical education within our learning and development. And thank you very much for all of your presence. And Dr. Shankar crafted so beautifully as a knowledge sharing platform. And thank you very much. With your presence, it is successful. And thank you.
Thank you, ma'am. Now I would like to invite Dr. Madan Mohan Reddy, ISCCM past president, Tirupati chapter, to have a few words with all the dignitaries.
Good morning. Good morning for all the dignitaries and guys and the delegates who are sitting in front of me. In 2005, when I came to Tirupati to start a hospital, there was no separate specialty like critical care medicine. The critically ill patients were admitted in SWIMS. That was the only place critically ill patients were getting admitted. And there was no separate specialty who were taking care of the critically ill patients. So then with the help of other colleagues, we slowly started a branch called critical care medicine in Tirupati with a limited facilities, and we were admitting not very ill or critically ill patients, so reasonably were recoverable patients into our ICUs. Slowly, I'm very happy, I have seen through my eyes how the critical care has progressed from those days till now, over 2 decades. Now it has become a big branch in Tirupati. So there are more than 40 critical care specialists who are working in Tirupati. Maybe more than that, but these are around 40 are the members of critical care society. There are many are practicing critical care medicine. They are not at the members of critical care society. We were actually in 2023, we started doing CMEs and alternate months for full day CMEs. So it was slowly progressing. Now with this CME in Amara Hospital, it has grown further and it has become bigger. We were targeting only students and physicians from the local community. Now with this program, so now we are seeing delegates coming from all over the state. I'm very happy that critical care medicine has grown a lot, and I have to congratulate Shankar for conducting such a wonderful program today. Thank you, Shankar. And the new executive committee of critical care medicine, I hope they take forward whatever we were doing before and make it much bigger and more useful to the patients as well as the physicians. Thank you very much.
Thank you, sir. I would like to request Dr. Mona Lisa Sahu, infectious disease specialist from Hyderabad, to have few words.
Good morning, everyone. Dignitaries on the dais and off the dais. I am very pleased to be here, and I thank Dr. Shankar for giving me an opportunity to be a part of this CME. He has chosen a very apt topic like the sepsis, how to combat it, because sepsis is the one which is claiming the most number of lives, and it is predicted by 2050 that it will be the most common cause of mortality, surpassing all the other causes. So it is the right time where we should intervene and combat the sepsis so that it does not claim further lives. And with the limited armamentarium of drugs and the facilities that we have, we should be doing our best to combat the sepsis. So not consuming much of your time, the CME is going to be very informative to all of you, and I am sure that you will gain a lot of knowledge. Again, congratulations to Dr. Shankar for doing such a wonderful CME. Thank you.
Thank you, madam. Now I would request Dr. Ramadevi Gaurineni, Managing Director of Amara Hospital, to have few words.
Thank you, Varun. First of all, I'm very happy to see the vibrancy in this room. An atrium usually filled with patients. Now seeing so many distinguished doctors, including our guest, Dr. Madan Mohan Garu, Mona Lisa Garu. And on this very important topic, sepsis. Amara Hospital was inaugurated about 4 years back, and but about 5 years back, 2021, the first wave of COVID is when we opened fully. It was unexpected. We didn't. I didn't think COVID was going to start, and in India, because everybody was saying in warm weather COVID wouldn't come. When it started, one person came, and we thought we'd give it a try and take care of that one patient, and then we offered to take care of 5 patients, then 10 patients. By the time the second wave came and the borders closed, we were taking care, in total, almost 1,000 patients we took care of. This whole atrium was converted into cubicles, which we read about how they converted a warehouse into ICUs in China. Multiple people around the world helped us to get proper oxygen supply, and it was a real community effort. Dr. Madan Mohan Garu came and offered his services then. But I think we all understood the importance of having critical care and community working together, and especially in our hometown in Tirupati. When we came back, we weren't sure if we could make it work, but I think COVID, the patients, the doctors, the community gave us the confidence that we required to know that we had to push forward with our mission. Our mission, we're in the process of writing and rewriting our vision, but the vision contains patient well-being, community engagement, culture of quality, inclusiveness, and continuous support, not only for the community, but also for the doctors that work here and the patients who come and trust in us. Both my husband and I, Dr. Prasad Gaudaneni, we're from the academic background. When we first went to US, it was a time when it was very difficult for doctors to get into any specialty, but we gave education a very high priority. Actually, the only 2 doctors in our immediate family. Most of, especially in Namaraja side, we're into batteries, we're into food, many other things. So the idea of starting a hospital is uniquely ours. We're just going to have a small orthopedic hospital, but my father, Galla Ramchandra Naidu Garu, having lived here for almost 30 years, saw every time we needed something, a lot of times, even though there's very good doctors, very good facilities, and things were there, we invested in the manpower to have 24-hour coverage. Actually, Dr. Radhika was alone when the first case of COVID came in. She managed it completely on her own. But since then, we've built up a very efficient staff. And like I said, Dr. Madan Mohan Reddy Garu and all have contributed to us along the way. In addition, education was also always a priority for us. Dr. Prasad, when he was training, there was a place called the Learning Center in Chicago, where they used to teach new procedures using cadavers and simulation. And the affordability was very difficult. So he used to work there part-time on weekends. He used to push the cadavers and help transport things so he could enter the courses for free during that time. And finally, now he's a teacher in the institution, and he's always wanted to come back and create a center for learning and re-learning, because things change so fast, and it's important to be a continuous learner. So I'm really glad that Dr. Shankar, as part of that mission, has created this, and going forward, I pledge our support in such activities. But in addition, we don't need such big activities all of the time. It's really important to have smaller gatherings. In Chicago, there were 5 major academic institutions. We never saw each other as competition. Neurologists had their own group, the sleep specialists had their own group. We used to discuss cases, we used to get together, sometimes just in a small conference room, I attended during my neuropathology rotation, I went and met the neuropathologist. Usually it was just some pizza and Coke, but we used to discuss the latest advances, cases that we saw we thought were difficult, and help each other. Anytime I couldn't figure things out, I will be calling people around the city as well as around the country to discuss things. Because, you know, a lot of things are present in the textbook, but at the same time, the cases you need mentoring from not only from your teachers, but from your peers, and sometimes even your juniors, to be a lifelong learner. And it would be very nice to inculcate more of that, more of that. And like I said, it can be in a small room. It doesn't have to be fancy food, and nothing else needs to be there. But that continuous learning is important. And finally, the first case of sepsis I saw when I was an intern, I was shocked because when an older person, especially if they're immunocompromised, when they come in, they don't have the same symptoms as a younger person would. It can be early sepsis, it can be MI, it can be PE, almost anything. But seeing that rapid deterioration really opened my eyes to understand that sepsis and infection are very different. And now, with the recent advances, there's early markers of sepsis. There's a way to diagnose the organism and the antibiotic sensitivity faster. I used to have these elaborate notes similar to what Dr. Radhika said about the most probable organisms and which antibiotics to start under different circumstances. Sometimes some culture, even though the gram stains would come back fast, for the cultures to return, some things used to take almost a week or longer in some cases, like fungi. So in the meantime, everyday monitoring and discussing whether to continue the same antibiotic, whether to change a different antibiotic, and if we were doing the right thing, it was a very, it could be very taxing. But now it's nice that along with the guidelines, there are more rapid methods of diagnosis. And but still, India is #1 when it comes to antibiotic resistance. I'm not sure if that's something to be proud of, but it's definitely a lot of room for improvement. And for us to think that starting with the strongest medication is not always the right decision. Keeping in mind Dr. Radhika's talk and really thinking through which antibiotics is best to start, how to escalate, how to de-escalate, and what are the most appropriate methods of learning and management. The other thing is you don't need to go around with notebooks and run to the library like I did when I was younger. Now online, so much information is available if you go to the proper resources. You know, everything Radhika said, I don't remember all of it. I'll probably ask her or go online to learn about it if the situation comes. I remember what I need to remember as a sleep doctor for daily work, but the information is there, so even if you don't remember, talk to the experts and go online and learn. Learn and relearn and refresh yourself on exactly what needs to be done under each circumstance. Again, thank you all for coming and visiting our institution and taking part in this conference. Thank you.
Thank you, ma'am. Then, ma'am, I request you to give moment of appreciation to Dr. Shankar and Dr. Madan, and I would also like to request Dr. Aladi Mohan garu to brace the stage and give token of appreciation for the dignitaries. I request Dr. Rama Madam to give moment of appreciation to Dr. Aladi Mohan garu. I also request all the critical care team to please come on the stage of Amara Hospital for a photograph with the dignitaries. So this is the whole unit of our Amara emergency critical care team. So we have good ample number of doctors of around 10 people, rounding 24/7, 365 days. Thank you. Thank you, doctors. So moving on to the next session. So, a small request from the organizing team. So try to keep your presentations restricted to 20 minutes and not more than that. And I would also, due to lack of time, most of the questions will be addressed during the lunch or at the time of network.
Hello everybody. Let's start the third session. I request our honorable chairpersons to come over the stage, starting with Dr. Anil Babu garu, Consultant Neuro Anesthesia and Critical Care Medicine, Amara Hospitals. Let's have a huge round of applause for Dr. Anil garu. Dr. Manolasya garu, Associate Prof, Department of Medicine, SWIMS, Tirupati. Dr. Radha J. garu, Professor, Department of Anesthesia, Rio Hospitals. Dr. K. N. Bhargav garu, Assistant Professor, Department of Medicine, SWIMS. Dr. V. S. Sabarish garu, Consultant, Department of Medicine, Sahasra Hospital, Tirupati. So thank you everyone.
I request Dr. Suryasetti Srinivas garu, served as ISA State Reserve Secretary, to grace the occasion.
Now I request Dr. Anil garu to introduce our esteemed speaker, Dr. Lisa Sahu, Consultant, Department of Infectious Diseases, Yashoda Hospitals, Hyderabad.
Good morning to all. So I would like to invite Dr. Lisa Sahu, and who is currently she is working as a senior consultant and HOD in the Department of ID from Yashoda Hospitals, Hyderabad. Yeah. She has done her MD and DM in AIMS, New Delhi. So we are privileged to welcome her.
Please put your hands together for Dr. Lisa Sahu garu.
Good morning, everyone. I thank Amara Hospitals and Tirupati for the warm welcome. The topic allotted to me for the day is like confronting the superbugs that we encounter, tackling the multi-drug resistant bugs with the gram-negative ones with the next-gen antibiotics. And we shall be dealing with the topic under the following headings. So why is it that we need newer antimicrobials? We have many with us, but there are certain lacunae with the existing ones that we need to go ahead with the newer antimicrobials. The most important reason being the antimicrobial resistance that has been upcoming in a very rampant way. The pathogens also have become very intelligent, like there are newer pathogens coming and the existing ones are developing the resistance mechanisms much faster than we are developing the drugs. The safety profile of the existing drugs is questionable, and we need more safer drugs with lesser adverse effects. The convenience and the compliance of the patients is also very important, and the current drugs also have a huge economic burden on the patients. So newer antimicrobials are the need of the hour. The antimicrobial resistance is the most important cause for the development of newer antibiotics. So regarding the definition, there are like three categories which we come across: the MDR bugs, the multi-drug resistant ones, the XDR, the extensively drug resistant ones, and the pan-drug resistant ones. So as you can see in the pie chart, about 40% of the isolates that we come across are the multi-drug resistant ones. That is, they are not susceptible to more than one agent in three antimicrobial categories. And the XDR ones are the component of the MDR, subset of that, where it is not susceptible to more than one agent in at least all except two categories. So we are left with very few options, and then comes the pan-drug resistant one, which is resistant to almost all of the available antibiotics. So this is very concerning, like we are growing ahead towards the pan-drug resistant bacteria which we come across occasionally. And as you can see in the antibiotic pipeline, when the penicillin came up in 1928 by Alexander Fleming, we have developed many antibiotics over till 1980. But as you can see, from the 1990 to the 2010, there was a huge gap in the development of antibiotics. There were not many antibiotics which were developed. Maybe the manufacturers thought that it was not a very beneficial thing, and but later on, when the XDR bugs and all have hiked up in all over the continents in the world, the newer antibiotics have come in the pipeline. The antimicrobial resistance is one of the top 10 global public threats, health threats, and about 7 lakh deaths are estimated annually due to the antimicrobial resistance. And by the year 2050, it is estimated that about 10 million deaths would occur per year due to this. This is a very huge number and very alarming. The mortality rate per 1 lakh deaths, AMR, is about, in 2021 in India it is about 18 to 21 per lakh, and it is estimated that about by 2050 it would be about more than 30. India would come into the highest zone. So it is high time to be concerned about it. So regarding the methods of tackling the antimicrobial resistance, there are many ways we can go ahead with it, like restricting the rampant use and unauthorized use in the humans, having good antimicrobial infective control measures, public awareness, increasing the surveillance, restricting the use of antibiotic in the animals, and development of the new agents. So we shall be dealing about the topic, the development of the new agents in the current era. The WHO has come up with a priority pathogen list, and the critical group includes the gram-negative ones, the Acinetobacter, the enterobacterials, which includes the E. coli and the Klebsiella and the Pseudomonas. They are the 4 most important pathogens. They are included in the critical group. Most of them are extracellular and or facultatively intracellular. And the Indian priority pathogen includes the gram-negative ones, the Klebsiella, E. coli, Acinetobacter, and Pseudomonas. Unlike the West, where it is the gram-positive ones which are of more concern. Even the gram-positive are increasing in our scenario, but not as much as the gram-negative ones. The carbapenem resistance is also very high currently, accounting to about 40% across the country, and the most important resistance mechanisms being the carbapenemases, the OXA and the NDM genes. This is the global distribution of the carbapenemases, and as you can see in the India, it is endemic for the metallo-beta-lactamase, the NDM, and the other IMP, KPC, OXA and VIM are sporadic. As you can see, in India, the NDM is very endemic. The NDM is also endemic in the other neighboring countries, Pakistan, China, and Bangladesh. There are several mechanisms of resistance which includes the carbophenamases as well as the non-carbophenamase mechanisms which includes the efflux pumps and the porine channels and the other mechanisms. This is a meta-analysis and the systematic review which was published in the BMJ Open, which impacted upon the impact of carbapenem resistance in the mortality, and it was shown that there is a significant increase in the mortality in the carbapenem resistant isolate from the patients as compared to the carbapenem sensitive ones. So coming to the newer options that we have in the pipeline, and some of them are also available with us, we have been using the BLIs, which includes the Ceftazidime-avibactam, the Meropenem-Veborbactam, the upcoming Astronam-avibactam, Cefepime-zidebactam, Imipenem-Relibactam, and the other ones of the other groups, the Cefiderocol, the Sidor-4 antibiotic, the Plazomycin, and the Eravacycline. We shall be dealing with them in a little bit detail. Coming to the real case scenarios that we come across in the day-to-day, a 50-year-old female known case of CLD with decompensation was intubated in view of low GCS. On day 4 in the hospital, she developed fever, increased TLCs, rising oxygen demands, and the X-ray shows a right basal patch. So this is a case of VAP. We come across such cases very often, and on the day 4 of hospitalization, so it is a case of VAP. And what would you do next? Like hike it to a peptase or a meropenem or polymyxin, or like ask about the antibiogram, or a newer BLI would you choose? What would be your approach? We shall be seeing. Another case scenario, a patient with a 48-year-old female with type 2 diabetes and hypertension and recurrent CVA, presenting to the emergency with high-grade fever with chills and burning micturition, altered mental status in 2 days. Investigation shows neutrophilic leukocytosis and AKI, and the urine routine microscopy shows field full of pus cells. The blood and urine cultures were sent, which show carbapenem resistant organisms, and the biofire of the blood shows NDM and OXA48. This scenario is also not uncommon. So in this case, what would you go ahead with? Like you would, regarding the newer antibiotics available, would you go ahead with a Cefiderocol or a Cefepime-10-avibactam or a Cefepime-zidebactam or a Cefepime-N-metazobactam? Like all these are newer drugs, and like by the end of the talk, we shall be having a clearer idea which one would we go for. So regarding the treatment of the carbapenem resistant organisms, that is the most common mechanism in our setup being the OXA48 and NDM, the KPCs are lesser as compared to the West. So for the CRE cystitis, we may go ahead with the cystitis, go ahead with a simple nitrofurantoin or a cotrimoxazole or a quinolone if sensitive, and a single dose of aminoglycoside or colistin, Ceftazidime-avibactam may suffice. But if it is a carbapenem resistant organism outside the urinary tract, we need to go for the higher drugs, like the Ceftazidime-avibactam if it is a KPC or OXA, and along with if NDM is present, we should be adding Astronam, TG-cycline not for the bloodstream infections or not for the UTIs, and the other drugs are not there. Polymyxins are not much preferred for the carbapenem resistant organisms, enterobacterials. Some of you may be thinking the oral carbapenem to be ferropenem, but it is a very big no-no. So we should be going home with the message that it is not at all a oral carbapenem, and it is like a misnomer, and it should not be used. It is of no use. Other oral medication that we have for the UTI is the tebipenem. It is the dosage is 600 milligram TID, but it is not available with us. Coming to the Ceftazidime-avibactam, that is the talk of the day, and we have many CMEs being conducted to not go for the inappropriate usage of the drug and help it keep safe. So it is the Ceftazidime-avibactam is a third generation cephalosporin along with avibactam, which is a non-beta-lactam. Beta-lactam is inhibitor. It gets reactivated, and it is not like the other sulbactam which would get decomposed. So the spectrum of activity is also very large. It includes the ESBLs, AMCs, KPCs, and the OXA48 producing enterobacterials. But the Pseudomonas have also other mechanisms like the efflux pumps and the porins. So it may not be very effective in the case of Pseudomonas, but it also does not cover the Acinetobacter or the Metallobeta-lactamases. So these should not be used on if the patient we are suspecting Acinetobacter, or if NDM is present, we can go along with Astronam. It has been approved for the various uses like complicated intra-abdominal infections, complicated UTI, VAP, and other BSI. Several trials have been conducted, like the pre-reclaim trial for intra-abdominal infections, the recapture trial for complicated UTI, reprise trial for the abdominal infections, and the reproof trial. All of them have shown that the drug is very effective and has a very minimal adverse effect profile, like a nausea or diarrhea in a few of the patients. The drug has also been compared to colistin, which has been the age-long therapy for the carbapenem-resistant ones, and it has been shown that the all-cause mortality in the Ceftazidime-avibactam group was significantly lower as compared to the colistin. It has also got its place in the guidelines, where it is suggested to be used for the complicated intra-abdominal infections by the Surgical Society of Infection Society guidelines. The hospital-acquired pneumonia, it is the first choice of antibiotic. Even the Spanish Society as well as the British Society suggest it as the first line of therapy for the carbapenem-resistant enterobacterials. But it does not work for the MBLs, which is one of the most common problem in our country. The IDSA guidelines also suggest if metallo-beta-lactamase like the NDM, WIM or IMP is present, we should be going ahead with ceftazidime-avibactam with aztreonam, or cefiderocol may be used. It is not much available in our country. And if it is only OXA48 which is identified on the expert carbar or the biofire, then we should be going ahead with ceftazidime-avibactam alone. This is our problem in India, the metallo-beta-lactamases. Coming to the ceftazidime-avibactam plus aztreonam. In most of our patients, in our setup, it is about 60 to 70% of the isolates have NDM along with OXA48. Getting alone OXA48 is very less number of cases. So addition of aztreonam helps inhibit the NDM and OXA48 like producers, and several studies that have been published in the Clinical Infectious Disease Journal and others have also shown that this combination works very well, and it should be administered simultaneously, both the drugs going simultaneously over a prolonged infusion of 3 hours, given every 8 hourly. The Pfizer is coming up with the molecule avibactam aztreonam in the month of July. The ceftazidime is not much helpful, as there is a resistance, and the molecule of interest in the combination is avibactam. So they are coming up with avibactam aztreonam, which has got activity against the MBL, and it is approved. The FDA approval has been obtained for complicated intra-abdominal infections, complicated UTI and VAP, and the dosing would be every 6th hourly. Coming to the other drug, the meropenem-vaborbactam, it has got a good spectrum of activity against the MDR ESBLs, including the E. coli, Klebsiella, Proteus, and the vaborbactam shows improved activity against the beta-lactamases. Coming to the other one, the ceftazidime-avibactam, it is a good spectrum against the Enterobacteriaceae escape organisms, but no activity against the NDM. It has also been approved for the intra-abdominal infections and complicated UTI. The cefiderocol molecule, which has been recently introduced in India, the mechanism of action is a little bit different for this. It acts like a siderophore, the Trojan horse phenomenon, by which it prevents the entry of the iron into the molecules, and the spectrum of activity is also very large. It includes the Pseudomonas, Burkholderia, Cepacia, Stenotrophomonas, Acinetobacter, as well as the CREs. But it does not cover the gram-positive or the anaerobes, similar to the ceftazidime-avibactam. Coming to the Cefepime-based BLI combinations, we have the Cefepime-tenibarbactam, Cefepime-zidebactam, and Cefepime-N-metazobactam. The Cefepime-zidebactam and Cefepime-N-metazobactam are available with us, and we have experience using them. The Cefepime-zidebactam has been the drug which is developed in India, and it is a game changer. It has got a very wide spectrum of activity. It inhibits OXA48 and NDM as well, and also for difficult to treat Pseudomonas, Klebsiella, as well as Acinetobacter, it has been very helpful. It is a newer beta-lactam enhancer, and pan-beta-lactam is stable. It acts on all the exflux pumps as well. So this is specific about its action as compared to the other BLIs. There have also been studies which have shown that the in vitro activity of the Cefepime-zidebactam as well as Cefepime-tenibarbactam against these enterobacterials has been very helpful from the isolates collected in India. As you can see, the MICs are very low for Cefepime-tenibarbactam as well as Cefepime-zidebactam. This is one of the case reports which was published in 2023 from one of my colleagues. about a patient of AML who had a severe Pseudomonas infection in the bloodstream as well as pneumonia, and he was given the drug Cefepime-zidebactam, which is available on a compassionate basis, and he improved very well. Coming to the other drug, the Cefepime-N-metazobactam, it is available with us. The CIPLA has launched it a couple of months ago, and it is been approved for the complicated urinary tract infections and also complicated like VAP. It is like a meropenem sparing agent, and it is helpful only for the ESBLs, but not against the class D or class C carbapenemases. So regarding this patient, like he has a carbapenem resistant organism, so Cefepime-N-metazobactam would not be helpful for us because it is a carbapenem sparing BRBRI. Cefiderocol also would, like if the patient has a NDM-oxa along with the PBP3 insertion, which is more commonly seen in the E. coli isolates. The Cefepime-Taniborbactam if the MICs are higher, and the Cefepime-zidebactam for the carbapenem resistant organisms. So in our case of complicated UTI with the patient, we can go ahead with using Cefepime-zidebactam. There is another drug in the, like which is going to be released in a couple of months. This is also by the CIPLA, the plazomicin, which has got in vitro activity against the ESBL's carbapenem resistance as well as the NDM, and some activity against the Pseudomonas and MRSA. The other drug which is going to be available with us, the eravacycline, it is currently being imported for specific cases. The spectrum of activity is also very large, including MDR Acinetobacter, ESBL E. coli, and MDR Klebsiella pneumoniae. It also covers the gram-positive organisms, the MRSA and the VRE. The guidelines, IDSA guidelines come up with the Acinetobacter. So for the Acinetobacter, we should be going ahead with the Sulbactam-Durlobactam combination, but this combination is not available with us. So we go ahead with high-dose Sulbactam along with the minocycline or TG-cycline combined with polymyxin B for the cases of Acinetobacter, XDR Acinetobacter. Regarding the study for this Sulbactam-Durlobactam in the Acinetobacter, XDR Acinetobacter group, the study, the ATTACK study was done, which is a phase 3 control study, and it showed that the Sulbactam-Durlobactam was non-inferior to the existing colistin-based combination therapies. A very good review article has been published by Dr. Rajiv Suman sir and the colleagues in the which is the expert review on anti-infective therapy. You can, the iconic study which you can go through, which highlights all the antibiotics that we have available with us for these carbapenem resistant organisms. Coming to a specific case where we had experience with the Cefepime-zidebactam, he was a 22-year-old male who had a road accident in 2022 December, and he had sustained severe brain injuries and multiple fractures. He underwent decompression craniectomy. During his course of stay in the hospital, he developed sepsis with XDR Klebsiella, which was isolated from the blood. Subsequently, he also developed osteomyelitis of the skull bone. He was given 6 weeks of Ceftazidime-avibactam with aztreonam. After 6 weeks around, it was stopped. But after doing well for 5 months, again he deteriorated with high-grade fevers, abdominal pain, and developed hydrocephalus. For the hydrocephalus, the VP shunt was repositioned. The ultrasound of the abdomen showed a subcapsular collection in the liver and internal echoes and a collection of about 64 cc with a massive right-sided pleural effusion. The subcapsular collection was aspirated, and again it was growing the XDR Klebsiella with NDM and oxa. The synergy was positive, so again we went ahead with Cas-IV with aztreonam for 8 weeks. Then he was afebrile for a couple of months, again presenting with severe fever and abdominal pain. And then again it was a smooth wall cyst, and this time it was a hydroerythronephrosis. The cystic fluid was aspirated and again grew the Klebsiella, for which he was given the only drug available with us, with aztreonam. And then we finally decided to go ahead with like always, there is an alternative. It is not that the end of the way. We went ahead, and since it was XDR Klebsiella and prolonged Cas-IV therapy with aztreonam was given in about a total of 24 weeks, we asked for the compassionate use of the drug Cefepime-zidebactam, and we sent ahead the isolate to the Wokhard, who is the manufacturer of the drug, and they said that it was sensitive, and they tested it in their labs, and the Cefepime-zidebactam was sensitive. And then he was started after the drug was obtained after the approval from the central drug authorities. And the patient was administered the drug from April for about 8 weeks along with aztreonam, as it was a like case of osteomyelitis, CNS infection and peritonitis. Prolonged therapy was planned for the patient, and the patient showed a remarkable improvement with the drug and is now doing very well at 1 year follow-up. So these drugs has now gone for the approval, and it may be like they might be launching it another 1 year. And this compassionate use of the drug has been tried about 30 patients all over the country. These are the antibiotics that we have in the pipeline. There are also newer strategies like the nanoparticles or the phage therapy, which are upcoming these days. We do not have much data about them, so I have not included them in my study, my talk. So the correct approach of the patient is very essential. We have many antibiotics in our pipeline, and a few are available with us. Making the right empiric choice, rational choice in the beginning, obtaining the cultures and keeping in mind the resistant patterns, de-escalation as soon as possible, as soon as we have a appropriate diagnosis, and infection prevention and control are the right approach in managing these patients with sepsis. We need to identify the risk factors, like keep in mind the antibiogram, the hospital, for our hospital where we are working, so that we have an idea of what resistant bugs we come across and choose the antibiotic appropriately. Initiate the right rational choice of antibiotics in the beginning. Have stringent infection prevention and control measures. And if available, an infectious disease specialist would also help you in making a right choice of the antibiotics. So, we know the antimicrobial resistance is a growing concern and is a medical emergency. Knowing your local epidemiology is like mandatory. You need to know, it's not an optional thing. The carbapenem resistance is on very high rise, about 40 to 50% in the country. The most common gene patterns being the NDM and the OXA48. Point of care testing has been highlighted in the previous talks and is the need of the hour, so that we cut down the time to detection and early initiation of appropriate measures is done. The newer drugs that we are using currently are the BLBLI, Ceftazidime-avibactam with aztreonam, and they are helpful. The newer antimicrobials are not the antidote, and sepsis control, source control is very essential, and we should treat the patients, not just the culture reports. It is otherwise, if we do not follow these measures, we would soon be arriving in the post-antibiotic era where we do not have any antibiotics in hand and we would be doomed. So this is the summary slide which shows what is the spectrum of activity of these newer antibiotics against these MDR bugs. Thank you.
Thank you so much, ma'am. It was very nice. Now I request Dr. K.N. Bhargav Garu to introduce our next speaker, Dr. Lalita Priya Garu.
Good morning, everyone. It is my pleasure to introduce Dr. Lalita Priya, who did her DNB pulmonology from KIMS Trivandrum, then her IDCCM from Ramchandra. She is working as a critical care consultant in the Department of Critical Care. I welcome Dr. Lalita Priya to the stage.
Let's put your hands together for Dr. Lalita Priya Garu.
Thank you, sir, for the introduction. Proper, that is non-infectious causes of fever in ICU. We'll go about, the talk will go about in this particular manner. So how do we define fever in ICU? IDSA defines fever in ICU as when 2 consecutive measurements are more than 105 degree Fahrenheit, and we may consider low threshold for fever in certain group of patients, that is an immunocompromised elderly and patients receiving NSAIDs or patients on ECMO or CRRT who are prone for hypothermia with a threshold of more than 100.4 degree Fahrenheit. And in neutropenic patients, a single oral temperature of more than 101 degree Fahrenheit or a temperature of 100.4 degree Fahrenheit which lasts for more than 1 hour is defined as fever. So what are the appropriate methods of measurement, temperature measurement? The most appropriate measurement would be by pulmonary arterial catheter, but it is invasive, so not possible in all the patients. So followed by rectal and oral temperature. So what is the significance of fever in critically ill patient is that a temperature more than 39.5 degrees centigrade has been showed that there is increased mortality associated with it. And also fever has been included in all the mortality, most of the mortality prediction scores. And what is the significance of learning non-infectious causes is that, as we discussed earlier in the earlier talks, there is an increased antibiotic abuse and antibiotic resistance. So having a knowledge of non-infectious causes, we can try and reduce this risk. So there are two terms which is fever and hypothermia, which are different from each other. So the different in terms of pathophysiological mechanisms and the causes related to it. So the fever is triggered by the fever is produced by cytokines which triggers the hypothalamus, but whereas and the thermostat level is set at a higher level, whereas in hypothermia, body temperature increases beyond the hypothalamus set temperature. So the typical temperature in fever is less than 105, whereas in hypothermia it is more than 105. So antipyretics are ineffective in hypothermia, whereas it is effective in treating fever. Hypothermia needs physical cooling like cooling blankets to treat it. So coming to the etiology of fever in ICU. So whenever we see a patient, critically ill patient with a fever spike, we have to look into the temperature spike. If it is more than, as we discussed earlier, if it is more than 105, we have to think in terms of causes related to hypothermia, which might be due to drug-related, that is neuroleptic malignant syndrome, or malignant hypothermia, or serotonin syndrome. There might be endocrine causes to it, that is thyrotoxicosis, pheochromocytoma, or adrenal crisis, or environmental related, that is heat stroke. When there is a fever less than 105 degrees Fahrenheit, then we have to think in terms of either infectious or non-infectious. When we don't have a clear focus of sepsis, that is when we don't really find a clear focus of sepsis, or we think there is no active, we have a suspicion of whether there is no active infection, then we have to think in terms of non-infectious causes. In non-infectious causes, again we have to see whether the fever has started outside the hospital or after arrival into the hospital. If the fever has started before the arrival into the hospital, think in terms of drug reactions like Stevens-Johnson's and other local factors like thromboembolism, or in cases of trauma like traumatic brain injury or SAH, pancreatitis and connective tissue disorders or neoplasms. When if fever arises after inside the hospital, then we should think in terms of either drug related, that is either drug related fever due to antimicrobials or AEDs used, or any transfusion related, that is after starting blood products, and because of prolonged immobilization, the patients might be prone for venous thromboembolism, and cases admitted into Neuro-ICU, central fever caused due to SAH and traumatic brain injury, and very rarely but very dreadful complication that might be acalculous cholecystitis might be there in prolonged hospital stay patients, and also can be seen in few drug withdrawal. So if you can see the system-wise causes, this is how it goes. So whenever we had to think about non-infectious causes, probably we can go in this order and rule out causes. So how do we investigate for it? So we can do a serum lactate level more than 2 usually usually favors sepsis but doesn't always rule out non-infectious causes, because in mesenteric ischemia, conditions like mesenteric ischemia, serum lactate might be elevated in much more conditions also. So whenever we have a clinical suspicion, depending on the symptoms, we can always investigate. That is, if a patient has pain abdomen, think in terms of pancreatitis and send off amylase lipase. If at all there is no focus of sepsis but the patient is severely ill, always think of acalculous cholecystitis and rule it out by sending alkaline phosphatase and GGTs and do an ultrasound abdomen as well. So this is how it goes in terms, if in case of thyrotoxicosis, adrenal insufficiency, depending on the clinical scenario suspicion, you go about and test it. So what is the role of CRP and procalcitonin in ruling in and ruling out infection? So CRP is a very non-specific marker, so it is really not very helpful in differentiating infective and non-infective cause. But procalcitonin, it is a biomarker of sepsis. It correlates well with bacterial infections, only there are some demerits to it, that it can be raised in post-trauma and post-surgical patients. In such patients, it might not be really helpful, but it helps in de-escalation of antibiotics when required. And higher procalcitonin values are associated with increased mortality. So whenever a patient develops fever inside the ICU, always examine from head to toe clinically, like with basic examination like volume or quality of sputum. If at all any drains are present or any lines are present, look at the site of insertion, how clean is the site of insertion. If a patient is post-surgical, look at the surgical site, whether it is clean or infected. And we always have an ultrasound available on bedside in ICU. So always, you can always perform a lung ultrasound to rule out any, if at all if we have to rule out infection, then look for consolidations. If non-infective causes, then we might find a atelectasis which shows a static air bronchogram. So you can, we can do a gallbladder ultrasound to see to rule out calculus cholecystitis, and DVT scan for to rule out DVT, that is 4-point compression ultrasound. So we'll discuss few cases. So probably we'll understand some approach. So a 25-year-old male admitted to the hospital following RTA. He was on phenytoin for seizure prophylaxis post-trauma and was on ceftriaxone. He developed early VAP due to strep pneumonia, but he became afebrile on day 4. But started to have a single spike of fever on day 7. But patient was hemodynamically stable, heart rate was okay. He looks well for the spike of fever he had. Only positive investigation was that total count was high with 25,000 and mildly elevated alkaline phosphatase. The other investigations were normal. So how do we go about this case? Send off cultures and switch to another antibiotic, is it really required? When the patient is quite comfortable and quite stable enough, we, in this case, we might wait on it. When do we have to do this? If the patient is neutropenic, hypertensive, oliguric, or any worsening sensorium. When do we have to send culture, whether to send cultures and stop all antibiotics? We can still wait on it in this case. If there is multiple spikes of fever, but otherwise stable patient, you can always send cultures and stop the antibiotic. In this case, is there only a single spike, otherwise patient is improving clinically. So there are no need for cultures as of now. We can stop antibiotics and wait and watch. What is this fever at all due to? So diagnosis in this patient is drug fever. That might be either due to the ceftriaxone he was receiving, that is beta-lactam, or due to the phenytoin AED prophylaxis he was receiving. So how this clue was, like how did we get a clue of it? That it is because the patient had an initial improvement, further had a single spike of fever, and the pulse rate response was not appropriate with the degree of fever amounted. So there is a relative bradycardia, and the patient was clinically stable enough with a mildly raised WBC. So, and there is a temporal association of starting a drug before that. So we came to a diagnosis of drug fever because of that. So what are the high-risk agents associated with drug-related fever? Antibiotic-wise, most common it is beta-lactams. AEDs-wise, it is phenytoin, carbamazepine. And anti-arrhythmics-wise, it is quinidine, procanamide. Antihypertensives like alpha-methyl-dopa. Usually, if it is a drug-related fever, it usually resolves within 72 hours of stopping the drug. So let's move on to next case. A 65-year-old diabetic male underwent CABG. He develops fever on day 2. Wound is clean X-ray is normal, hemodynamics and urine output are normal, but the counts are raised and procal is also raised. So there arises a suspicion whether it is infective or non-infective. So the likely cause of fever here is post-operative fever. Why is it? Because in a patient who has undergone recent surgery, the procal might be as well raised, and the fever has appeared within 72 hours after surgery. So it is usually post-operative fever within 72 hours of surgery is usually non-infective. So we think of infection only when the fever arises after 96 hours after surgery, and the surgical wound was also clean. So within the first 72 hours, if fever appears, cultures are not mandatory. But a surgical wound examination should be done on a daily basis. Procal was not helpful in this case because it might be raised after a major surgery. So DVT and pulmonary embolism, we would not think of it here because anyway patient was post-CABG, he would have been on anticoagulants. Next one, a 42-year-old female with low GCS diagnosed with aneurysmal SAH for which surgical clipping was done. She underwent tracheostomy following day due to low GCS and thinking that she would require a prolonged ventilator requirement. So she developed fever on post-operative day 4 and mildly tachypneic, but CT scan showed resolving SAH and a small post-operative hematoma, but otherwise hemodynamics were stable. GCS was slightly improving, but counts were increasing and chest X-ray was normal. She was already on a central line and Follis day 5. Here again, what would be the differential diagnosis? Should we think in terms of fever, but the patient is apparently normal for the degree of temperature and clinically she is improving, GCS is improving, CT scan report shows there is an improvement. So we hardly think in terms of either CAR-T or CLAPSI. So what are the differentials we would see in this case is that it can be a post-neurosurgery fever, that is any intervention done inside the brain, immediate period. This might mimic meningitis even if you draw a CSF because of the active inflammation going on. There might be a rise in neutrophils, but cultures are always negative. So 45%, nearly 45% of all post-surgical neurosurgical fevers are non-infectious. And it might be drug fever because it is a post-SAH patient. For AED prophylaxis would have been started. It might be very possible. And DVT and fat embolism, yes, it is possible. If not for fat embolism, DVT might be possible in this patient because of he or she might not be receiving prophylactic anticoagulants. And the other most possible possibility is that it is central. It might be very well be central fever because it occurs very early in the presentation and most commonly seen with SAH. So there are two components of there are two components, that is central fever and other paroxysmal sympathetic hyperactivity, which produces fever in this neurosurgical patients or in post-trauma neuro patients as such. So how do we differentiate both is that central fevers are usually produce high fever and are all continuous. They do not have any diurnal variation and there is absence of sweating. And patients usually have relative bradycardia and they are resistant to antibiotics with negative cultures. Treatment would be bromocriptine. So the other component is paroxysmal sympathetic hyperactivity. It might be relatively rare compared to central fever, but most common in traumatic brain injury. It is episodic, unlike central fever which is continuous. It is precipitated by a trigger. Sweating is usually present. Tachycardia, hypertension and dilated pupils may be other findings. The treatment is clonidine and propranolol, which might block the sympathetic activity. So next would be a 55-year-old male on treatment for depression with fluoxetine and antibiotic drugs. Develops cellulitis of lung, treated with augmentin, undergoes urgent debridement in OT. Post-op antibiotics changed to piptazine linezolid. He develops fever of 105 degree centigrade, 105 degree Fahrenheit, and post that he develops some agitation also. So what would be the differentials in this case? And what would be the treatment of choice as well? So first let us discuss the differentials in this case. So this might be very well be serotonin syndrome, because there is a concomitant use of linezolid, which is a MAO inhibitor, which was used with SSRIs, which has increased production, which causes increase in serotonin release and causes the symptoms. And it can be malignant neuroleptic syndrome if patient was on antipsychotics. It can be malignant hypothermia if drugs like halothane or succinylcholine would have been used during the intra-op, and if patient was genetically predisposed. So how do we differentiate NMS and serotonin syndrome is that predisposing agent, whatever agents the patient was on, how do we differentiate is that they share multiple clinical features, but reflexes or blunt in in NMS, and whereas hyperreflexia is seen in serotonin syndrome. Pupils are normal in NMS and dilated in serotonin syndrome. The treatment for serotonin syndrome is ciproheptadine. So what is malignant hypothermia? It is caused by, as we discussed, it is caused by succinylcholine and inhalational anesthetic agents like halothane. A patient would be having a gene mutation, that is ryanodine receptor mutation, which causes exaggerated calcium release, and this would cause the symptoms. Treatment would be dantrolene. Moving on to next case, 65-year-old male, diabetes, ischemic heart disease, underwent small bowel resection following mesenteric ischemia. He was on TP and developed fever on day 12, but hemodynamically stable, central line site is clean, X-ray is normal. So this is ultrasound lung, which is normal. Ultrasound abdomen shows distended gallbladder with sludge in it and with a thick wall thickness and minimal pericholecystic fluid. So what is the most likely diagnosis? So the ultrasound itself gives us a clue that it is acalculous cholecystitis with distended bladder, with gallbladder edema and minimal pericholecystic fluid. So how did we come to that conclusion apart from ultrasound is that patient underwent a large bowel resection surgery, and due to the if at all, sorry. Post that the patient would have had a prolonged gallbladder stasis and underperfusion, which might have resulted in acalculous cholecystitis. So it is very rare complication, but very dreadful complication, which contributes to increased morbidity and mortality of the patient. So whenever a patient is very severely ill, but when we don't find an obvious source of illness, always keep this in mind. So are there any clues that differentiates infectious from non-infectious causes? Yeah, maybe we can think whenever there is a patient with shock, widened pulse pressure, and elevated biomarkers like procal, and altered sensorium, increasing lactate, or thrombocytopenia, we might as well have to think in terms of infection. So when we find obvious focus, then yes. So other clues are that if a patient presents with fever with shock, usually infectious, those are the causes. If fever with shock with rarely non-infectious causes would be adrenal crisis, thyrotoxic storm, hemolytic transfusion reaction. Fever without shock, yes, you have to think in terms of non-infectious causes, as we discussed earlier. So I would like to conclude the talk by saying nosocomial infections are usually overdiagnosed. Fever is not always equal to infection. It is not a sign of antibiotic deficiency. So we need not start an antibiotic or escalate an antibiotic at a knee jerk. Fever is not necessarily dangerous. Antibiotics are not antipyretics. These are my references. Thank you.
Thank you so much, Dr. Lalita Priya Garu, for your enlightening presentation. Due to time constraints, we'll have questionnaire session post-lunch. Now I request Dr. Anil Garu and Dr. Bhargav Garu to kindly present a token of our Now I request our chairpersons Dr. Suri Shetty Srinivas Garu, Dr. Manolasya Garu, Dr. Sabarish Garu to present a memento to Dr. Lalita Priya Garu for her enlightening session. Thank you so much. Now it's my privilege to call upon our Managing Director Dr. Ramadevi Madam Garu and Dr. Shiva Parvati Senior Consultant, Department of Nephrology, Amara Hospitals to join and present a mementos to our chairpersons in acknowledgement of their time, knowledge and valuable guidelines. Thank you, ma'am.
Moving on to fourth session of the day. Kindly a small reminder. So since we are running out of time, so there is no tea break, and if anyone wants to have tea, they can have it at the cafeteria, but the sessions will go on. And fourth session, I would like to invite the chairpersons for the session. So, I please request Dr. Nagaraj Makam, Head of the Department.
researcher and a physician. During his interested more than 28 gold medals in his career. He is always the best outgoing student from SUMC. During I have an opportunity to have postings with him. So we have college days. He usually very interesting in postings. He won't go to the clinics hostel after completing his postings. He went to every posting wherever the teaching is going on. So like that he started his research not in the after graduation. He started at physiology. When he is doing his physiology first year, he started his research on hypertension. So that is the interest of Dr. Aladi Mohan. And he is interested in tuberculosis. He wrote a book on tuberculosis, which is a standard textbook for all respiratory medicine postgraduates. So with this introduction, I invite Dr. Aladi Mohan to start his speech.
Please give a round of applause to Dr. Aladi Mohan garu.
Respected chairpersons, Dr. Subbarao sir for his very kind, affectionate words of introduction, the august audience who have gathered here, very good morning to one and all. I, at the outset, like to thank the organizers of this major event, the Amara hospitals and Dr. Rama Gaurineni madam for giving me this opportunity, and for my esteemed colleague Professor Hari Krishna for facilitating this lecture to be fitting into this scheme of the program today. I like to share with you something very interesting. It's not exactly a sepsis thing, but something which is very interesting in the ICU. I will share the story of how this evolved in the next 17-18 minutes so that we can deliberate over a few minutes. I have no conflicts of interest to declare, and I have not received any funding to participate in this event. Right. At this point in time, why have a talk on this subject at all? Well, of late, the critical care has evolved in many dimensions, from the intensivists, the invasivists, the experts in anesthesiology, medicine, pediatrics, neonatology. Everyone wants to have a pound of flesh of critical care. So, at this point in time, there is something called a medical ICU, which harbors a peculiar subset of patients. Each critical care team in a given place handles a different set of patients. My background is from a medical intensive care unit, which we have been running for more than 2 decades. And ARDS is a very common cause of admission in a MICU, and in the tropics, certain causes of ARDS are unique and different. For example, when I went to Houston to interact and present data on ARDS with the Baylor College of Medicine, Professor Guntupalli Kalpalata, they were astonished to see the spectrum of cases we were seeing in Tirupati. To the extent Madam came and visited us. Right. So, due to lack of awareness regarding the diagnostic criteria, the treatment guidelines which keep changing, it is a undiagnosed or a underdiagnosed disease. Now, if you look at the epidemiology and mortality, it's a very big study. It has shown that ARDS is seen to the tune of 10%, unrecognized, undertreated 20 to 50% of severe to mild ARDS. The whole spectrum remains like that, and the mortality is quite high, even in mild, moderate or severe ARDS. These are global figures, and definitely the figures in tropics would be higher. Right. If you see the spectrum of causes of ARDS all over the world, the most common causes are the green ones, bacterial sepsis, pancreatitis, burns, etc. There are other causes, but this gray circle, it shows a very peculiar subset of causes, of which tuberculosis is an important cause of ARDS. Many people think of tuberculosis as a subacute or a chronic disease where the patients amble into the outpatient service and seek care on a OPD consultation. But tuberculosis is a major thing which is treatable and curable. If you look at some of the studies on ARDS from India, the definition of ARDS has been changing. Till 1994, each one had their own definition. In 1994, we had the American European Consensus Conference criteria for ARDS. That went on for some time, and in the year of grace 2012, we had the new Berlin, the then new Berlin criteria, which survived a Pushkara column or 12 years, and in 2024 January, the criteria, the new global definition of ARDS has come up. So when you interpret data, when you compare data, when you collate data from different centers, one should always keep in mind that are we comparing apples with oranges? Right. The problem is significant, mortality is still terrifying, more than 35 to 40% at all places. So this is the slide which I borrowed from my friend Subbarao, who is a ECMO fellow. The Ashbog and Petty definition of 1967 included persistent tachypnea, hypoxemia, and chest opacification. In the American European Consensus Conference criteria, it became the term, the PF ratio was introduced, onset was acute, bilateral infiltrates, no evidence of cardiac failure. These were built in. Then there was the concept of ALI and ARDS, acute lung injury, acute ARDS. That got changed. Why does it get changed? More evidence, more data. In 2012 came the Berlin criteria, which is since abandoned. Berlin criteria are also gone. So this is the current new global definition of ARDS, which came up in the year of grace 2024, already a year and some months old. So the time is ticking for this. The conceptual model of the new global criteria is very physiologically, pathologically sound compared with what the Berlin criteria were, and the clinical presentation is influenced by the medical management, position, sedation, paralysis, PEEP, and fluid balance. 5 things influence the course of the patient. These are also configured into the new definition of ARDS, and these are the details. Today I will not be discussing this definition threadbare, but it would suffice to say that the risk factors, origin of edema, timing, acute onset or worsening hypoxemic respiratory failure within 1 week, it is within 1 week of estimated onset. And then the chest imaging is not only the X-ray but also the CT. And you have the oxygenation variable, and the categorization as mild, moderate, and severe. In resource limited settings, in Chandragiri or Naravaripalli or Chinnagottigallu, with a pulse oximeter, which is now commonplace thanks to COVID. COVID was an adversity, but we have learned something from COVID. If we do not have the arterial blood gas analysis, we can use the SpO2 to FiO2 ratio. It is a boon. Actually, till then, till this point in time, till the new criteria came, it was more of guesswork rather than precision medicine. This is a major sea change. In resource limited settings, you have the facility for defining ARDS concretely. So these are the typical intubated ARDS, non-intubated ARDS, and ARDS in resource limited settings. The lower panel shows a small under-resourced hospital without blood gases, X-ray or MEC-vent. Ultrasound is everywhere. Ultrasound of the lung is the new kid on the block. POCUS is the order of the day. With POCUS and a pulse oximeter, you can diagnose acute respiratory distress syndrome. Right. What is the evidence for TB-ARDS? It's a very classic paper which was published way back in 1995, and this paper was abstracted in the Yearbook of Diagnostic Radiology. This is a story I want to share with you regarding how we picked up TB as a primary cause of ARDS, how we established the cause and the effect relationship. Not mere guesswork, but how did we tangibly tie up these two. Right. So this patient was admitted for resistant Kala-Azar. He came from Bihar. Patient had been treated with sodium antimony gluconate. He did not respond. We had admitted him for microsomal amphotericin B administration, which was not available anywhere. The year was 1993, 32 years ago. Okay. So when this patient was admitted, it was a Sunday morning. The patient was admitted on Saturday evening. On Sunday morning, all wards are cleaned in the All India Institute. Arun Raja will remember. Sunday is the cleaning day. Wards were being scrubbed. And except the consultant, the JR on call and the SR on call, ab sab log bahar jaiye. All others were kept out. He was in bed number 10. So previous evening, we had done the splenic aspirate. It showed LD bodies. It was positive. It was pakka resistant Kala-Azar. That is the working diagnosis. Next morning we were supposed to start liposomal amphotericin. In the morning when we started the round, Professor S.K. Sharma came for the round. At 9 o'clock, the guy was good. He was sitting and eating some roti dal. At around 10:30, the nurse came slipping, falling on the wet floor and told, "Doctor, wo patient gas pe kar raha hai." And we went there. We went there and the guy was literally in respiratory distress. And then the guy was gasping. So we tried to call our friend from anesthesiology from the 8th floor. Then there was that guy came and said, "I will discuss with my consultant to intubate or not." Kala-Azar, what is this? How can suddenly? Then boss told, "Tube dalo." They were discussing. So I intubated this patient. And this is the X-ray, portable X-ray, which is taken at that time. Typical frontal opacities. It's a very precious X-ray. It was a typical ARDS-like picture. We never really knew what it was. We never really knew what it was. Then we did the ET aspirate. ET aspirate. Then we sent the ET aspirate for acid fast bacilli. Nobody usually sends ET aspirate for AFB. In those days, expert was not there. ET aspirate showed AFB. Then we started this patient with, in those days there was a streptoarbazide. Streptoarbazide was streptomycin, injectable streptomycin with isoniazid. And we started the patient also with ethambutol through the Riles tube. And some modified ATT we started. But within few days, the chest X-ray, the consolidation, airspace consolidation cleared. You can see a miliary pattern. We were not convinced. Are we some kind of fluke or something contaminating the AFB positivity? So we did a liver biopsy. And the liver biopsy showed the typical granulomas of miliary TB. So when we sent this paper for publication, Julian Hopkins, he asked, "Can you send us the X-rays?" So I was young and I was mad. I told, "Do you think I'm black? You are not believing me? If you don't want to publish my paper, go and jump in a well. I'll go somewhere else." He said, No, doctor. The quality of photographic prints you have given, your camera is of lesser quality. I will take better photographs. We want to send it to Yearbook of Diagnostic Radiology. So that is how, this was our first encounter with TB-ARDS. Then I wrote up a paper subsequently. We took out our 12-year experience with TB-ARDS and what we found. And thereafter, after I came to Sri Venkateswara Institute of Medical Sciences, Tirupati, we did a study over 5 years with regard to TB as a cause of ARDS. 2 centers, All India Institute at New Delhi and our center at Tirupati. Till today, you can, I just did an online check now, you can verify this. Till today, this is the largest published series of ARDS where TB is the primary cause in the world. There is no publication further beyond this with a larger number of patients. Okay, so the important point I want to mention here is the diagnosis confirmation. If you look at our study, we got diagnosis in a significant number of patients by testing the ET aspirate for mycobacterial culture and AFB smear in those days. Okay, so when there is a ARDS of obscure etiology, think of tuberculosis as one of the differential. Though the history is acute and the patient may not fit into a typical presentation of TB. So microbiological and histological methods, if you carefully examine the patient, you may pick up a node somewhere. If nothing is there, there is no, if the liver enzymes are elevated, the SAP is elevated, you can do a liver biopsy, else you can do a bone marrow. You will get the etiological diagnosis. So the clinical presentation is typical like any other ARDS, the acute phase, the exudative phase, the progressive phase and the recovery phase. Any ARDS, the presentation is monotonous. There is not much to choose. But we should keep in mind the subacute or chronic disease in the differential diagnosis. Later on, we further continued this work with regard to acute respiratory failure requiring mechanical ventilation in the MICU. My esteemed colleague, Professor Hari, is a co-author for this paper. We found that a significant 5.2% patients in this study, they had TB as the primary cause of acute respiratory failure requiring mechanical ventilation. The story does not end there. The Royal College of Physicians wanted, as a subject expert, an editorial on this topic. So we put together what is current and what needs to be done on this issue. So treatment strategies for ARDS is early confirmation of etiological diagnosis and start of specific treatment for the underlying cause. The lung protective ventilatory strategy, I think for most of you here it is bread and butter. I don't need to go into great details. The following the resolution of shock, fluid conservative strategy including use of diuresis to achieve a net fluid negative state. The role of neuromuscular blockade, prone positioning for patients with moderate severe ARDS, prophylaxis for stress ulcer DVT, sedation and analgesia to promote ventilator asynchrony, and these measures facilitate ventilator liberation, which can be begun when the patient is able to tolerate a FiO2 of 0.5 or less and a PEEP of 8 or less. So to conclude the journey in TB-ARDS, the clinical presentation of ARDS can be obscure. The expenditure involved in diagnostic armamentarium is high and is astronomical and is unavailable. The need for developing point of care tests is urgent. Early diagnosis is important because institutional specific treatment can be life-saving. Yeah, the specific treatment of anti-TB treatment, specific institution of anti-TB treatment is life-saving, but where are the injectable anti-TB drugs? Ceftorbazide is no more available. Breaking the tablet, making them into a powder, putting through Ryle's tube is jugadism. But are we sure of bioavailability? We don't know. These are all the research questions for the future which needs to be addressed. Putting a combination of injectable amikacin and injectable quinolone is two-drug therapy, which is no good. One may tide over if there is a MODS or etc. But we need to look at this in the years to come. So at the end of the day, what is the take-home message? Patients with ARDS are sick and require intensive care, invasive monitoring, and frequently need assisted ventilation. What is the role of NIV? Role of NIV in malaria ARDS, TB-ARDS, typhoid ARDS, snakebite ARDS, pesticide poisoning ARDS, there are no data. Yeah, I will try NIV, if it fails I will intubate the patient. It's an innovative approach, again jugaadism. We need data, unless there are data, there will not be guidelines. Unless there are guidelines, it will not be SOP or standard of practice. Data need to be generated. But I will repeat what Professor Sharma told me at the end of the day. K, Sera, Sera. Whatever will be, will be. Right? Later in the day, it does not matter what mode of ventilation is being used. Outcome is poor. If you want to tackle ARDS, you aggressively intubate. Intubation should not be an afterthought. It should be a forethought. Whether you are with volume control, pressure control, lung protective prone positioning, blah, 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 and ECMO. ECMO is also the new kit, and there are very few papers of ECMO in TB-ARDS. So, all things said and done, whatever you do, do early. So, what should be the take-home message today? In ARDS of obscure etiology in the tropics, think of TB, think of malaria, think of scrub typhus. We recently published the interest trial in the New England Journal of Medicine, March 2023. The comparison of doxy versus azithromycin versus combination of both in moderate to severe scrub typhus. My center was one of the collaborating centers for the interest trial, and ARDS of obscure etiology, remember TB, remember malaria, remember leptospirosis, remember scrub. One unconnected point to TB. Please examine the patient's perineal area in the ICU. Unknown etiology ARDS, examine the eschar will be in perineal area because eschar forms at the site of bite of the mite, and our people do open air defecations squatting in the field. The mite will bite in perineal area. So if you find the eschar, it is life-saving. So the journey in TB has been long. What started as a idea in 2001, the second edition came in 2009, the third edition came in 2019, and now it is considered to be the best textbook of tuberculosis in the world among all academic circles. And we are due for the fourth edition very shortly, in a few months from now. I thank the organizers. Yeah, I think it is Indian Standard Time, not Indian Stretchable Time. My timer says it is 20 minutes. So I will conclude my presentation. If there are any queries and questions, they are welcome. Else, that's it.
Sir would want to take few questions, and any questions from audience are invited now. Yeah. Any questions from the panelists?
Regarding diagnosis, so is that tracheal aspirates is sufficient or any other modalities?
So the tracheal aspirate is a routine, easily obtainable secretion which can be sent, sir. But if you have the facility, I am talking about low resource setting where the highest interventional critical care is not available. But the person can always be bronchoscoped and representative bronchoalveolar lavage taken from the affected segments as defined on the chest CT. That would pinpoint a good material. One needs to do expert MTB for gene expert on the respiratory secretions.
Are these all cases presents with acute presentation or a chronic presentation?
Sir, ARDS will, as per the current definition 2024, sir, the duration of symptoms can be up to 1 week, sir. Up to 1. Usually they come over a short period of, like the first patient I saw, history of was a few hours duration, few hours, 2-3 hour duration. But up to 1 week, it still fits with the definition of ARDS, sir.
Is there any radiological findings which suggest of tuberculosis ARDS?
No, sir. Specifically suggesting tuberculosis ARDS, there are no findings, sir. Because ARDS, the typical presentation, radiological imaging is same, monotonous with any cause of ARDS, sir. Based on radiology, it is not possible to distinguish, sir. It is not a discriminatory test, sir.
Yes. This is the clinical course will go. Patient may have tuberculosis, may have localized opacities. Followed once this patient develops ARDS, immediately the opacity is bilateral and acute, as my
yes, sir. Sir,
experience.
See, a known TB patient while being treated can develop ARDS, sir. That is easy to diagnose. But the problem is patient presents to the casualty with what looks like a typical ARDS, but no focus, no cause is found, sir.
But no, not on treatment, but they will be seeing so many physicians. Diagnosis will be like tuberculosis only, spares cavity or upper lobe opacities, like that.
More common
After some time,
landing out of nowhere,
they
sir.
land in sudden acute respiratory failure. That is more in suggestive of ARDS developed in a patient of tuberculosis. So most of the times diabetes we see commonly, they will be wandering here and there as like pneumonia. After some time they will come and within 1 day they land in ARDS. So these are the routine clinical pictures.
A patient with a history of 1 or 2 days, usually the typical history of patient with a slowly resolving, non-resolving pneumonia will be around more than a week or 10 days like that, sir. But we see patients with a very typical few hour history of what looks like a typical ARDS, sepsis or something. But no clue is found, sir. That is when the picking up TB will be life-saving.
Sir, I just have one question, sir.
Yes, Arun.
Now that there are some trials showing evidence in ARDS usage of steroids, so would you actually prescribe steroids for TB-ARDS?
Good question. Till now, even now, there has been a subset of patients with ARDS where BAL has shown eosinophilia. In that subset of patients, steroids are supposed to be beneficial. So that subgroup analysis has shown. Per se, the evidence is yo-yo. Some studies says useful, some not. But at some point in time, if you want to save life, give steroid. We have to put the art before science of medicine.
Sir, I have one question, sir. I am Dr. Amara, sir, Assistant Professor of Medicine. Sir, most of the cases, sir, which are having underlying immunodeficiency such as retroviral disease and tuberculosis, we have to keep in mind that where there is diabetes and immunodeficiency, can we suspect we are presented with acute ARDS without prior history of TB? That was the first question. So second question, whether we have to start any empirical ATT based upon this.
Both questions are really relevant. Sir, the risk factors for occurrence of TB of any form or immunosuppression of any form is evident only in some patients. In many patients, more than 35 to 40% of patients, we have no clue. The two new emerging, especially tobacco smoking is a risk factor for development of TB, sir. That history should be meticulously documented. Regarding starting ATT, the sooner we start, one may err, overdiagnose and over-treat. That will save life than withholding for a proof. That will kill the patient.
So we have to start
Yes,
empirically, we have to
sir.
start.
Yes. No harm. Review the diagnosis later. You want to stop, you can discuss.
Thank you, sir. And further, I want to tell you, this can be taken up as a thesis topic.
Yes, sir.
So I want to give my PG, sir.
Yeah, please.
Thank you. And we need your cooperation also. We need your cooperation also,
yes,
sir.
anytime.
Thank you so much.
Anytime. The idea is to stimulate thought process so that work gets carried forward. Right then. So if I am done, I'll get going.
I request Dr. Subbarao Garu and Dr. Alok sir and Srinivas sir to award memento to Dr. Aladi Mohan sir. Thank you, sir. That was indeed a very beautiful session on ARDS. Thank you for sharing all the expertise and knowledge. So with that, we move on to the next topic. And I would like Dr. Aloka, sir, to present the next faculty.
I had the pleasure of inviting Dr. Hamid Kumar, who after finishing his DM cardiac anesthesia has joined Amara Hospital as a consultant cardiac anesthetist and cardiac critical care. So he has 4 publications to his credit. I invite Dr. Hamid Kumar to deliver his talk.
Thank you for introduction, sir. Good afternoon. My topic is POCUS precision and revolutionizing sepsis management with POCUS. Here I begin with a case scenario. 30-year-old male, post-trauma, open fractures, underwent external fixation on 3rd POD. Patient has heart rate of 140, BP of 90/40. What are the possible differential diagnosis in this case? So post-trauma, inadequate resuscitation in ICU or internal bleeding, it can present as a hypovolemic shock. Post-trauma, open fractures can present as a septic shock. So post-trauma, long bone fractures can present as a pulmonary embolism. Sometimes in ICU, clinical examination alone is not sufficient and the lab investigations takes time. Here where the role of POCUS sets in. This is second case, 60-year male, EF of 35%, cellitis over right lower limb, and heart rate of 130, BP of 80/40. What is the next step in hemodynamic management? IV fluids first or noradrenaline first? This is exactly where POCUS steps in. This is POCUS bundle in sepsis. It plays 3 major roles: diagnosis, fluid treatment and monitoring, and therapeutic management. The most important thing in diagnosis is identification of primary source of infection from lung, heart, abdomen, pelvis, skin, soft tissues, vascular, transcervical and transoral routes. Another most important thing is identification of cause of shock. So this is an approach to undifferentiated hypotension. This is a systematic step-by-step approach. Step 1 is visual assessment of left ventricle and right ventricular size and location. And second, from this step we can rule out a cardiogenic shock. And second step is measurement of stroke volume with left ventricular outflow tract VTI. Left ventricular outflow tract VTI is mostly seen in septic shock. If it is more than 18, then it is septic shock. LVOT VTI less than 18 seen in hypovolemic, obstructive and hypovolemic shocks. Step 3 is rule out obstructive shocks like pericardial tamponade, pulmonary embolism, dynamic LVOT obstruction, and also measure the left ventricular end-diastolic area to rule out septic and hypovolemic shock. Step 1, assessment of left ventricular function by endocardial excursions and myocardial thickening. Here there are many studies which shows that the visual estimation of left ventricular ejection fraction versus quantitative measurement of ejection fraction shows that visual assessment of ejection fraction has acceptable accuracy. This study is conducted in emergency physicians and anesthesiologists. This is a parasternal long axis view. To assess the function of left ventricle, assume an imaginary line at the center of left ventricle. Here we can see the both walls of endocardium is approaching towards the center, and you can also notice the myocardial thickening. This is short axis view, mid papillary. In this This is the apical four-chamber view. We can see the endocardial excursions and myocardial thickening here. This is parasternal long axis view showing severe LV dysfunction. Here you can see there is minimal endocardial movement towards the center, and you can also see the minimal thickening of myocardium. This is parasternal long axis view showing mild to moderate LV dysfunction. Assessment of right ventricular function is by right ventricular to right ventricular size, septal kinetics, IVC size, and right ventricular systolic pressure. Normally, the size of right ventricle is less than 2/3 of the left ventricle. Here, in second echocardiographic image, you can see LV size is equal to that of RV size, which indicates that RV dysfunction. And in third echocardiographic image, you can see the RV size is more than that of left ventricle. We call it as severe RV dysfunction. This is parasternal short axis view. Normally, the shape of left ventricle is usually circular. Here you can see the right, because of high pressures in the right side, the interventricular septum becomes D-shaped. The shape of left ventricle becomes D. This is another characteristic feature of right ventricular dysfunction. Dilated IVC is another characteristic. Second step is measurement of stroke volume measurement by LVOT VTI. So get a good five-chamber view, place pulse wave at the LVOT, and you will get a trace like this. Measure this trace, and you will get LVOT VTI. LVOT VTI more than 18 is seen only in septic shock. Hypovolemic shock and septic shock share common echocardiographic features, like the walls of left ventricle is almost touching each other. We call it as kissing papillary muscles. So to differentiate from hypovolemic and septic shock, there is another thing is left ventricular enddiastolic area. Left ventricular enddiastolic area is normal in septic shock, where it is reduced in hypovolemic shock. Identification of source of infection from lung. A meta-analysis of 10 studies demonstrate that POCUS has high sensitivity and specificity in diagnosing lung conditions when compared with the chest X-ray. Complete lung ultrasound examination involves assessment of 6 areas for each hemithorax in mid-clavicular, mid-axillary, and interscapular regions. This is ultrasound of lung. The area of lung which shows tissue-like echo structure is called hepatization, and hyperechoic areas moving to and fro with inspiration and expiration, call it as dynamic air bronchogram. This is another characteristic feature of pneumonia in POCUS, Strett sign. The pleura becomes irregular and disrupted. Here you can see the liver, above which is diaphragm, and anechoic collection above the diaphragm is pleural effusion. You can see the area of lung is compressed and floating in the pleural effusion. We call it as a jellyfish sign. Both pleural effusion and empyema share common echocardiographic features, except you can see the multiple echogenic dots here, which represents a thick fluid, which can be a pus in empyema or blood in hemothorax. Identification of source of infection from heart. You can see multiple vegetations here attached to the aortic valve moving during systole and diastole, and here you can also see vegetations attached to the tricuspid valve. With the help of POCUS, we can diagnose acute cholecystitis, appendicitis with high sensitivity and specificity, and diverticulitis, colitis, and complicated UTI. This is ultrasound of skin and soft tissue infections. Here you can see the cobblestone appearance. The hypoechoic and anechoic areas between the soft tissues represents the edema fluid. This is ultrasound of necrotizing fasciitis. You can see hyperechoic areas moving to and fro is the air in the tissues, which is the characteristic feature of necrotizing fasciitis. Fluid management. In 2021 surviving sepsis guidelines provided a weak recommendation for dynamic measurements to predict the volume responsiveness, but POCUS becomes a valuable tool in fluid management, particularly associated with cardiac conditions and mixed shock. The physiology behind fluid responsiveness is IVC collapses during inspiration. In mechanically ventilated patients, IVC distends. So collapsibility index is a measure of fluid responsiveness, and distensibility index is a measure of fluid responsiveness in mechanically ventilated patients. A collapsibility of more than 50% and distensibility of more than 18% are considered as fluid responders. Here, this is a subcostal view. The IVC walls almost touching each other, collapsing more than 50%. In second echocardiographic image, you can see IVC is dilated and it is not showing any movement during inspiration. We consider it as a non-fluid responder. Another test for fluid responsiveness is straight leg rise test. Make the patient lie down and rise the legs. A volume of 500 ml reaches the heart and measure the LVOT VTI within 1 minute. If it is LVOT VTI improvement is more than 12%, then it is a fluid responsiveness. These are therapeutic interventions with ultrasound. Ultrasound guided thoracocentesis. POCUS reduces pneumothorax by 19% and also reduces local complications. US guided diagnostic and evacuation paracentesis. Ultrasound guided placement of urinary stents and percutaneous nephrolithotomy. POCUS guided escalation and de-escalation of fluids and vasopressors. Conclusion, POCUS helps in rapid identification of source and also diagnosis of septic shock from undifferentiated hypotension and effective management of sepsis and septic shock. POCUS with clinical assessment has high sensitivity, specificity, positive predictive value and negative predictive value. These are my references. Thank you.
Thank you, sir. So now I would request Dr. Nagaraj and Dr. Srinivas sir to give memento to Dr. Hemant. I also request Dr. Anand and Dr. Radhika to come on stage. So, I request Dr. Anand and Dr. Radhika to come on stage and present a moment of appreciation to all the chairpersons. So now we are at the end of the morning session. We'll break for lunch now. So the next session will start in exactly after 15 minutes, and people who are not able to eat fast, they can get their plates and they can come and brace the next session.
Consultant, Critical Care, Apollo, Nellore. Dr. Ramesh Reddy, sir, Consultant, Department of Medical Oncology, Omega Hospitals. Dr. Rajesh Naidu, sir, Consultant, Anesthesiologist and Pain and Palliative Care, Amara Hospital. Dr. Ashok Reddy, sir, Senior Consultant, Department of Orthopedic Spine Surgery, Amara Hospital. Dr. Rakesh, sir, Senior Consultant, Department of Anesthesiology, Amara Hospital.
I request Dr. Rakesh, sir, to join the chairpersons. Now I request Dr. Dinakar, sir, to introduce our distinguished speaker, Dr. Madan Mohan, sir, Managing Director, Mother Hospital, Tirupati.
Hello. Welcome you all to the afternoon session. I would like to introduce our beloved speaker, Dr. Madan Mohan Reddy Garu. So he is currently Managing Director of Mother Hospital. I feel he doesn't need any introduction, but still I would like to tell a few words about him, as we already listened about him in the morning session. So I would like to come to give this valuable talk from Madan sir.
Let's have a huge round of applause for Dr. Madan, sir.
Good afternoon. Thank you very much. First, I would like to thank few people before giving my lecture. I would like to thank Shankar and his team for conducting a wonderful CME today and inviting me to deliver a lecture on sepsis. And I would like to also thank my professor, Dr. Fanindranath Tota, who is late Dr. Fanindranath Tota, who has not only taught me anesthesiology and critical care medicine, who has really instilled a lot of passion in working for the patients. And I always remember his words that medicine is a science, it's not a belief system. So without scientific evidence, you are not supposed to practice medicine. So I strongly believe that, and now I proceed with my lecture. So whenever we think about sepsis, immediately we more than 99% of the times we think about bacteria, MDR bacteria, XDR bacteria, but very rarely we think about either virus or fungi. So because we commonly see and we easily diagnose bacterial infections in the ICU, so we tend to think about bacteria whenever a patient of sepsis gets admitted into the ICU. But fungi are existing. More than 300 species of fungi can cause infections in human beings, but not all of them can lead to the sepsis. So the incidence of sepsis due to fungal infections, that is invasive fungal infections, has risen sharply since 1980s. So this correlates with the invention of broad spectrum antibiotics and advanced treatments for malignancies and prolonged admissions in the ICUs. So they nearly contribute up to 10% of total sepsis patient. The range may vary based on what type of hospital you are working. So the hospitals where they deal with hematological malignancies or transplants or patients where the patients are on immunosuppressive drugs, the possibility of sepsis due to fungi is more. And out of fungal infections, Candida contribute the major chunk, that is nearly 70 to 90% of invasive fungal diseases are due to the Candida species, and the remaining few most probably with Aspergillus. So out of Candida, there are nearly around 17 species can cause infections in human beings. Candida albicans is historically more common fungi which can cause invasive fungal disease. So recent one Indian study in neonatal ICU has shown that the incidence of Candida albicans has come down below 50%. Now the others like Glabrata and Cruzae are contributing the remaining 50% of infections due to the Candida sepsis. So others like Aspergillus, histoplasmosis and Mucorales can also cause sepsis in ICU patients. So why we are more worried about fungal sepsis is the fungal sepsis carries mortality higher than the bacterial sepsis. The reasons may be, one, we diagnose them very late because generally we don't think about fungal infections on the first and the admission, and the two, it's difficult to diagnose fungal infections and it leads to the delay in the treatment of antifungal agents. So there is always, the morbidity is always higher in fungal infections when compared with the bacterial infections. So now we know that invasive fungal infections are increasing over fewer decades since 1980s, and delay in antifungal therapy is associated with the increase in mortality. It is an established fact. So whenever you think about fungal sepsis, you have to diagnose it early and initiate the treatment as early as possible. So early antifungal treatment is the key. So then only we can save the patients in patients with invasive fungal infections. So then how could we diagnose? Blood culture is the gold standard for either for bacteria or fungal infections. But in fungal infections, we cannot depend on blood cultures because the yield ratio is low and it takes prolonged hours or prolonged time to diagnose through cultures. And for Aspergillus, the blood cultures, negative blood cultures rate is very, very high. And we have non-culture diagnostic tests like galactoman test, which is widely used in Aspergillus, Manon antigen or antibody test, then beta, sorry for this, I type it like B. It is beta 1,3-D glucan, PCRs, and T2 Candida, which is not yet commercially available, and latex agglutination assay mainly used in cryptococcal infections, then imaging, either chest X-ray, CT scans. So these investigations are not without problems because most of these non-blood culture diagnostic methods for fungal infections require huge infrastructure, and that's the reason they are limited only to the tertiary care centers and which are not available widely. And moreover, most of them are expensive. So now we are left with options. One, to start antifungals to all the patients admitted with sepsis in ICU, or you identify the risk factors and identify the patients who are at high risk for fungal infections and start empirical antifungals for on these patients. Before discussing about empirical antifungal treatment, we go briefly through the antifungal agents which are available widely. So polyenes, it's mainly amphotericin B. All of you know about amphotericin B. It is a very popular antifungal agent with broad spectrum activity, but it constitutes a lot of toxicity, mainly infusion related toxicity or nephrotoxicity. So later they prepared lipid formulations which are now popular, but they are expensive. So which they also have toxicity, but much lesser than the amphotericin B deoxycholate. The polyenes, the amphotericin B, they are, as already said, they cover most of the fungal infections except the rare pseudosporium and epiospermium, and it's available only in the IV formula. So only admitted patients can receive amphotericin B, and it has poor penetration into the CSF, pleura and synovium, as well as aqueous humor. So then triazoles, we have lot of drugs which are commonly used now: fluconazole, voriconazole, posaconazole and isavuconazole. Fluconazole is these triazoles are potentially teratogenic, though there are recent studies which has shown any teratogenic effect on fetus, but traditionally we consider them as teratogenic. It is not widely advised in pregnant patients, and they can be both substrate and they are inhibitors of cytochrome P450 enzymes. So it causes, because for this reason they interact with a lot of drugs simultaneously we use in intensive care units. Then they can cause prolongation of the Q2 interval. When you are prescribing these drugs along with other drugs like tricyclic antidepressants which can prolong the Q2 interval, you should be careful. Then we look at fluconazole. It is the best tolerated agent among all antifungals, and bioavailability is very high, so it can be used orally as well as IV, and protein binding is low, and it has wide volume of distribution which can easily penetrate into, it can travel to CSF, urine, even aqueous humor. And drug reactions are less, especially when you use in doses of less than 200 milligrams per day, and dose exceeds more than 200 milligrams per day, the toxicity also increases. It is eliminated through urine, primarily unchanged. The spectrum is, it works better. Candida and Cryptococcus species are susceptible, and there is recently there is development of resistance to the Candida albicans also. The resistance rate is around 6%. For Candida glabrata, the resistance rate is now around 15 to 20%. But Candida krusei, it is intrinsically resistant to the Candida krusei. So if you are suspecting Candida krusei, better not to initiate treatment with fluconazole. Next is voriconazole. It is also high, bioavailability is high and a low protein binding. It is unlike proconazole, it is metabolized in the liver, and it is also inhibitor of cytochrome P450. And the major problem with the voriconazole is they have transient visual disturbances like photophobia, flashing of lights, hazy vision. If you use for prolonged use of voriconazole, it can cause the squamous cell carcinomas. It can also cause periosteitis and alopecia. So it has a wide spectrum. It is like fluconazole, most of the yeast are sensitive to voriconazole. It also acts on aspergillus. So unlike fluconazole, it is highly effective against Candida krusei. Then the newer drugs, posaconazole and isavuconazole, they are available in India now. So these both are available in both oral and IV formula. It is a highly protein bound with a wide volume of distribution. So posaconazole, the specific problem it is, its gastric absorption is poor. So then you need to give much higher dose for the better absorption. So now recently the better formulations of posaconazole are available, which has a better, which absorb better through the gastric route. So they are, isavuconazole has very few side effects, and unlike most of the triazoles, it shortens the Q2 interval. So all the triazoles actually prolongs the Q2 interval, but isavuconazole shortens the Q2 interval. So when you are using when patient is already on other drugs which can prolong the Q2 interval, isavuconazole is a better option. So it has a spectrum against Candida and Aspergillus and also mucormycosis. So that is So now Fluconazole and isoconazole are recommended as a second line agents for mucormycosis. So echinocandins, so we have 3 drugs are available now, caspofungin, micafungin and anidulafungin. All 3 have this almost similar spectrum with a little change in the potency. So it is only available as IV and it is widely distributed except for CSF and urine. And elimination of life is very prolonged and it can be given once daily dose. The spectrum is, it covers most of the Candida species and aspergillosis. And recently the reports of resistance to the Candida glabrata has been reported recently. And the complications, it's generally well tolerated echinocandins, but if you give rapid infusion rapidly, patient may develop red person syndrome, and you may see transient rise of transaminases in these patients. So now we know that it's diagnosing and establishing invasive fungal infection may take longer time and it's difficult. So most of the times we start fungal antifungals empirically. Then we have to look at who are really at risk of invasive fungal infections. So one, febrile neutropenia, patients who has undergone complex surgical procedures, especially abdominal surgeries, and who are on broad spectrum antibiotics for more than 5 to 7 days, and patients who are on mechanical ventilation for 5 to 7 days, and indwelling vascular catheters, especially central vascular catheters, and patients who are on parenteral nutrition, the patients who are diabetics, and patients on immunosuppression therapy like chemotherapy, and hematological malignancies, and patients who are on high dose corticosteroids, and even patients with pancreatitis are at risk of developing invasive fungal infections. So in 2016, it is a multi-center study done in Europe. So they have done 260 non-neutropenic, non-transplanted patients who are admitted in ICU with sepsis with multi-organ failure, and where they have found colonization of Candida. They used micafungin as a empirical treatment and placebo without empirical treatment. So so the conclusion they've come to is using micafungin in these patients did not increase, no, sorry for the mistake, did not decrease the fungal infection-free survival, did not increase the fungal infection-free survival at day 28. So despite using micafungin, they did not find any difference whether patient either received micafungin or whether they have not received any antifungal in this set of patients. So this is like most of the critical care specialists were practicing empirical antifungals in patients who are at risk in ICUs. But this study has shown that by using micafungin as an empirical treatment, it did not show any improvement or any, not only in fungal free survival, even survival at 90 days also there is no difference. So then it was like a jolt for whoever is practicing empirical antifungals in high risk patients. So then Ortshop has written a editorial. So is it a final nail in the coffin of empirical fungal therapies? But he has come up with a solution. We cannot, because this study has shown there is no benefit of using antifungals empirically, we cannot stop using empirical antifungals in all the patients. So they have done in a specific subset of patients. So still we practice using empirical antifungals in at-risk patients. So for that, there are few clinical risk indicators. One of them is a clinical risk prediction rule, where they identified 2 major risk factors, that is using antibiotics for more than 5 to 7 days and patients who have central venous catheter. Then minor risk factors like parenteral nutrition, dialysis, surgery or mechanical ventilation in medical ICU, patients with pancreatitis and who are on corticosteroids or other immunosuppressants. Out of these risk factors, if patient has they should have both the major risk factors plus at least 2 of the minor risk factors. You can consider using empirical antifungal agents in patients in ICU. Then is another score called Candida score. So where the 4 factors they are taken into consideration, that is multifocal colonization. In this, you collect non-invasive, you collect samples from not from the blood and the body fluids, you collect samples and send it for cultures. So if it comes as a colonization, you take it as a risk 1. So colonization should be present in more than one site, then it is score 1. If patient is on parenteral nutrition, they take score as 1. If patient has underwent surgery, especially abdominal surgery, score 1. And if patient is in severe sepsis, they allot 2 points. If score is more than or equal or more than 3, so the patient is at risk of having invasive candidiasis. So in this patient, you can consider giving empirical antifungal agents. So for invasive aspergillosis, so they suggest you are suspecting aspergillosis according to the risk factors. You do screening strategy is send blood for galactomannan or BD glucon test. You do at least twice in a week sampling. If it comes negative, ignore it. If it comes positive, then consider diagnostic driven strategy. So if comes positive, you start antifungals. In diagnostic driven strategy, you send blood or ball fluid or tracheal secretions or tissue biopsy for this test. And if they come positive, you consider giving antifungal agents. So sorry. So now we'll look at a few of the common invasive fungal disorders we see in sepsis. Invasive candidiasis is the commonest invasive fungal disease responsible for sepsis in ICUs. So whenever there is a central venous catheter, please remove it as soon as possible. If patient has tunneled catheters, that is long-term permanent intravascular catheters, you can retain them. So because these catheters rarely get infected with the fungal infection, so you can consider them retaining if you have a tunneled intravenous catheters. So whenever there is a suspect invasive candidiasis, you always have a examination of eye, that's a ophthalmic examination, because most of these patients have endophthalmitis. So invasive candidiasis, if patient is non-neutropenic and if patient is stable, you can still consider using triazoles like fluconazole or voriconazole as a first line agent. But you should, because of better safety profile, fluconazole you can consider as a first choice, but if you are suspecting Candida cruzi, you always consider voriconazole as the first choice. And in neutropenic and clinically unstable patients, you better start with echinocandins as a first choice of drug. So in deep-seated infections like in bone or CNS or endophthalmitis, combination therapy recently has been tried, though they don't have, now we don't have enough evidence to definitely recommend combination therapy, but they found that there is a benefit using combination therapy with amphotericin B and flucytosine. So invasive aspergillosis is the second most common invasive fungal infection. So in this, pulmonary aspergillosis is the most common form. So typically it occurs in first 2 weeks of, typically occurs 2 weeks after neutropenia or while patient receiving therapy for host versus graft disease. I mean graft versus host disease. They generally present with fever, cough and hemoptysis. The diagnosis is culture, either ball fluid or tissue biopsy. So for aspergillosis, the ball fluid gives better yield than sending a serum sample. And you have non-culture tests like galactomammon test or beta-glucan, PCR, and CT scan can give you the diagnosis of invasive pulmonary aspergillosis. So the treatment, because most of the times the diagnosis of aspergillosis gets delayed because of difficulty in diagnosing it. So, all high-risk patients, the treatment should be based on either clinical or radiological findings, radiological diagnosis. Later, you can confirm your diagnosis with either culture of ball fluid or other diagnostic tests. So, the options are voriconazole, posaconazole and isavuconazole, all three work against aspergillosis, and amphotericin B and echinocandins. So, combination therapy with voriconazole plus echinocandins has been tried in resistant cases because treatment failures are common in voriconazole and the mortality is also high when compared with the invasive candidiasis. And mucormycosis, it has become very popular during COVID times. It's caused by the member of order Mucorales, and the site of involvement depends on the patient risk factor. If the diabetics, generally they develop sinus mucormycosis, and patients with hematological malignancy, they can have either pulmonary or sinus infection. Solid organ transplant patients, they are at high risk of pulmonary aspergillosis, and patients who are on deferoxamine therapy, generally they develop pulmonary, sinus or even disseminated aspergillosis. In premature newborns, GI is the most common, and patients who are on corticosteroids, they are also at risk of sinus infection, paranasal sinus infections. The diagnosis is mainly clinical assessment is important. Imaging, most of the times imaging can easily diagnose the mucormycosis. So the infected parts, you can send it for culture. The non-culture methods are, one is PCR, other one is MALDI top MS. So don't ask me what it is, it's difficult for me to explain. Then the treatment of mucormycosis mainly depends on, one is the rapid initiation of treatment, then reversal of the underlying condition. If it is a DKA or a diabetes, control it. If the patient's on high dose steroids, better to reverse it. So whatever the underlying condition, you should try to reverse it as early as possible, and selecting the appropriate antifungal is very important. And surgical, in addition to the medical management, in mucormycosis, surgical debridement is very much important in curing these patients. So the treatment of choice is liposomal amphotericin B. So now recently isavuconazole and posaconazole were also recommended as a salvage treatment. So now few institutes are trying as a primary line of treatment for mucormycosis. A combination of antifungals, there is no definite recommendations, though they have tried many combinations. So hyperbaric oxygen therapy has been tried with some benefit, and because it constitutes high mortality, the prevention is very important. So whenever you are prescribing either corticosteroids or desferoxamine, be careful, do not use unnecessarily. Whenever you use the right dose, high dose corticosteroids are responsible for most of the fungal infections. If you identify the patients who are at a high risk for mucormycosis, so they are in the ICU, so they should be supplied with the HEPA filtration air. So to summarize, we have to recognize that the invasive fungal infections are on rise, and they constitute nearly 10% in many of the ICUs, 10% of sepsis patients of many of the ICUs. And in comparison with bacterial sepsis, fungal sepsis constitutes higher mortality, and invasive candidiasis is the most common form, and invasive aspergillosis is most common in patients with hematological malignancies. Diagnostic tests are expensive and limited to tertiary care centers, and cultures of fungi takes much longer time, and waiting for cultures to start the antifungal therapy may result in poor outcomes. So big jolt was empirical study which said that empirical antifungal treatment does not give any much benefit, but still you should use it, empirical antifungals, and patients are really at a high risk. Then newer antifungal drugs with better safety profile are coming into the market. So we hope for the better future in invasive fungal disease causing sepsis. Thank you very much.
Introduce our renowned speaker, Dr. Harshita ma'am, Consultant, Department of Internal Medicine, Amara Hospital, Tirupati.
Good afternoon, one and all. So our next topic will be care for the vulnerable. Among the vulnerable group, we have chosen neutropenic sepsis and its management. And I would like to invite Dr. P. Harshita Reddy, who is a general physician, to speak about this topic. Over to you, ma'am.
Last to the Thank you for the introduction, sir. I would like to thank my ICU team, Dr. Shankar sir, Dr. Radhika Garu, and the other team for giving me this opportunity. It's actually a privilege, and it's my first talk, and it's a good day because the thought was there a couple of months back, and to bring it forward and to initiate this session is very important for the hospital, and especially for me. Thanks for considering me a part of the faculty. And they have given me a very precise and important topic today. It's neutropenic sepsis, presiding neutropenic fever. Coming to the topic, neutropenic sepsis is different. It's a different ball game because it's a medical emergency per se. A lot of people who are on chemotherapy drugs, they would end up like having fever, and sometimes they land in sepsis, coming to emergency. So sepsis is the severe form of neutropenic fever. We all know that neutrophils are part of innate immunity. They are the first line of defense mechanism. So usually they they are useful for inflammatory response as a first line. So in case of people taking chemo, the inflammatory response is minimized or less, and that would cause this fever and sepsis, and mostly because of the cytotoxic drugs. And there is a theory behind it saying that people on cytotoxic drugs, they have less immune response, and because of that the gut lining will be damaged, and this will cause translocation of the gut microbes like bacteria, fungal, to the other sites, causing this infection. So mostly the symptoms are subtle, and usually they present with fever. And this is a urgent care situation. Usually the situation has to be addressed within the first hour, otherwise the mortality is very, very high. If you look at the definitions per se, the fever, here in the neutropenic fever, the first episode, once the patient comes to ER, the documented fever will be more than 101 degree Fahrenheit or more than 100.4 in the first 1 hour. And the neutropenia per se, absolute neutrophil count below 500 or expected to drop in the next 48 hours below 500. And we call it as a profound neutropenia when the neutrophilic count is less than 100. And if this less than 100 count persists for another 7 days, that's called prolonged profound neutropenia, and they're more susceptible to severe infection and sepsis. So since we know that there is impaired phagocytosis because of less neutrophils. So sepsis, we all know the definition. Because of dysregulated host immune response, it will cause multi-organ dysfunction, which is life-threatening. If sepsis is associated with shock because of circulatory, cellular or metabolic abnormality, the mortality increases. This absolute neutrophil count will say it mild if the count is between 1000 to 1500. The moderate is between 500 to 999. The severe neutropenia we call when the count is between 100 to 499. The profound neutropenia is when the count is below 100. So what increases the risk of neutropenic infections? So this incidence is itself increasing, and because of this chemotherapeutic drug, they are to counter the cancer, the regimens are very intense, the chemotherapeutic regimens. Because of the intense regimens, the incidence is increasing, and people who has mucositis post chemotherapy, they are more prone for infections. And again, I said prolonged profound neutropenia with less than 100 count they're more prone for infections. And if they have repeated bone marrow transplantations, they're more prone. And in this population, there is increased use of catheters. All of these are risk factors which increase the neutropenic infection. And again, prognosis here, the important thing is prognosis will not depend on the neutrophil count. Even after treatment, if the neutrophil count increases, if the person still has organ dysfunction, and also depending upon the severity of illness and severity of infection, the mortality and morbidity is still high, though the neutrophil count increases. So this we have to bear in mind. And this is an important part. Evaluation, if you take, we'll start with history taking. So we should always ask if there is any previous episode like this. Apart from that, localizing the symptoms is very important. This we can do by reviewing the systems, different systems. Then nature of chemotherapy, what kind of chemotherapy the patient is on. If they have any documented previous cultures, we should ask about that as well. And if they're already on prophylactic antibiotics while chemotherapy is going on, this information is also important. And if the patient is already on long-term use of steroids, especially more than 3 weeks, these are the basic points which you have to ask. And evaluating the vital signs is very important. And while evaluating review of systems, you should always, these are the spaces which we actually miss. We should examine ears, sinuses, oral and perianal areas, and also IV catheter sites. These are also important. And if the patient had bone marrow aspiration, those sites also have to be examined. And this is important again, review of systems if you take from top to down. Eyes, you have to look for conjunctivitis and orbital cellulitis. These are all the sources. And with ear, nose and throat, you should look for any otitis media, tonsillitis, pharyngitis. Teeth, you should look for tooth caries and abscesses. Chest, you should look for pneumonia. And abdomen system, you should look for enterocolitis, persistent diarrhea or dysentery. When it comes with perineum part, if they can have perianal candidiasis or abscesses. When it comes with skin, cellulitis, abscesses and furunculitis. With CNS, you should look for meningitis, signs of meningitis and meningoencephalitis. When it comes with urinary tract, look for UTI, and also check IV lines. This is again important. You should, while checking the IV lines, you should rule out port infection, tunnel infection and exit site infections. So these are some of the pictures. This is a person who had who was on chemo port and had infected area over there. And this is the mucositis. And this is the catheter related infection, the localized infection. These are the people who have developed infection or mucositis, the severe form of mucositis over the tongue. So the other part is risk stratification. This is important because this will decide whether the patient can be treated on OP basis or IP basis. So we are using one score system called MASCC. It stands for Multinational Assessment of Supportive Care of Cancer Patient. So this is the parameters which they are using in the score. First thing is burden of febrile neutropenia, whether the patient has no symptoms or mild or moderate symptoms. It is given a score of 5, and they are considering hypotension. If the patient is not hypotensive, they are given a good score. And if there is any history of COPD, bronchial asthma, bronchitis, we should rule out. And we should also ask whether they have a solid tumor or a hematological malignancy, and if they had any previous fungal infections. And we should also look for signs of dehydration and what is the burden of the febrile neutropenia with symptoms. And if the patient was came to OP basis or to emergency, and the age below 60 years. So if the score is higher, that is more than 21 or close to 21, they are at low risk and they can be considered treating on OP basis. If the score is below 21, you should consider admitting the patients with IV antibiotics. So score greater or equal to 21 is at low risk. The investigations, these are all the basic investigations. So we are dividing investigations into routines and higher investigations. When you take the routine investigations, we all do CBC, renal function, liver function and CRP. Coagulation screen is a must, and cultures you have to take 2 sets of cultures from IV lines and also peripheral. So 2 sets, 1 set for aerobic and 1 set for anaerobic. Apart from that, you should also collect blood for urine, sputum and stool samples for culture and microscopy. Skin, if there is any breaks or pus drainage, you should aspirate, swab, and also you can do the biopsy of the skin. And chest X-ray or HRCT chest, if the pyrexia is there for more than 72 hours in spite of patient being on antibiotic. Next thing after HRCT, if you still don't get any clue, you can go for BAL. Biomarkers will also help us to identify how severe the bacteremia is. So C-reactive protein, it's not like specific, but usually arises in the inflammatory process. You can see higher CRP in bacterial infection, myelomas and people who are on chemotherapy. Procal will indicate the bacteremia, and higher the procal, higher is the bacteremic load. And pentraxin 3, again higher value corresponds to mortality. These are the fungal parameters, beta-D-glucan and galactomannan. And when they have like persistent diarrhea or dysentery, you have to rule out a Clostridium difficile infection or neutropenic colitis with CT abdomen with contrast, and also have stool examination. In these cases, early BAL, we don't know how early it is, whether the first day of admission or within 24 hours or 48 hours. Early BAL is important because in spite of doing basic investigations, still we cannot get a clue where exactly the source is. At that time, if you can do a BAL, then we can lavage it and send it for analysis. It can give us a clue. So when we are doing BAL, the recent thing which I've learned is if the X-ray is showing any consolidation patch, you should first enter into the other side of the lung and then go to the damaged side of the lung. And on top of all of this, we can also do multiplex PCR for respiratory and pneumo panel. When it comes with the management, once after we use that MASSC score and stratify the patient as mild, low risk or high risk, if the patient falls under low risk with a score greater than or equal to 21, the basic things are, you can start with fluoroquinolones. Usually ciprofloxacin or levofloxacin works well, or to this you can add moxiflox, but if they are allergic to amoxi, then you can use Clinda 600 mg TID with Ciplo. And if they are falling under high risk category, in India, as we all know that gram-negative is prevalent, you can start as a monotherapy with meropenem, higher doses if RFT is normal. It can be given TID. If not meropenem, you can also use imipenem, colistin or cefepime, 2 grams IV TID. If the patient is hemodynamically unstable at the time of presentation, you can also consider starting aminoglycosides, and you can wait for the blood cultures, and after the cultures, if there is no sensitivity to aminoglycosides, we can switch over. Catheter-related MRSA, you have to consider giving vancomycin. If the person has vancomycin resistance, you can consider using linezolid or daptomycin. And if they have a risk of Klebsiella and have a carbapenem resistance, you can use polymyxin with colistin or tigecycline. Usually 50% of the patients having neutropenic fever or sepsis, they land with acute respiratory failure. So in them you can do fibro-optic bronchoscopy or early BAL. NIV use is a must, and the ARDS risk, if persists, you can consider giving granulocyte colony stimulating factor. They say that there is no much role about the granulocyte and monocyte colony stimulated factors, but in cases like this you can try. And when it comes with catheter related bacteremia, This thing is very important. Differential time to positivity. How would you differentiate whether the infection is in the blood or from the catheter associated time? So once you draw the two sets of blood cultures from the peripheral lines and also the catheter, then if the bacteria grows within less than 2 hours from the catheter site, then most precisely it is from the catheter related infection. So it has a high sensitive and specific indicator of catheter related bacteria. The differential time to positivity being less than or equal to 2 hours. If the growth is after 2 hours in the blood, then mostly it could be a blood infection. In case of gram-positive bacteria, you can use Vanco or Tico when it is catheter-related infections. So better thing is to remove the lines, and if persistent bacteremia is present, in spite of giving a proper antibiotic and fever persists even after 4 days of treatment with antibiotics, you can consider ruling out atypical mycobacteria or fungal infections, especially Candida. So, and the other, usually if they have enterocolitis, you have to do stool cultures and also send C. diff toxin. And if they have pneumoperitoneum or hemorrhage in the peritoneum with shock, you can consider surgery and also conservative management with IV fluids, blood transfusions and nasogastric tube suctioning. So these are the other things which you could do to minimize the mortality. And after every 24 to 48 hours, we have to reassess how the patient vitals are and how the infection is. And accordingly, we have to change the antibiotics once we get the first culture. Then if still deteriorating, we should not hesitate asking consultations with ID and microbiologists, clinical microbiologists. And up to here, we have talked about the antibacterials. When it comes with antifungals, we should consider antifungals or ongoing invasive fungal infection if the neutropenia persists more than 7 days and if the fever persists more than 4 days. So, and if we should ask if they were not previously put on antifungals, you can consider giving fluconazole. Already if they were given antifungals before, you can start with echinocandins. So even if the patients are unstable, in spite of fluconazole, you can start with echinocandins. So echinocandins, we all know, before presentation, we talked about caspofungin, anilidofungin and mycofungin. And if they have pulmonary infiltrates in the lung, you can start with oriconazole and amphotericin B. If there is suspected mucor, you can start with the amphotericin B. And these are different scenarios to stop antibiotic or antifungals. So if the first scenario, after giving treatment, if the absolute neutrophil count improves more than 500, patient is asymptomatic and there is no fever for the last 48 hours, then blood cultures come out to be negative. You can stop IV antibiotics and you can convert to orals, or you can stop antibiotics per se. In the second scenario, if the absolute neutrophil count is still below 500, but there are no complications and the patient becomes afebrile after 5 to 7 days of antibiotic course. So here the antibiotics can be stopped, but in cases of acute leukemia, especially AML, myelodysplastic syndromes, you should consider prolonging the course of antibiotics for about 10 to 14 days. And a third scenario, persistent fever despite neutrophilic recovery. So here the absolute neutrophil count more than 500, and you can go for consultations and consider antifungals. So here there is no much role of antivirals, but people who are on steroids for more than 3 weeks, and if the people are taking chemotherapy with the T-cell depleting agents, and if they have profuse diarrhea and pneumonia which is not responding to antibiotics or antifungals, you can consider antivirals at this stage. So usually for cytomegalovirus, we can go with ganciclovir. If they have pneumocystic carinine pneumonia, you can consider trimethoprim sulfamethoxazole as an empiric treatment. If they have varicella zoster and herpes simplex, you can consider acyclovir. And granulocyte colony stimulating factor as a prophylaxis, the helpfulness of this process is not definitive, but you can add with a primary chemotherapy, the first dose of chemo you can consider if the neutrophilic infection risk is more than 20%. In also as a secondary prophylaxis also you can give after the patient, if the patient develops neutropenia or neutropenic fever after the first cycle of chemotherapy. So even in those patients also you consider this as a secondary prophylaxis. Usually we give pegfilgrastim as a single dose 6 micrograms, or you can also give filgrastim 300 micrograms per day. You should stop this when absolute neutrophil count increases more than 1000 for 3 consecutive days. And this is granulocyte transfusion. These are granulomonocyte colony stimulating factor prophylaxis, but this is granulocytes per se we are transfusing. So this can be done by from a donor. You collect you give dexamethasone, that is steroid, to the donor. Because of the steroid, the granulocytes will increase in the donor blood. So you collect the donor blood and you do apheresis. You get a buffy coat, and the buffy coat is rich in plasma and the WBC. That buffy coat can be given to the after irradiation, it can be given to the recipient. And after this, the granulocyte transfusion continues again till absolute neutrophil count increases more than 500 for 3 consecutive days, or resolution of the sepsis episode happen. And the next one is neutropenic fever precautions. This is a must. It's a preventive measure, and you can isolate the patient. You can isolate the patient in well-sealed room with laminar flow, and you can insert HEPA filters. We have to use N95 mask, and prohibition of the organic material near the patient it should not be practiced. And this is the final checklist. This is like a take-home message again. So you should identify and treat sepsis, and it has to be treated within the first hour of presentation to avoid high mortality. Obtain 2 sets of blood cultures from center and peripheral lines. Assess the risk, whether the patient is at low risk or high risk, using that MASSC score, and start appropriate empiric antibiotics in the first 1 hour. Consider additional diagnostic workup based on likely source. Identify and control the source of infection. Start supportive care. Urinary catheters and other lines, if they are infected, has to be removed. Neutropenic precautions, it has to be started from the time we see the patient. And hemononc opinion and infectious disease consultations are a must if we are not able to control the sepsis and the infection. ICU transfer if the patient hemodynamics are unstable. Thank you.
I request Dr. Vishal sir to present mementos to Dr. Rakesh sir and Dr. Rajesh sir. I request Dr. Vishal sir to present mementos to our Dr. Rakesh sir and Dr. Rajesh sir, Department of Anesthesia, Amara Hospitals. Thank you, sir. Now I request Dr. Shankar Garu and Dr. Arun Raja Garu to come on the stage and present a memento to Dr. Pradeep Garu, Professor, Department of Anesthesia, Birds Hospital, our today's APMC observer. Thank you, sir. Thank you to all the chairpersons and speakers. So without taking a pause, let's move on to the next session. I would like to invite our chairpersons of this session, Dr. Anand Garu, Senior Consultant, Department of Neurosurgery, Amara Hospitals, Dr. Srinivas sir, Senior Consultant, HOD, Emergency Critical Care, Apollo Hospitals, Dr. Kishore Garu, Consultant Neonatologist, Amara Hospitals, Dr. C. Srinivasul Reddy Garu, HOD, Department of Emergency Medicine, KIMS, Bolineni Hospitals, Nellore. Let's have a huge round of applause for all our chairpersons.
A small announcement. I would like to request Dr. Madan Mohan Reddy sir to come onto the stage and announce the new committee of ISCCM.
ఇదేనా దీంట్లో ఉందా నేను జనరల్గా అనౌన్స్ చేసి ఓకే నెక్స్ట్ the Tirupati ISCCM chapter has selected a new executive from this month. They were elected unanimously. So I would like to announce that Dr. Hari Krishna, Senior Physician from SWIMS, has been elected as Chairman for ISCCM chapter. Dr. Rana Pratap Simha has been elected as Secretary for ISCCM Tirupati. Dr. Shankar, Critical Care Physician, Amara Hospitals, has been elected as Treasurer for ISCCM Tirupati. I congratulate the new team and I wish them all the best. and I wish they continue the academic activities and for the next 1 year. Thank you very much.
Now I request Dr. Anand VK sir to introduce our speaker, Dr. J. Harikrishna sir.
Good evening all. Dr. Harikrishna is a professor of medicine in SWIMS Tirupati, and he is a distinguished author, and he has published 23 in journals, publications in industry journals, and he has written 8 book chapters, and he is a member of WHO RNTCP and delivered O.A. Sharma Endowment Lecture in 33rd Andhra Pradesh and TB and chest disease conferences. His main interesting are hemodynamic monitoring, mechanical ventilations and infectious diseases. I kindly request Dr. Hari Krishna to proceed.
A very good afternoon to all of you. I thank the chairperson for his kind introduction, and I would like to thank the organizers for giving me this excellent opportunity to speak with you. As a post-lunch session, it's difficult for any speaker to keep everybody awake. I'll try my level best. My topic is not so overburdened. It's just simple topic, tropical fevers or tropical infections in intensive care unit. So my first question is, why tropical fevers are so important to us? Because tropical infections lead to severe life-threatening illness and require ICU admissions, and they constitute 20 to 30% of ICU admissions in India. In monsoon and post-monsoon seasons, it may reach up to 50%. And
Small announcement, I request Dr. Ravi Prakash Garu to come on the stage and join as a chairperson. Sorry for the interruption.
And the recently published INDICAPS 2 study has shown that 12% of ICU admissions in India are due to tropical fevers, and it is associated with a mortality of 20%, which is huge. If we identify these at early stages and use appropriate treatment, we can prevent these, at least we can reduce the mortality. So this is the most important learning point for today. The overlapping clinical picture makes the initial diagnosis challenging. Usually, not only the clinical presentations of tropical fevers is confusing among themselves or overlapping among themselves, it overlaps with the other infections also. So whenever we see a patient with fever or infection, either in our wards or ICUs, our first idea is to find out what is the diagnosis, where is the focus of the infection or focus of the fever. In that situation, we would like to look for either in the history or examination for focal clues. Likewise, whether patient has any signs or symptoms suggestive of respiratory tract involvement, or any signs symptoms of abdomen, or signs symptoms of urinary tract infection, or any cellulitis, any neurological symptoms suggestive of meningitis or encephalitis, like that. But unfortunately, all these tropical fevers have certain symptoms which overlap with other infections. For example, we see sore throat. If somebody has a sore throat and fever, what we usually think, it's a pharyngitis, viral or bacterial. But unfortunately, leptospirosis is associated with sore throat. And if it is cough, if you see a patient with cough and fever, we usually think of it's a respiratory tract infection. But scrub typhus and leptospirosis are associated with cough. So if we think like that, we may miss sometimes. So we have to keep these things in our mind whenever we are evaluating our patients. Likewise, abdominal pain and diarrhea, it overlaps with the tropical fever symptoms. So delay in the diagnosis and treatment will further worsen the outcome, because the treatment for the other conditions and tropical fevers is sometimes differs. So it is essential for all critical care physicians to be familiar with the presentation, diagnosis and management of tropical infections. Over the next 20 minutes, I am going to discuss about these things. So second question is, what are the tropical infections? So the infections that are prevalent or unique to tropical regions are collectively known as tropical infections. So what is this tropical region? It is the area that is on the either side of the equator in between the Tropic of Cancer and then Tropic of Capricorn. So this is called tropical region. Why this region is, these tropical infections are confined to this region? I think all of you agree the climatic variations in these areas are very less. All of you agree with me that in Tirupati we have only 2 seasons, summer and severe summer. So if you go to Delhi, the temperature variation is so much. In summer you see 40 degrees and in winter it goes to 2 and 3 degrees centigrade also. But as you go closer to the equator, these variations are limited, which is favorable for both for the organisms and for the vectors of these tropical diseases to proliferate and to survive. This is the reason certain infections are more prevalent in these areas. They are called as tropical infections. So they are malaria, scrub typhus, dengue, leptospirosis, enteric fever, diarrheal diseases, chikungunya, Japanese encephalitis, melioidosis, viral hepatitis, so on and so forth. But today I am not going to discuss about all these things. What is more common to us, we will discuss. Apart from that, diarrheal diseases and encephalitis and meningitis. So the Indian studies which are done in India has shown that the common tropical fevers in our area or India are dengue, followed by scrub typhus, meningoencephalitis. These are the patients admitted to ICU. Malaria, followed by leptospirosis, viral hepatitis, and typhoid is the last one. Usually we consider it as the first diagnosis, but proved enteric fever, either in the form of the blood culture or bone marrow culture, over the past 2 years I have seen 2 to 3 cases. Proved, I am not talking about the other methods of diagnosis. So likewise malaria also, we see decreased incidence of malaria. Maybe I may be biased because I work in a tertiary care institute and malaria patients may not be coming to me. Because we compared to 10 years earlier, nowadays we are seeing a less number of malaria cases. We see more of dengue and scrub typhus. So how to approach these patients with tropical fever? As these patients get admitted with various organ dysfunctions, initial stabilization is the most important step, followed by a focused history and examination will give some clues to us to differentiate from the other infections and to differentiate among the other tropical fevers among themselves. So when it comes to the history pattern of fever, one thing, it may not be reliable because everybody will take paracetamol on their own. But when it comes to malaria, if it is Plasmodium vivax, it may be tertian, and it's Plasmodium malaria, it may be quartan fever. But in falciparum malaria, this pattern of fever may not be there. It is associated with shaking, chills and rigors. Another important point is saddleback fever, which is seen in dengue. The saddleback means here you see initially fever will be there for 3 to 4 days, then there will be decrease in the intensity of fever, then again after 1 or 2 days fever again increases. This is the saddleback fever. The saddleback fever is seen in dengue and also in influenza. And another thing, most important thing is fever by lysis and fever by crisis. Fever in, for example, malaria, leptospirosis decreases within no time with treatment, especially in scrub typhus. If you give appropriate treatment, fever will come down in 24 to 48 hours. On the contrary, in patients with enteric fever, fever comes down by fever by lysis. Even if we give appropriate therapy, it takes 4 to 5 days for the fever to come down. We have to keep this in mind, otherwise we keep on changing the antibiotics. We may not have blood culture susceptibility reports for that. So if fever continues for more than 12 days, dengue is less likely. If somebody, we get a patient with fever of 10 days, 12 days, fever would be less, dengue would be less likely in those patients. And if the fever is associated with retroorbital pain or pain while moving the eyes or severe low back ache, generalized diffuse body pains which is called breakbone fever, dengue is most probable diagnosis. And sometimes dengue is associated with warning signs like severe abdominal pain, persistent vomitings, signs of third space losses like edema, facial puffiness, abdominal distension, bleeding manifestations and those things. And severe arthralgias may favor a diagnosis of chikungunya. So in the same study which I have quoted previously, they have, this is the most important slide of this talk. So they analyze the presenting symptoms in the patients with tropical fever. If you see here, diarrhea is seen in almost 10% of patients. When it is diarrhea, we feel that it may be a focus of infection is in the abdomen, but it is seen in second week of enteric fever, in algid malaria associated with diarrhea, shock, secondary bacterial infections, and scrub typhus and dengue also sometimes presents with diarrhea. And when it comes to cough, 30% of patients with scrub typhus, 25% of leptospirosis patients, and 25% of enteric fever patients will have cough as a presenting symptom, and not presenting symptom during the course of the disease. So seizures may be seen in cerebral malaria and scrub encephalitis. But how to differentiate these from the other diseases? So usually in these patients, if it is a respiratory tract infection, usually they will present with fever. Within 1 or 2 days they may develop cough. But in these tropical fevers, they get cough later in the course of the disease, like 5th day, 6th day. So that is one clue. It's not always absolute. This is the one clue which makes you to think that it's not looking like typical respiratory tract infection, though patient has cough. We need to think about tropical fevers. So travel history, for example, if you see this picture, malaria is more common in the Chhattisgarh, southern parts of the Chhattisgarh and Orissa area and Vizag. If somebody travel to those areas, if they come back with a fever, we need to suspect malaria in those patients. Recreational activities like trekking, when they go to these areas, these are called shrubs, which are small plants. These are more favorable for the growth of mites, thrombiculid mite, which is the mite through which the scrub typhus is transmitted from thrombiculid mite to humans. So this is the chigger. It bites these chiggers are there on these scrubs. Whenever we come into contact with that, it transmitted to us through that Orientia susugamushigi is transmitted to us. So it won't bite actually. It secretes a certain digestive enzymes which makes the tissue digested. It will suck it. So to cause the inflammation, it takes 48 hours almost by the time infection would get transmitted to us. So then swimming pools in the lakes, most common is leptospirosis, drinking unclean water or environmental changes with floods like leptospirosis, and if mosquito bites, there may be dengue, malaria or Japanese encephalitis are the possible diseases. And when it comes to rash, eschar is the most important, which if you find eschar, it is pathognomonic of scrub typhus. So what are the areas we should look for eschar? The tight areas, tight clothing areas, which is more common, which is above waist in females and below waist in males. And the studies have shown that eschar is seen in 30% of patients with scrub typhus, but studies from South India, especially from Vellore, have reported almost 50% of patients with scrub typhus will have eschar. So as morning Aladi Mohan sir pointed out, sometimes to these shrubs they may go for open defecation. This we see sometimes around the perianal area, these eschars. Just one simple clinical finding which changes your diagnosis. So these are the common areas where we should look for eschar in scrub typhus. And another thing is diffuse branchable erythematous rash, and I think you can see the islands of sparing here, which is classical of dengue fever rash, which is seen in 2nd to 5th day of the fever. And sometimes maculopapular rash is seen in scrub typhus and dengue. The most important point is the rash associated with tropical fevers is non-proratic. If you see a proratic rash, you should suspect some other diagnosis rather than tropical fever like viral exanthemas or drug-induced fever. And rash is less likely in malaria and generalized rash is less likely in enteric fever. So we can see on examination anemia in malaria and leptospirosis. Subconjunctival hemorrhages and subconjunctival suffusion and deep icterus are suggestive of leptospirosis. And coated tongue, rose spots favors the diagnosis of enteric fever. And one simple test which is called tourniquet test or Hess test, which I insist all our postgraduates to do whenever a patient presents with short febrile illness. Just by doing this test, it's because of increased capillary fragility. We see more number of petechiae when we apply tourniquet or cuff, rivaroxy cuff to the patient. And within 1 inch area, if there are more than 20, more than 10 are there, 20 are there, it's positive test. So it indicates more capillary fragility and it is suggestive of dengue. If you see leukopenia and Hess test positive, it increases the odds ratio of dengue fever by several folds. So then relative bradycardia is seen in enteric fever and scrub typhus. Lymphadenopathy is common in scrub typhus. Predominantly hepatomegaly is seen in leptospirosis and predominant splenomegaly in malaria and typhoid. And especially muscle tenderness, which is more common in leptospirosis because of myositis in these patients. So then how to approach this patient? Because of till now we have discussed the symptoms are overlapping and immediate non-availability and non-feasibility of specific test, which may lead to delay in the diagnosis and start of definitive therapy. So this led to the proposal of a syndromic approach, which helps in narrowing the differential diagnosis and start of appropriate empirical therapy to our patient. So the syndromic approach includes fever with respiratory involvement, fever with renal involvement, neurological syndromes, cardiovascular syndromes and shock. So when it comes to respiratory involvement, pneumonitis with pulmonary infiltrates is common in scrub typhus. ARDS picture is seen in 25% of patients with leptospirosis, 10 to 15% of patients with malaria. So whenever we see ARDS in our patients, especially in our tropics, we should strongly suspect tropical fevers in these patients. It's majorly because of endothelial injury and capillary leak. Pulmonary alveolar hemorrhages are seen in leptospirosis and hantavirus infections. And when it comes to renal failure, it is seen in all leptospirosis, malaria, dengue and scrub typhus. What I want you to emphasize is interstitial nephritis is seen in leptospirosis, which is predominantly non-oliguric. In other types of infections, the renal failure is oliguric. So then when it comes to neurological syndromes, as we all of us suspect, if patient presents with altered sensorium, seizures or focal neurological deficits, a viral or bacterial meningitis, but it is seen in all tropical fevers also. So it is associated with malaria, it is associated with leptospirosis, aseptic meningitis seen in the later immune phase of anicteric leptospirosis. Scrub typhus, encephalopathy is very common in leptospirosis, but it is rare in dengue fever. So if you see a patient with severe thrombocytopenia, with bleeding manifestations, signs of third space losses like facial puffiness, pedal edema, and a blanchable rash with islands, and encephalopathy, in spite of other organ dysfunctions, jaundice and renal failure, sensorium is relatively preserved. It should suggest dengue fever. So like enteric encephalopathy can happen in the 3rd week of enteric fever. So like cardiovascular syndrome and shock, the important thing which we need to observe here is what is the systolic and what is the diastolic blood pressure. If there is narrow pulse pressure, then we should think of either hemorrhage or hypovolemia or myocarditis. When this narrow pulse pressure shock is not responding to fluid challenges, we need to think of myocarditis, which is seen in dengue, leptospirosis and scrub typhus also. And if there is a wide pulse pressure, it is suggestive of septic shock. So investigations are very useful, non-specific, the routine investigations useful in come to a reasonable diagnosis like leukopenia, thrombocytopenia, hemoconcentration, elevated transaminases, which favors the dengue. And severe thrombocytopenia is seen in dengue. I'll take just 3 more minutes. And this is when it comes to LFT, in spite of increased AST, ALT levels, normal bilirubin is seen in dengue fever. The investigations, so whenever we want, when it comes to serological investigations which are immediately available to us, we need to have at least either seroconversion or fourfold raise in the antibody titer to definitely diagnose those infections, which is not possible for us, which becomes retrospective, which may not be useful for us immediately to treat the patients. So what I observe regularly is to do this, all these antibodies on first day, second day and third day of these tropical fevers. By the time there will be no production of IgM antibodies, at least it takes 5 days to second week for the development of these antibodies. So whether you do it or do not do it, it's okay, but how to interpret it? If you do it in the first day, second day, and again that is negative, and again you have repeated it on the second week, if it comes positive, that is seroconversion, that favors your diagnosis. But if you do it in the first week, getting a positive test result is less likely. Even if it comes positive, it is very non-specific or false positive things are more common. And when it comes to scrub typhus IgM ELISA will be positive for almost 1 year, especially in endemic areas. When it comes to Leptospira IgM, false positives are very common in Leptospira IgM. This is also will be positive for few months in patients with leptospirosis. So when it comes to management, as scrub typhus, malaria, enteric fever, dengue, these are the leptospirosis, these are the more common tropical fevers. As our patients are very sick, we have to start definitive therapy as early as possible. Better to start empirically these patients on doxycycline, ceftriaxone or a beta-lactam with beta-lactamase inhibitor and artesunate. In our clinical practice, we are not routinely starting artesunate because we are not seeing malaria so commonly, and at the same time we have a quantitative Buffy coat analysis. The turnaround time is 2 hours only. By 2 hours we will, which is very sensitive test, we will come to know whether malaria is there or not. This is the last slide of my presentation, which is the results of the INTRUST trial published in NEJM, and our SWIMS is one of the trial site for this study, and it has shown that combination therapy with azithromycin and doxycycline is better in severe scrub typhus patients compared to either doxycycline or azithromycin alone. That's why all patients admitted to ICU with scrub typhus, we use combination therapy both with azithromycin and doxycycline. So the take home message is, don't get deceived by overlapping manifestations. Identification of subtle differences in manifestations is useful to come to a differential diagnosis. Syndromic approach is very useful in tropical fevers, and ARDS, tropical fevers are the important cause of ARDS in our ICUs, and early treatment is life-saving. I thank you very much for your patient listening.
Thank you for the insightful and thought-provoking presentation, sir. Now I request Dr. M. Srinivas, sir, to introduce the next speaker, Dr. V. Arun Raja, sir.
Good afternoon. I thank Dr. Shankar and his team, the management of Amara Hospital, for giving an opportunity to chair this session. I welcome Dr. Arun Raja, MD Medicine, DM Pulmonary Critical Medicine, and a consultant at Amara Hospital. And his achievements has a good paper awards in Epicon 2013 and APCON 2023, and he has 12 publications and 5 chapters in his name. And his area of interest is pulmonary infections, critical care, and interventional pulmonology. As we all know, the misuse and overuse of antibiotics is a major concern of antimicrobial resistance. Let's hear from Dr. Arun Raja about the debunking of myths and misconceptions of antibiotics. Over to Dr. Arun Raja.
Thank you, sir. Thank you for your kind introduction. At the outset, I'd like to thank the scientific committee for having me over here. Full screen. So today I'll be talking about myths and misconceptions about antibiotics. So this is how it started versus how it is going. So this is actually the patient, she was seen in 1943 at Mayo Clinic when patients were actually started treatment on penicillin, within 7 to 9 days, actually patient has completely recovered. So this was in 1943. This was a first published report on penicillin effectiveness. And if you see the power of antibiotics when compared to myocardial infarction, the treatment of myocardial infarction with aspirin and fibrinolytic drugs had only 3% change in death after the introduction. Compared to the power of antibiotics, if you see, it has a major reduction of 30 to 70% reduction in the deaths after the invention of antibiotics. So right now how it is going, for every 45 seconds, one patient is dying because of antimicrobial resistance, and it is projected that by the year 2050, 10 million people will die actually because of antimicrobial resistance. So handle your antibiotics with care. So this was one of the surveys in which they have done that in 100 patients they have seen, their patients have responded that 45% of the patients stopped the treatment too early. When asked, they said that they got better, so they stopped the treatment. And 74% of the respondents have kept the leftover prescribed antibiotics, and among them 51% intended to use it for further use. And 28% of the respondents reported prior use of antibiotics from previous prescriptions also. And this is one of the most common myths: finish your antibiotic course. So this was first actually proposed by WHO in 2016 in the antibiotic awareness. It says that previously they thought that you should finish the antibiotic course because the longer duration of antibiotics actually reduces the chance of drug resistance. That was the concept previously actually. But the present concept says that once the patient is stable, always you can de-escalate the antibiotics for oral, or you can completely stop the antibiotics also. And also, if the patients are given more time of antibiotics, there is a chance that the body, drug resistant organisms will increase because of previous exposure to the antibiotics. That organism may get selected and it may reproduce. So finish your antibiotic course is a myth. And always assess the patient's response to therapy, and there is also no fixed number. 3 days, 5 days, 7 days, 10 days, there is no fixed number. Always assess the patient's response to therapy and you can happily stop the antibiotic. And antibiotics alone can cure infection. This is one of the myths. And always think of source control in sepsis. And always try to address other factors which are promoting the infection, like uncontrolled sugars. If the patient is on immunosuppression, try to stop the immunosuppression. And if you think that there are infected catheters and biofilms responsible for the infection, please try to take it out. And always rule out viral and fungal infections before you think that patient is not responding. And the other myth is broad spectrum is always better. So if you see, it may be better for some of the things, but if you see the most common thing like MSSA bacteremia, if we use vancomycin, the chances of mortality were high than when compared to using only cefazolin alone. So it is always a myth that broad spectrum is always a better. And one more myth is longer course of antibiotics is better. So this is actually, I have taken these slides from Brad Spielberg. He actually does this work of collating data on oral antibiotics and the duration of antibiotics. If you see for 23 conditions, even the duration of antibiotics, if you use for short-term period or even for long-term period, both the results were equal. So shorter is better for all these conditions. You should always remember there are some exceptions. One being prosthetic joint infections, otitis media in children, and streptococcus sore throat. These are only certain exceptions that you should remember. And the other myth is IV antibiotics are always better other than giving oral antibiotics. So this is also a myth. He has also collated all the data. Even for osteomyelitis, he has used oral antibiotics. For intra-abdominal infections, even for bacteremia, even for endocarditis, and for complicated UTIs. Patients who were put on oral antibiotics fairly same, they had both performed equally better. And you should remember these clindamycin, ciprofloxacin, doxycycline, these drugs have very good bioavailability. And so the mantra should be oral is the new IV. Whenever the patient is clinically stable, always try to de-escalate from an IV antibiotic to an oral antibiotic. Or you can also think of starting an oral antibiotic if the patient is not so sick. And another myth is bactericidal agents are better than bacteriostatic agents. So the concept of bactericidal and bacteriostatic is very non-specific. Actually, it depends upon a lot of in vitro studies and lab tests, which may vary from lab to lab. And patients may not, the bacteria may not behave like samely in vitro and in vivo. They have actually defined like bactericidal as MBC by MIC more than 4, and for bacteriostatic as MBC by MIC ratio less than 4. To put it in simple terms, bactericidal is something which kills actively dividing bacteria, and bacteriostatic actually doesn't kill, but they decrease the growth of bacteria. But per se, this concept itself is wrong, and people say that you shouldn't, the old school of thought is you shouldn't combine bactericidal plus bacteriostatic, because bactericidal drugs act on rapidly dividing bacteria. If you are giving a bacteriostatic drug, the bacteria will actually not stop dividing, so bactericidal drugs won't act. This was the previous concept, but right now, what they say is even some of the drugs, they can behave as bactericidal for some organisms and bacteriostatic for some organisms because of the in vitro and in vivo nature. And these are the usual bactericidal agents and bacteriostatic agents which you should remember. This is a general set, but strictly speaking, if you see polymyxin B, TG-cycline, they are using for all the multi-drug resistant organisms, TG being a bacteriostatic drug. Even if you see the usage of linezolid, which scores equally better with when compared to vancomycin for MSSA bacteremias or for skin and soft tissue infections. So the usage of combination of bactericidal and bacteriostatic drugs is also a myth actually, and also there are strictly no things like a pure bactericidal drug or a pure bacteriostatic drug. And antibiotics must be changed if there is no response. As the previous speaker Dr. Lalita said, always rule out the other causes of infection. Always think of non-infective causes first, and then if there is, like if the patient has pneumonia, the patient is not responding, always think of complications of pneumonia like empyema before labeling the patient as not responding and changing the antibiotics rapidly. Another thing is antibiotics with the lowest MIC among the culture sensitivity report should be used. So MIC only tells that whether the antibiotic is susceptible or resistant depending upon the break point. So using the MIC of different antibiotics to compare and take a decision is a wrong thing. So many people think that lowest MIC, whichever the culture sensitivity report is, we should use it. So that is also a myth. And this is one of the most common things which we see, double anaerobic coverage. You see, there are many antibiotics which have intrinsic anaerobic activity, meropenem, piperacillin-tazobactam, cefepime-zidebactam, even cefoxitin, cefotetan, amoxiclav. If you are giving these antibiotics, please do not add metronidazole. The most common thing we see in the prescriptions is meropenem plus metronidazole for every infection. So always, most of them have this anaerobic coverage. There is only very limited evidence to use a double antibiotic coverage, like extra addition of an anaerobic agent. And if you see, the double antibiotic coverage has, in intra-abdominal infections, they have increased mortality than a single antibiotic agent. And the most common myth is if the patient is sick, we will start him on Ceftazidime-avibactam. That is the drug and it will take care of everything. This is also a myth. It is active against ESBL, AMC and OXO48, but it is not active against anaerobes. If you are treating an intra-abdominal infection with Ceftazidime-avibactam, please add an anaerobic coverage. And also it doesn't act on Acinetobacter. If you're thinking of a VAB, your Zavicefta will not act. And also Strenotrophomonas, even for gram-positive also, this has no coverage. Even for the MBLs like the NDM, you should always treat it with addition of azithromycin, which should be administered simultaneously. Another myth is tetracyclines should not be used in children. Actually, the recent AAP has cleared that in patients, if you are using for less than 21 days, tetracyclines can be used. And linezolid has renal dose modification, no renal dose modification. The package insert usually mentions there is no renal dose modification, but the studies have shown that in patients with renal dysfunction, if you use the same dose of linezolid, 600 mg BD, patients will have increased incidence of thrombocytopenia and bleeding manifestations. So if the creatinine clearance is less than 30, please limit your linezolid dose to 300 mg. And this is the most favorite myth among all of them. Ferropenem is an oral carbapenem. So this has been popularized by the marketing gimmick. In 2010 to 2015, there was a rapid increase in ESBL because people thought that ferropenem is an oral form and they started using left and right. If you see the chemical structure, this is the carbapenem and this is the ferropenem. Ferropenem belongs to penum group of antibiotics. It doesn't belong to the carbapenem group. It belongs to the penum group. There is only one chance, that is the sulfide group is the extra addition in ferropenem. Because of structural similarity, if you abuse using ferropenem, patients may develop carbapenem resistance in future. That is what it is happening. And aminoglycosides are useful in abscesses. So aminoglycosides require aerobic environment to activate it. And in abscesses, because there is there is acidic pH, aminoglycosides will not act. So aminoglycosides will not be useful in abscesses. And for UTI, actually, do not treat asymptomatic bacteriuria. When you are suspecting infection, if you are sending urine culture, please send urine routine microscopy with it. Please make sure patient has pyuria, and then you only treat the cultures. And same occurs with nitrofurantoin. Nitrofurantoin is a good drug which acts on cystitis. But if you give nitrofurantoin, is intrinsically resistant against protease because it produces urease. In alkaline environment, nitrofurantoin will never act. If you see a prescription which contains nitrofurantoin with alkaline citrate like citralka syrup, this actually increases the urine alkalinity and nitrofurantoin will not act. This is as good as giving no antibiotic. And the most important thing which I want to share here is there are many unorthodox beta-lactam and beta-lactam inhibitor combinations which are never US FDA approved. These are available in India and China. So most of them being like the ceftriaxone, sulbactam, EDTA, whatever you want, you can add a sulbactam and a tazobactam and you can market it actually. But these all combinations, they never had a pre-drug studies. Because when you combine a beta-lactam and a beta-lactam inhibitor, it is always important that what ratio you should combine, and they should do a pre-drug study and then they should actually go for approval. But because we don't have strict norms in India, any combination can be used. If you see the MICs of all these agents, they are more than 128 and 64, meaning they are not useful for Enterobacteriaceae. And here you see surprisingly meropenem sulbactam has a slower MIC. That is possibly because of the meropenem itself, not because of the addition of sulbactam. So never use these unorthodox beta-lactam and beta-lactam inhibitor combinations. Usage of them is increasing your resistance. And I really wanted to emphasize on this fact. Do you really believe that physicians don't know you shouldn't treat asymptomatic bacteriuria, or the surgeons don't know when to start an antibiotic? It's not that we are all educated, we know everything, but antibiotics are the most potent drugs which actually act on prescriber's mind. If I write an antibiotic, the antibiotic acts on my mind. I think that patient is sick, I write Zavicefta or Ceftazidime-avibactam. I think that I am safe, okay, patient is stable now. That the antibiotic acts on my mind, it doesn't act on the patient's thing. So when providers are afraid, they act instinctively and the antibiotic soothes their fear. So fear cannot be actually overcome by rational education. So if I requested an IDF specialist or an intensive care that my patient is crashing, or I wanted vancomycin, please add, or I wanted polymyxin B, please add, my patient is sick. If they say if they deny it, the symptoms of antibiotic restriction, they actually resemble that of an opioid withdrawal. You will have anger, tachycardia, diaphoresis, tremulousness, cursing, and diarrhea of the mouth and potential violence also. So thank you for this opportunity. Thanks a lot.
That was a wonderful presentation, sir. Your words were not only informative but also truly inspiring. Thank you for sharing your knowledge and experience with us. Now I request Dr. Anand sir, Dr. Srinivasulu Reddy sir to kindly present a memento to Dr. Harikrishna sir as a token of appreciation. Now I request Dr. M. Srinivas sir, Dr. Kishore sir, Dr. Ravi Prakash sir to kindly present a memento to Dr. Arun Raja sir.
Now I request Dr. Pradeep Reddy Garu to come to the stage, Consultant, Department of Neurology, Aster Narayanadri Hospitals. I request him to present a memento to Dr. Anand Garu and Dr. Srinivasul Reddy Garu. I request Dr. Pradeep Reddy Garu to come on the stage. Okay. I request Dr. Gauri Priya Garu to come on the stage, Consultant, Department of General Medicine, Ashraya Hospitals, Chittoor. I request Dr. Gauri Priya Garu to present a memento to Dr. M. Srinivas Garu, to Dr. Ravi Prakash Garu and to Dr. Kishore Garu. I request Dr. Gauri Priya Garu to present a memento to Dr. Ravi Prakash Garu, to Dr. Anand Garu, let's have a huge round of applause for Dr. Anand sir. I request Gauri Priya ma'am to present a memento to Dr. Ravi Prakash Garu. I request Dr. Gauri Priya Garu to present a memento to Dr. Srinivasul Reddy sir. I request Dr. Gauri Priya ma'am to stay back and present a memento to Dr. Kishore Garu. Thank you so much, ma'am. So, looking forward for any queries regarding the presentations. If you have any questions. Okay, thank you so much. Anybody, any questions? Thank you so much. Moving on to the next session. Thank you so much. Thank you to all the chairpersons, all the speakers.
With this, we conclude the current session. We now move on to the next session. I would like to introduce the honorable chairpersons for this session. Dr. P. Sunita ma'am, Assistant Professor, Department of Nephrology, SVRRGG Hospital, Tirupati. Dr. S. Munikrishna sir, Consultant Surgical Gastroenterologist, Amara Hospital, Tirupati. Dr. J. Praveen Kumar sir, Assistant Professor, Department of General Medicine, SVRRGG Hospital, Tirupati. Dr. V. Sunil Kumar Reddy sir, Consultant Onco Anesthetist and Critical Care, Sri Venkateswara Institute of Cancer Care and Advanced Research, Tata Cancer Care, Tirupati. And Dr. Lalita Priya ma'am, Consultant Intensivist, Department of Critical Care, Amara Hospital, Tirupati. First speaker, Munikrishna sir. Now I request Dr. Munikrishna sir to introduce our first speaker, Dr. Rana Pratap sir.
Thank you everyone for the opportunity given to me. Now I request Dr. Rana Pratap Simha, MD Anesthesia and FIDM and IDCCM board member. He is a chief intensivist and anesthetologist at Spurs Hospital and a good friend of mine, and I give that as to him to continue.
Yeah, good afternoon, one and all. And coming to my topic, biomarker. Biomarker is a detective searching for clues. The doctor searches for the biomarker. A biomarker describes a measurable indicator of biological status in normal and pathogenic process. And a biomarker is any substance or any structure or process that can be measured in the body or its products and influence or predict the incidence or outcome of a disease. The biomarkers are majorly 5 types. They are diagnostic, prognostic, monitoring, predictive and safety. The diagnostic ones are, they helps in the identifying the disease like that of troponin in myocardial infarction, and the prognostic ones predicts the likely course of a disease like that of our procalcitonin in sepsis, and predictive ones indicate response to a specific therapy like that HER2 receptors in breast cancer, and the monitoring is tracking the disease progression or the treatment we have given, treatment efficacy, that is HbA1c in diabetic. The safety biomarkers indicate the toxicity or adverse effects of the treatment. Coming to the sepsis, it is a pathophysiologically, as already we discussed in the morning, PAMPs, that is the pathogen associated molecules, and DAMPs, damage associated from the tissue cells, they bind to the PRR or NRR receptors and they activate signaling pathways which trigger the immune response. And the immune response stimulates the liver to produce acute phase reactants like CRP, procalcitonin, SAA, fibrinogen, etc. We measure these proteins and these liposaccharides, and they can assist us in diagnosing and treating the patients. These products result in inflammation and sepsis progression. Mainly, sepsis progression depends upon the inflammation, disrupting the inflammation, coagulation, endotheliopathy, and vasodilation. Everything has a set of biomarkers which may be useful to diagnose and monitoring the treatment, and organ dysfunction can be measured by scores. Coming to the sepsis biomarkers, there are diagnostic biomarkers like procalcitonin, C-reactive protein, and liposaccharide binding protein, and CD64 molecules. And the prognostic markers like lactate, IL-6, HMG-B1 mediator, and adrenomedulin. And our main aim in studying about the biomarkers is early detection, early intervention, and target-based personalized intervention. Coming to among the biomarkers, the OG biomarkers are always the vital signs and TLC. Vital signs and TLC, these are the earliest and useful biomarkers like fluctuations in temperature, heart rate, hypotension, and saturation. Leukocyte count will provide us the information that all is not well in the body. But the problem with them is they are non-specific and sometimes the presentation is very late. Whereas coming to the NLR, it is a neutrophil and lymphocyte ratio correlates with the worst outcomes. High NLR correlates with the worst outcomes and high mortality. As other biomarkers in this group, OG group, it is also non-specific. There is no fixed cutoff, and sometimes lymphocyte counts appear very late in the disease. Whereas the band cell width or bandemia refers to the presence of proportions of immature neutrophils in the peripheral blood, and it can be used as a biomarker in sepsis, especially for early dissection. Bandemia occurs so early that it can be found even before the rise of TLC. Non-specific and observer, it is has to be given by the based on the smear. So non-specificity, observer variability, and no threshold for it is the limitations for this biomarker. And the next biomarkers of the LDH and ESR, both rises in inflammatory states and in the states of tissue damage, especially hypoxia and anaerobic things. But their rise and fall are not acute, and the whole purpose of early detection is defeated. And they cannot differentiate the event from inflammatory to infection. The next one is ferritin. It is an acute phase reactant and also useful for differentiating viral and fungal sepsis, and is a marker of macrophage activation. The rise of ferritin cell levels is non-specific and is less validated compared to other biomarkers. Lactate is a byproduct of anaerobic metabolism produced when tissues are hypoperfused or oxygen starved. In sepsis, elevated lactate levels often induce tissue hypoxia, shock, and organ dysfunction, making it a powerful prognostic biomarker. But it is non-specific trend, rather than a single value, trend will give us a more useful information. If the initial lactate is more than 2 millimoles per liter, it is a sign of tissue hypoperfusion. Whereas the lactate is more than 4, it is the high risk of mortality, and urgent intervention is needed. Whereas we have to aim for more than 10% of clearance in first 6 hours of sepsis to indicate effective resuscitation. And these are the diagnostic biomarkers which are currently available in the market. Among them, the CRP is a 5-protein synthesized by the liver when exposed to inflammatory cytokines like IL-6 and IL-1 beta. This protein triggers the complement system and encourages platelets, monocytes and endothelial cells to become active. Localized infections can produce false negative results. It can differentiate bacterial to viral sepsis, but estimated CRP velocity levels of more than 4 is a strong indicator of bacterial sepsis. Coming to the procalcitonin, it is produced by the liver due to the insult to the tissue, and it rises within the 2 to 4 hours, and the area of curve is 0.72. And values more than 0.25 nanogram indicates of sepsis, and values more than 1 is indicate more of a bacterial sepsis. And it is also not only for specific for bacterial sepsis, and it is also useful for antibiotic de-escalation therapy. Coming to IL-6, it is produced by immune and non-immune cells. It rises earlier than 2 hours, and the area of curve is 0.71 only. By area of curve, when it is nearer to 1, it is more specific and more sensitive. That is, it is more useful test. Whereas area of 1 is 0.5, it is nothing but a chance. It indicates, not only indicates the sepsis diagnosis, but also can differentiate between sepsis and septic shock. So no specific cutoff is the major limiting factor for the IL-6. And the HMGB1 is a non-histone nuclear protein that plays crucial role in inflammation. It can be secreted by activated macrophages or released using cell necrosis and apoptosis. It has the highest AUC and among 0.95. It is almost the ideal biomarker, but because it has high sensitivity and specificity, but it comes in the late stage of the sepsis. That is, the almost damage is done by the time. And the other one is presepsin. It is a novel immunobiomarker that exists in a soluble form of CD14. Presepsin levels increase in response to bacterial infections, and it is a valuable biomarker for the early detection of sepsis with an AUC of 0.85. It optimizes antibiotic use, but it is very expensive, and it is only under limited availability in India. And the newer biomarkers like circular RNAs and HOTIP and microRNAs, which got high sensitivity, can helpful in potentially targeting the therapy against that biomarker and stopping the pathogenesis. But the limited clinical studies and variable response time hampering the entry into the clinical arena for regular use. These are the, now we have talked about the diagnostic biomarkers, these are prognostic biomarkers. Among these prognostic biomarkers, adrenomedulin, pentraxin and plasmagen activator inhibitor 1 got high sensitivity to predict organ failure, whereas NT-proBNP predicts both organ failure and 1-year mortality. Coming to ESM1, endothelial cell specific molecule, and calcium binding protein and non-coding long RNAs and microRNAs, they are more sensitive to their levels directly, and their levels are directly correlated to mortality risk in the case of sepsis. Whereas the adrenomycin, PTX and PAN are compared to organ dysfunction, these are correlated to mortality in sepsis. Due to limited research and validity and no much info in human studies and clinical scenarios, the availability of them and incorporating them into practice guidelines are of long wait. These biomarkers are available in India, especially procalcitonin, CRP, lactate, IL-6, WBC, which we routinely do, serum ferritin, D-dimer, presepsin and SUPAR. SUPAR is a plasmogen activating reactor which uses for prognosis in ICU. But CRP, procalcitonin and IL-6 are widely available, especially CRP and procalcitonin are incorporated in the sepsis guidelines. And there are many scores which can predict the prognosis in sepsis, like that SOFA score, Q-SOFA, NEWS and PYRO score and etc. These scores are clinical scoring systems that are available, can be interpreted bedside, but the problem is they are both subjective and objective. So it cannot give us the exact biochemical or molecular or cellular component what's happening in the sepsis. These are some scores which helps us in diagnosis. For diagnosis, Q-SOFA and SIRS is useful. For prognosis, SOFA and APACI2, and monitoring changes in SOFA and risk stratification, PYRO or SEPTI score. Similarly, biomarkers are also corresponds to the diagnosis and other things. Whereas coming to the what are the main advantages of scores are, they are easily available bedside and they are instant and fast. they are moderate and broad overview can be taken. But coming to the biomarkers, they are highly and quantifiable, and they can we can get detailed information and high potential for omics and precision medicine. That is, we can target at the level of molecule by using biomarkers. What are the future directions? The future directions is multi-biomarker panel involving more than one biomarker, like combining the CRP, procalcitonin and SAA, and machine learning algorithms and omics based profiling. Omics means genomics, proteomics and metabolomics. All these are combined into a AI assisted EHR intelligence, and then we use the multi-biomarker panel in it. And then that biomarker can guide us to immunotherapy, especially like checkpoint inhibitors and cytokine absorbers. The multi-biomarker panels that are available now are CRP, PCT and SAA panel and 5 cytokine panel, which includes IL-6, 8, 9 and 10 and TRALI. Where AI-driven biomarker tools are used, which the sepsis immunoscore by Prognosis. The sepsis immunoscore by Prognosis is FDA approved and is ready to come into the market. And TREVS and AI-enhanced blood test. In this AI-enhanced blood test for early detection, it considers 22 parameters and analyze them and the trends, and will give us the what is the exact problem and where is what we have to do. These panels are available and they are producing promising results, and widespread availability is still work under process. And to conclude that, they just like in Samudra Kshetrasagar Madaram in Hindu mythology, the Devas and Asuras you all know that story. I will tell you that analogy, that ocean is like human body, which is a vast ocean complex processes. When infection enters, it begins to churn violently, just like a cosmic ocean. The churning is the inflammatory response. Sepsis is the churning of the ocean with immune cells, cytokines and signatures. Whereas while churning, it may result poison like the cytostorm and organ failure. Before we can we find the truth, that is the accurate diagnosis like Amrut or cure for the disease, the body first releases deadly signals like cytokine storm, lactate rise, organ dysfunction. These are like the hala hala. Unless we recognize and contain them, that will destroy the whole body. So with our clinical wisdom and timely intervention, we act like Shiva and neutralizes the poison. A clinician's judgment with the help of biomarkers. So with these biomarkers like CRP, lactate levels and multi-marker panels and AI biomarker, we can eradicate and achieve the biomarkers are all are not the Amrut, but they are the clues that emerge from the cosmic churning of the sepsis. They help us identify the poison early so that we save the patient before the organ damage is irreversible. Thank you.
That was an excellent presentation, Rana. And with the last slide, you have made the mechanism of sepsis easy to understand to all the PGs if they had listened. Thank you very much.
Thank you.
Thank you, sir, for that enlightening and well-articulated presentation. Now I request Dr. P. Sunita ma'am to introduce our next speaker, Dr. Shiva Parvati ma'am.
Good afternoon all. It gives me immense pleasure to introduce a clinician who exemplifies excellence in every sense. My dear friend and a true luminary in nephrology, Dr. Shiva Parvati ma'am. Her academic journey sparkles with gold. She has 5 gold medals in MBBS and she bagged the best outgoing student of NIMS 2018 while completing her DM nephrology. And she has 10 influential publications in peer-reviewed journals, 2 authoritative book chapters to her credit, and leadership roles as Joint Secretary of Women in Nephrology in AP Society and Executive Member of AP Society of Nephrology. Dr. Shiva Parvati has particularly revolutionized critical care nephrology, glomerular diseases and renal transplantation. Today, we are privileged to gain insights from someone who doesn't just study nephrology but shapes its future. Please join me in giving me a warm welcome to Dr. Shiva Parvati.
Thank you, Sunita. I think I'm blessed to have you here because you've given the wonderful introduction about me. I'm Dr. Shiva Parvati, a nephrologist. So you must be wondering why is she here? Because as a nephrologist, I'm peeping into the critical care team. My role has extended, like not just from supporting patients with acute kidney injury. In the next 20 minutes, I would like to all of you to go through what are all the various indications I can help you when you are treating a patient with sepsis. So before that, I just want all of you to say one sentence along with me. Okay, ready? All of you ready? Ready? I scream, you scream, we all scream for ice cream. Ready? You don't. No, that's the thing. If you are, because as a penultimate speaker, I have to activate you. So I scream, we scream. Okay, so no, so I will say I scream. We all scream for. That's superb. So I think I have a very good audience here. So we'll go to the. So this is I have learned from SWIMS. I worked as an assistant professor for 1.5 years in SWIMS. So we start every presentation with one single sentence. Om Namo Venkateshaya. Next slide. So today I am going to talk about extracorporeal therapies in sepsis. Next. Fast. This happens because my son started learning PowerPoint recently. So I'm going to talk in these lines. So first, what is the timeline in the management of sepsis? What is the pathological basis and mechanisms of action of extracorporeal therapies? What are the various available extracorporeal therapies and how to go about it? And our experience with extracorporeal therapies. What are the consensus and what are the controversies? And finally, take home message. Next slide. So timeline of management of sepsis. From morning we have been hearing to all the consultants about multiple antibiotics. We have experts telling about antifungals, about recently drugs in the pipeline. See, in way back in 1992, they have defined sepsis as something that is associated with inflammatory response syndrome. But in 2016, they have added it is also associated with life-threatening organ dysfunction. Next slide. So what is sepsis? For all the PGs here, if you want to take home what is sepsis, sepsis is a dysregulation of the host response to infection. It is not regulated. For that, what we do? So whenever a patient has sepsis, for that what we do, the first important thing is we have to do source control. How do we do that? We have surgeons here. So they remove the infective focus, be it cholecystitis, be it cellulitis, they are the first warriors for us. Source control is the most important thing. Next, addition of antibiotics. For that we have been continuously discussing. It is to kill the pathogen. But is there anything to stop the inflammatory response? Till now we don't have any drugs. Of course we have drugs. COVID has taught us many things, and COVID has taught us the role of anti-inflammatory drugs during this infection, especially during the COVID. They have tried tocilizumab right and left everywhere, and some of them positive results, some of them negative results. But we didn't discuss today about these anti-inflammatory drugs, but I am going to discuss how this uncontrolled inflammatory response can be tackled with by a nephrologist. And finally, the role of extracorporeal therapies, that is beyond supporting the organs. Like if we have renal replacement therapy, I am going to do dialysis. Suppose if we have an acute liver failure, I am going to do plasmapheresis. Beyond organ supporting, there are some therapies that we can apply in sepsis. Next slide. So source control, I have already mentioned. So from morning, what we have been discussing, it is the treatment by addition. So till now, all of them tried to put so many things into your brain. All of them are by addition. Now I am going to do subtraction. So what I am going to do? I am going to remove everything from the body. I am not going to give anything extra to the body. So what I am going to remove? I am going to remove all the anti-inflammatory mediators. Subtractive therapy. Next slide. So do we have any evidence? So this is called as Rakta Mokshana. So Susruta has practiced this Rakta Mokshana. He is the primary surgeon of India. What he used to do? He used to remove all the local blood from the infected site, so that he wants to remove all the inflammatory mediators from the local site. We have moved so far, and this is a statement. Morning Shankar sir has made this statement. I want all of you to remember this statement. Except on few occasions, the patient appears to die from the body's response to infection rather than from the infection itself. And this is the basis for the current role of extracorporeal therapies. We are not going to do anything with the infection, but we are going to deal with the body's response to the infection. Next slide. So pathogenesis of sepsis and how we can apply the extracorporeal blood purification therapies. From here on I will call them as EBPT. So this is what happens whenever there is an infection. Say there is a lipopolysaccharide which is released by the gram-negative bacteria. Suppose if you see this patient at this point of time, that is why I have asked in the morning, how many of you see a patient with fever directly coming to you without taking any antibiotic? Suppose if you see that patient at that particular point of time, yes, you can do source control. Suppose you have started antibiotics but the patient is growing multiple cultures positive. That means source control is not appropriate with antibiotics. At that time, you can do endotoxin removal with the help of endotoxin filters. Suppose you didn't have the chance to see the patient at this point of time. So the patient moved further in the pathogenesis of sepsis. He has a strong, robust immune activation. So at that time, can you do anything? Yes, we can do. We can remove all the inflammatory mediators. That means we can modulate the immune system with the help of cytokine removal systems. Still, you didn't get the chance. Most of us don't get, because you see a patient only when the patient is on double inotropic. At least I see 60% of my patients are double inotropic support ventilator AKI. So at that point of time only we have to do what is called as MODS, that is multi-organ support therapy. Next slide. So this is a simple thing. So what is exactly sepsis? Either you should have a pathogen in your body, or you should have what is called as damage associated molecular patterns, or pathogen associated molecular patterns, or cytokines. So in a sepsis patient, though we don't see on his face, but this is what exactly happens in the internal milieu of the patient. Suppose if you are able to see the pathogen, cultures are persistently positive, go for Seraph filter, okay, that can remove microorganisms as well as the endotoxins. Suppose you don't see any culture is negative, but you still see the patient is having persistent fevers, hypotension, increasing vasoactive support, then you go for a, suppose you see endotoxins. How do you see endotoxins? We cannot see with our eyes. So there are some assays called as endotoxin activity assays. So if you see that the endotoxin activity assay is more than 0.8, so we are justified in removing the endotoxin. At that time we can use the polymyxin B filter, which will deal further. Next, you see only the cytokine storm. All of us are very well versed. All the intensivists are very well versed. IL-6, TNF alpha. So if you see them, you can go for cytosorb or the heme adsorption therapies. Next slide. So for all this slide I have put for the PG students. So what are the extracorporeal therapies? Hemodialysis, hemofiltration, and adsorption therapies. Dialysis works by the principle of diffusion. So it is concentration dependent. Whereas hemofiltration works by hydrostatic pressure gradient, and adsorption nothing but molecules adhere to the surface of the phase, that we use some phase in the filter, all the microbes will come and get attached to that, we can remove. So these are the three basic mechanisms that I am going to use in a sepsis patient. Next slide. So there are various theories. I think they are very simple to understand. The first one is a peak concentration hypothesis. That means when you see the concentration of cytokines are peak, you apply this therapy, you will have a greatest result. That is why the early the better is the key. So whenever you see a patient with septic shock, if you start these therapies within 12 hours of onset of septic shock, you get the best results. That is based on the peak concentration hypothesis. But the next slide is, what happens is, suppose in this diagram, the red one is the blood vessel. If you remove the mediators from the blood vessel, the mediators from the tissue and the interstitial fluid slowly come back to the vessel again. So for that what we do, the next theory called as, next slide, threshold immunomodulation. That means we continuously treat this patient until unless there is a threshold, so that there is no movement of pathogens from the tissue. All the pathogens are completely cleared. So this is one theory, and the next theory is mediator delivery. Like in CRRT itself, we can give very high replacement volumes to the patient. If we give high replacement volume, what happens? The venous return to the patient increases. So all the mediators will come into circulation. Again, my peak concentration theory will help it. So we can remove the cytokines in a very effective manner. And the last one is the cytokinetic theory. So what they propose is, when you do these adsorption therapies, the cells also try to behave in a different manner. So their clearance will be increased. Most of the studies have seen that if we use polymyxin B filter, the HLA-DR expression on the cells will be more, so that they will be effectively cleared by our own system. So these are the various theories, because suddenly I am coming to and telling I have so many devices, use it. But you have to have a pathological basis for it. These are the various theories that support it. Next slide. So what are the currently available therapies? Next. So these are the therapies that I have already told you: Seraph, Toremixin, Cytosop, HA330 and 380 filters, Oxiris, Sepsis and Hemophil. Next slide. How do I select? So now I have given you so many things. What do you want to see? If most of you are from Tirupati, you must be able to tell what it is. The last slide. Can anyone tell? I have given the clue also. So it's a Patala Ganapati temple in Srikalahasti. How many of you will tell I can go through that steps now? It's very difficult. I could have gone through it 10 years back, but now I have a doubt whether I can go through it or not. Similarly, when you are dealing a patient, you have to see whether the particular molecule will be able to pass through this filter or not, through the pores or not. So, if you see, these people are cautious enough, they are assessing before only whether I can go or not. So, the intensivist and the nephrologist, they take a call what is exactly present in the body and whether this membrane will work for him or not. So, that is the important decision that we have to take. Next slide. So, Cytosop, I told you it is a heme adsorption therapy, and the other thing that comes to any intensivist, if I say that I have so many things, they will tell it is complication associated, because we use charcoal. Activated charcoal was the old item. We are not using now. We are having a very good membranes which are covered with PMMA membranes, and of late we are getting resin beads where the complications is less and the biocompatibility is more. So it has a very high surface area of 40,000 meters square. So this is a picture of Cytosop, and here it can remove all the molecules that are between 10 to 60 kilodaltons. So I have given, if you name anything, I think we are all familiar with. Complements, IL-8, IL-6, TGF-beta, HMBG1, all are in the range of the molecules that can be removed by Cytosop. Next slide. This is the one that I am talking. Suppose if you see a patient very early and your cultures are positive, you can use this polymyxin B filter. So how does this work? It's a polystyrene based filter to which we attach polymyxin B, and this polymyxin B will attach to the lipid portion of the lipopolysaccharide. So we are going to remove all the lipopolysaccharide that is present in the body. Next slide. So Seraph is a mythological term which means an angel with 6 wings. So this device, it's a simple one, like it's our endothelial calyx only. So the pathogen binds to our endothelial calyx with the help of heparin sulfate. So this Seraph also has a heparin sulfate molecule. So all the pathogens will go and attach to the Seraph molecule. So this is one of the best things if we can, use these filters earliest in the course of a severe sepsis patient. Next slide. This is, of course, we are doing it only in studies. There's one study called Neutralize AKI trial in which they are testing this. This is called as cytopheretic cell device, where we remove only the activated lymphocytes. They are tagged with a marker and then we remove these lymphocytes. Next slide. So how do we use these therapies? These therapies can be used directly, like we can use only the hemoperfusion cartridge, or we can use the hemoperfusion cartridge in association with either hemodialysis or CRRT. Next slide. So what are the complications? The complications are limited to the introduction of the central line, like infection, bleeding. Other things related to the biocompatibility, that is thrombocytopenia. An important thing that is not yet studied is loss of other anti-inflammatory mediators and antibiotics. So there is no data on how these filters are going to remove the antibiotics administered. That is why most of these cartridges are used only for 1 to 2 hours. And the last one is cost of the therapy. If you ask me what is the cost, each filter will be around 70,000 to 90,000. So it becomes a very tough part on us to counsel the patient to go for these therapies. Next slide. So now we have, all of you might have understood. So I am given small case scenario so that you have to answer what therapy has to be given. So 40 male diabetic, history of RTA, major abdominal surgery for liver laceration and stomach injury. He was successfully resuscitated, but on day 4 develops fever, already on multiple antibiotic regimens. Develops AK, blood culture Acinetobacter. We have heard Acinetobacter doesn't work for even Javisafta and azithromycin, it doesn't yield to. So what do we have to do? So next, what is the next best line of management? Next slide. So change antibiotics as per culture, CECT abdomen to look for abdominal source of sepsis, start RRT and start EBPT. This is a recent case that we have encountered. And all the options are correct because we have done all the three. We have done CECT to rule out abdominal sepsis. We have aspirated the fluid. We have again sent the cultures after 4 days, but we didn't do EBPT. So there lies the inertia. So in every patient, you have to ask yourself a question, will EBPT help this patient? That simple thing, if I can keep you in your mind, I think my talk is successful. Next question. So here is a 45 female, backache of 1 month, fever and pain abdomen for few days. She has taken antibiotic but increasing fevers and hypotension and end organ failure. Cultures, no growth. But we have CRP, procal, D-dimer, all are elevated. So what do you do now? Which phase of sepsis she is? Can I have any answer? Cultures negative, but all these are elevated. So she is in what phase? You are all like me when I am in PG. So you should come up and say the answer. You have understood or not? So she is in Varun. What phase of sepsis, Varun? Source phase or cytostorm phase? Sir, chairpersons, anyone want to tell which phase? Cytostorm phase, because we are very clear, the cultures are not growing anything, so there is no pathogen in the blood. But we are left with all these, from morning onwards we are seeing no procal, it is not specific, it is only used to escalate or de-escalate the therapy. So we are left with, I am just giving a clue, we will not have IL-6 and TNF alpha at our bedside. But whatever we have to use them and say that the patient is in cytokine storm, and yes, this patient will benefit from EBPT. Next slide. So, yeah, next slide. So 26 male RTA, multiple blood transfusions, multiple surgeries, post-operative. After 1 week, he develops persistent hyperbilirubinemia and liver impairment. This is also our own patient in our ICU. We have discharged the patient after 3 months, but he had persistent fevers, cultures always negative. There is no role for stepping up of antibiotics. What do? Normal renal function, so no role for RRT also. What did we do in this patient? Yes, this patient benefits from EBPT, but the type of EBPT that we have used is a cytosorb to remove bilirubin here, because bilirubin itself is a toxic substance. So we have used cytosorb in this particular patient, and the patient recovered very well and discharged it after 3 months. He was like a family member to all of us. Next slide. So this, I try to convince you that there is a role for EBPT in every patient. So what is the evidence? If I have gone through multiple studies, some says they are useful, some says they are not useful, but Claudio Ronco was the person for extracorporeal blood purification therapies, at least in our nephrology community. So what he says is, your patient is not a trial patient. So you have to tailor your therapy. So our patients will not fit into the criteria that they use for trials. Thank you for the reminder. So Mehta et al, they have used certain scoring system, CS scoring system, which is less than 8, 8 to 13 and more than 13. If you start this cytosorb therapy between 8 to 13, the patient gets the most of the benefit. Next slide. So if you ask me the evidence, it is category 3, grade 2B. That means not much useful as per guidelines. But next slide. So our experience with EBPT, if you see, I just try to present this data because if you compare the percentage of CRRT sessions that we are doing in our ICU, in 2024 they are slowly increasing. That I want to tell you that we are not seeing a straightforward sepsis patients. We are all seeing already partially treated sepsis, landing in septic shock. So our utilization of EBPTs have much increased over the last 4 years, at least in Amara hospital. Same is the data with hemoperfusion. Next slide. So these are some of the things that we have done. We have connected the CRRT with the ECMO machine, and this is a cytosorb that we have used in that patient with persistent hyperbilirubinemia. Next slide. So consensus was controversies. Next slide. So I would like to tell customization is the key. So we don't go for CMR and buy dresses nowadays. We all go for boutiques. So that is the same in treatment of the patients also. The most rational approach is to adopt a personalized approach, careful patient selection, patient evaluation and adequate dosing. And how do you tell this? Depending on the inotrope dosages, vasoactive inotropic scores, MAP, lactate and pH. And the most important contribution of cytokines to endothelial dysfunction is a central factor for all this thrombocytopenia, microvascular thrombosis, patients developing stroke and all. So this is very important to address. Next slide. I have put this CS score just not to make you remember, but just go back and see cytosine, when can the patient benefit from cytokines filter. So this is the simple things I just want to tell. SOFA score, we all can do. Yes. Vasopressor requirements, we all can calculate. Yes. Lactate, we all can measure. Yes. If you see IL-6 and procalcitonin, they have measured if you have only. So you don't require advanced lab to start all these therapies. With the data we have, we can select the patients, but within the first 12 hours of onset of septic shock is the most important thing. Next slide. Next slide. So this is the Department of Nephrology. I would like to thank them because they do all these procedures day and night. Next slide. And I want to dedicate my talk to all my patients. Because of their trust in me, I am able to do all these procedures and present to you. Next. Thank you. So the one question that I want all of you to take home is, will this patient benefit from EBPT? Ask in every of your sepsis patient who presents to septic shock and ICU. Thank you.
Thank you, ma'am. That was truly an engaging presentation. Now I request Dr. J. Praveen Kumar, sir, to introduce our next speaker, Dr. Anand Ram Alluri, sir.
I welcome Dr. Anand Ram Garu, consultant onco anesthesia and critical care medicine, who is currently working as consultant at Svikar Hospital, Tirupati. He has done his senior residency from NIMS, Hyderabad, and has worked previously as assistant professor NRI Medical College, Mangalgiri. He has 3 publications to his credit. I welcome you, sir.
Good evening all. My topic is regarding strategies for achieving infection-free ICU. So from morning you are listening regarding secondary prevention of sepsis. So once the infectious agent enters into the body, so how you manage the patient. So all those topics you are listening. Now we target primary prevention. So before the infectious agent enters the patient, so what all strategies can prevent the sepsis we see. So why infection control practices are important means they are so they prevent the hospital acquired infections, and which leads to usage of multiple antibiotics and leads to antimicrobial resistance. So further increases the cost of healthcare. So components of infection control includes so universal precautions, standard precautions, and transmission based precautions. So universal precautions are used when patient infectious status is not known. So when an so HIV positive patient we don't know came to casualty and we want to take an ABG. So in those scenarios we use universal precautions. So usually used for preventing bloodborne infections like HIV, hepatitis B, hepatitis C, and which are transmitted by blood. So all these are universal precautions. We can see washing hands and gloves, PPE, so safe disposal of waste and needles and decontamination, all those come under universal precautions. So standard precautions, so they also when the immune status, when the infectious status of the patient is known, we apply standard precautions. So decreases the transmission of infectious agents between healthcare workers and patients, and from patient to patient, and hospital environment to patient, and hospital spread to patient, and hospital waste to the environment. So standard precautions include hand hygiene and PPE, prevention of injuries from sharps, and safe handling of patient care equipment and environmental infection control. So hand hygiene, so this is the best method which prevents the transmission of infections among patients and healthcare personnel. So when hands are visibly dirty or soiled, we use soap and water we should use. So based on evidence and guidelines. So when hands are not visibly soiled, we use hand rub. Alcohol based hand rub is sufficient. So surgical hand rub, we use mostly chlorhexidine or povidone iodine. So alcohol based formulations like chlorhexidine with alcohol are superior to the povidone iodine containing solutions. So povidone iodine contained solutions, so contact period of 30 seconds to 1 minute, we have to wait. So and chlorhexidine will have residual action also. So chlorhexidine solutions were proven better compared to the povidone iodine solutions. So steps of hand washing, as you know, during COVID, everyone of us did it. Palm to palm and dorsum of the hand, next palm with fingers clasping, and back of the fingers, and thumb, and so tip of the fingers. All these are steps of hand washing. So here we can see palm to palm, and so dorsum of the hands, both hands. Next, palm to palm with fingers interlocked. Next, back of the fingers. Next, thumbs. So next, tip of the fingers. So all these steps are ideally to be followed while doing hand rub or hand wash. And last important thing is there should not be any towel hanging there. So if some towel is hanging, so we repeatedly use the towel, and all the steps will go waste. So these are 5 moments of hand hygiene when we should do hand hygiene. So with hand rub or soap and water. So before touching the patient, and after touching the patient, and before doing any aseptic procedures like central line or arterial line insertion, and after exposure to the body fluid, and after touching the patient's environment. So these 5 moments of hand hygiene are important. So to prevent cross contamination between 2 patients. So guidelines, so already discussed. So when hands are visibly soiled or dirty, we do with soap and water. When hands are not visibly dirty, then so chlorhexidine with alcohol solutions, and chlorhexidine has residual activity. and wearing jewelries, rings, watches, bracelets must be removed. So according to guidelines only. Fingernails to be trimmed less than 0.5 centimeters. So long sleeves and ties to be avoided in ICU, and aprons are discouraged, and wearing scrubs is encouraged. So all these are evidence based only. So we should practice all these things to prevent infection. PPE, we know, so all these components are head cover, mask, gown, gloves, and leg covers, booties, all those include. We all have experience in COVID. We all have worn during COVID pandemic. So, and eyes, nose, mouth to be protected with face shield, and so all healthcare workers and relatives who are having respiratory symptoms should also wear mask, and shoe and head coverings are not routinely required. So prevention of sharp injuries. So single hand scoop method is ideal. We all know. So this is single hand technique. So we should not use two hand technique like we cap a pin. So that is wrong practice. So a single hand technique. So cap should be kept on the floor, and the needle is passed into the cap, and lift the cap and then tighten the cap. So this is the technique to be followed to avoid needle stick injuries. So patient care equipment. So all the equipment contaminated with blood and body fluid secretions should be handled carefully, and reusable equipment should not be used for another patient without sterilization. And new service or repaired equipment should also be sterilized or disinfected before using in OT or ICU. So environmental infection control. So how to disinfect the ICU? So there are many disinfecting agents and sterilizing agents. So disinfection is the agent kills all organisms but not bacterial spores. So sterilization means destruction of all organisms including the spores. Bacterial spores also get killed. So disinfection, high quality disinfection as per this latest evidence. Glutaraldehyde is aldehyde. Glutaraldehyde is the best agent which provides high level disinfection, and it is most commonly used in almost all hospitals. So sterilization, many techniques are there. Ethylene oxide, dry heat and irradiation. ETO sterilization is most commonly employed in our hospitals. So advanced is irradiation, gamma radiation, other techniques. So these are high level, intermediate level, low level disinfectants used, and sterilizing agents, steam sterilization, ETO, plasma sterilizer. So cleaning and disinfection are important because that multi-drug resistant organisms like VRE, MRSA, Acinetobacter, Clostridium survive for prolonged periods in the patient area, like bedside tables, doorknobs, equipment, all those areas, multi-drug resistant organisms stay there for longer periods. So environment cleaning is important. So guidelines for cleaning is also there. So surface cleaning like walls twice weekly, floor cleaning 2 to 3 times a day, and terminal cleaning after discharge or death of the patient. So these sterilization used in our hospital, steam sterilization. For metallic instruments we use steam sterilization, and electronics and delicate instruments use ETO sterilization. And architecture and layout. So this is also important for prevention of for prevention of environmental contamination of environment with bacteria or other agents. So architecture and layout. So ICU should be close to the OT or emergency department, away from the main wards, and air should be filtered, and recirculated air should be passed through the appropriate filters to the environment, because if ICU air is contaminated with infectious agents, if they are released as it is into the environment gets contaminated. So filtration should be 99% efficacy down to 5 microns, and air flow should be from clean to dirty areas, and as per guidelines 6 total air changes per room per hour should be present in ICU. So optimal air movement, we can see there how to where to locate the patient, and examiner is also there in guidelines. So if examiner is like in picture A, so air from the patient is carried to the examiner, so high chances of infection to the healthcare worker happens. So if setting is like this, airflow will be like this, and healthcare worker is not affected by the infectious agent. And here, direction of airflow should be unidirectional. So from here to here, or from up to down. So if air movement is within the ICU or OT, so all the infectious agents will be, the environment will be contaminated and healthcare workers will be infected. So all these are other guidelines. Ideal space between the beds are 3 meters, and adequate wash basins and alcohol gel dispensers should be present at each bed area, and all these are guidelines. And safe disposal, we all know. So green kitchen waste, papers, tissues, plastic waste, and infected plastic waste like IV sets, syringes, all those are red, and so soil waste, anatomical waste, cytotoxic are yellow, and ampules and all blue, and sharps in white. So transmission based precautions, these are specific to the route of transmission of the organism. So airborne precautions are for tuberculosis, SARS, smallpox, measles, chickenpox, varicella zoster virus. So use negative pressure isolation and N95 mask, respiratory protection. All these are airborne precautions. Contact precautions like MRSA, Clostridium difficile, hepatitis, HIV, and scabies. So all these are contact based precautions. So droplet precautions are for influenza, Bordetella pertussis. Our COVID is falls into this category, droplet based transmission. So more than 5 micron size, so droplet transmission. Less than 5 microns, airborne transmission. So contact is direct skin to skin contact. When any injuries are there, direct skin to skin, or from surfaces. So so contact based precautions helps, like MRSA, all those. Specific strategies, these are important as so these these bundle of approaches decreases the hospital acquired infections, like a ventilator VAB bundle. So VAB bundle, if you follow properly, it's shown that it decreases the ventilator associated pneumonia in ICU. So avoid reintubation, avoid intubation whenever possible. So consider NIV. So better you try first NIV, then if patient is not managing with NIV, then go for intubation whenever possible. So prefer oral compared to nasal intubation. Head and elevation 30 to 40 degrees. So oral mouthwash and daily sedation vacation. It's not like etrachirum fentanyl will be going on daily 24 hours, 48 hours, 72 hours like that. So once that syringe is emptied, immediately sister loads and put the etrachirum and fentanyl. That is wrong practice. So daily during rounds we have to stop the sedation and muscle relaxant and see whether patient is becoming awake, whether patient is spontaneously breathing or not. So avoid reintubation whenever possible, and routine change of ventilator circuits is not required. So prefer endotracheal tubes with subglottic suction port, and periodically drain any secretions or any collections in the circuits to be drained. So HME studies shown that HME is better than the heated humidifier. This is HME filter, better than the heated humidifier. So this is old practice. So closed suction systems are better to avoid ventilator associated pneumonias, and cuff pressure monitoring. So cuff pressure to put more than 20 centimeters of water, better to prevent VAP. So strategies reducing central line associated bloodstream infections. So include upper extremity whenever possible. So avoid femoral route. So even if you place femoral catheter, replace it to upper extremity whenever possible. So use maximum sterile precautions. Use 2% chlorhexidine with ethanol. And antibiotic coated catheters are used if catheter is in place for more than 5 days. So ultrasound guided is preferred, and transparent dressing is preferred, and change dressing if dressing is visibly soiled, and insertion date should be mentioned. And so these stopcocks are used. So these are better needleless intravascular catheter access systems. These are needleless. So these systems are better to avoid central line associated infections than to use 3 ways. Those are called stopcocks. So these catheter systems are better. So clean injection port, whenever you are accessing central line, clean with alcohol swab, that is better. And replacement, all these are replacements. So peripheral lines to be replaced if more than 72 hours. So and IV sets and T-pen, all those things are replaced immediately. And if we are using IV set for only IV fluids, less than 96 hours, we should not replace. Strategies to reduce urinary tract infections, and drainage bag should be below the bladder level. So drainage bag should be hang to the bed frame and should not touch to the floor, and maintain sterile closed drainage system and unobstructed flow to be maintained. And 7S bundle for skin and soft tissue infections. So we safe operating room screening, and before surgery ask the patient to wash, to do a bath, then skin preparation, solution, all those things. So antibiotic stewardship, we have panel discussion. So just I am mentioning what is antibiotic stewardship, only one slide. So we follow 5 Ds and 4 moments. 5 Ds are right drug, correct dose, right drug route, suitable duration, and timely de-escalation. So if we practice all these 5 Ds, we are preventing antimicrobial resistance partially. And 4 moments. So making the diagnosis, and cultures and empiric therapy, we starting duration. We try to cut down the duration and stop, narrow, or change to oral antibiotics whenever possible. When patient is improving, change to IV to oral. So innovations, these are recent innovations. So central monitoring system, you all have seen, I think, in many hospitals. Sister need not go to all beds and monitor the vitals. At one monitor only, she can see all the vitals of all the 10 patients, 20 patients, or 15 patients. So this is electronic hand hygiene monitoring system. So this is latest employed in USA. So that badge will be applied to the apron. So that apron turns into red. It tells that your hand is unhygiene. So whenever the indicator is red, you have to go and do hand wash. So antimicrobial textiles. So so that bed sheets and all what we use in ICU, they are trying to make it antibiotic coated cloths, antibiotic impregnated cloths. Like studies showing iodine impregnated drapes, they tried in knee arthroplasty. It has shown that better outcomes. So UV light sterilization also latest they are trying. So this is UV light sterilization. And after all these measures, infection control programs also prevents the infection transmission, and so this is also one of the strategy for prevention of infections in ICU. Okay, thank you very much.
Thank you, sir. That was a wonderful presentation. Now I'd like to request Dr. Munikrishna sir to kindly present a memento to Dr. Rana Pratap sir. I request Dr. P. Sunita ma'am and Dr. Lalita Priya ma'am to kindly present the memento to Dr. Shiva Parvati ma'am. I request Dr. J. Praveen Kumar sir and Dr. Sunil Kumar Reddy sir to kindly present a memento to Dr. Anand Ram sir.
Thank you so much, sir. Now I request Dr. Sandeep Garu, Consultant Critical Care Medicine, Amara Hospitals, to come on the stage and present a memento to Dr. Sunil Kumar Garu. Dr. Sandeep Garu. Please have huge round of applause. Thank you, sir. I request Dr. Sirisha Garu, Consultant Critical Care Medicine, Amara Hospitals, to come on the stage and present a memento to Dr. Sunita ma'am. Thank you. Now I request Dr. Venkatesh Garu, Consultant Department of Anesthesia, Amara Hospitals, to present a memento to Dr. Lalita Priya Garu and Dr. Praveen Garu.
Now I request Dr. Sunita ma'am to present a memento to Dr. Munikrishna sir. And with this, we come to the end of this session. And I request Dr. Shankar Vallapu sir, Honorable Chairman of the Organizing Committee, Consultant and Head of the Department of Critical Care Medicine, Amara Hospital, to take over the further proceedings and introduce the panel. Thank you.
Dr. Shankar sir to come on the stage. Dr. Shankar sir.
It's time for panel discussion. So I invite all the panelists, Dr. Madan Mohan Reddy sir, Dr. Lisa Sahu, ma'am, Dr. M. Srinivas sir, Dr. H. Radhika, Dr. Prasanna Lakshmi Kakarla. I now invite moderator for this panel discussion, Dr. Vijay Kumar M. So let's make this panel discussion crisp and short as time is a constraint. So thank you.
correct antibiotic, as well as it guides the physicians to when to stop or de-escalate the unnecessary antibiotics. We directly goes to the clinical case, usual routine case, and we'll give the panelists each questions to discuss about the opinions in management of this case. 65 years old male, type 2 diabetic hypertensive with CKD stage 3 presented to ER with high grade fever. He had a history of burning micturition and altered sensorium, hypotension, and his MAP is 58. He's tachypneic and oliguric. We presumed he had a septic shock secondary to urosepsis because he had a history of burning micturition and high grade fever. And his labs came as total counts 24,000, creatinine is 2.5 and lactate is 4.8. So this patient was started on IV fluids, NORAD, and empirically started on meropenem and vancomycin. As on day 1, cultures was sent before giving the antibiotic. X-ray was normal, shifted to ICU. Foley was changed because it was inserted in hurry. Then cultures on day 2, over phone it was informed like ESBL E. coli, sensitive to only meropenem. Fever still persistent, and patient was intubated for worsening hypoxia. And day 3 patient had new infiltrates on X-ray. Ball was sent. Ball showed multidrug resistant Acinetobacter, sensitive to only colistin and cefetrocol, which was not available in our setups. On day 4, central lines changed in view of arrhythmia, discharge, and patient had still persistent fevers. Culture grown MRSA. Despite of meropenem and vancomycin, patient still febrile. Intensivist added colistin. Trough levels still vanco trough like AUC by MIC levels are still pending, and renal functions keep on worsening. This is the current status of the patient. He is on meropenem, vancomycin, colistin, still hypotensive requiring 2 vasopressors, still oliguric, required RRT, still febrile. Culture grown 3 different organisms: ESBL E. coli, MDR Acinetobacter, and MRSA. He don't had any obvious source of abscess or undrained source. I would like to start with Dr. Srinivas. Sir, what is your initial empiric choice in this patient? Whether this patient had received appropriate antibiotic, initial empiric antibiotic or not?
It's like patient is in septic shock, so the cultures were taken, and then administration of drugs like meropenem is correct. But why vancomycin is my mind? Because patient is a CKD on maintenance hemodialysis, not on any indwelling catheters and device, but because it's a high risk condition or a chronic medical illness, I think you added vancomycin, suppose. Otherwise, when there is no any indwelling catheters,
he was priorly hospitalized.
Prior hospitalization.
He was priorly hospitalized outside.
So I would consider that if patient has a prior colonization, infection, any recent antibiotic use or hospitalization, in high risk patients with neutropenic malignancy, then I can consider vancomycin. Otherwise, meropenem, and then I would take a ID consult, and then I would go for meropenem and MRSA coverage.
Yes, well taken. I would ask our microbiologist now, how can our diagnostic stewardship improves the antibiotic selection in this case?
Diagnostic stewardship is a part and parcel of antimicrobial stewardship, and this diagnostic stewardship encompasses pre-analytical, analytical and post-analytical phases for any sample that is taken. And usage of advanced molecular techniques, point of care techniques to give rapid results, and critical reports should be promptly informed to the clinician to make proper clinical decision. That is how we can help with diagnostic stewardship.
Rapid achievement of cultures before giving antibiotics.
Yes.
And timely alerts to our
clinicians
clinicians if any reports are happening, and guiding on antibiotic, whether de-escalation of those things will. How I would ask Dr. Mona Lisa, how would you handle antibiotic escalation or de-escalation when, like, this patient had multiple resistant organisms were isolated? How would you, what is your approach of de-escalation?
In this case of ours, she had a urosepsis when she arrived in the hospital, and later in the course she developed like newer chest infiltrates, and the XDR Acinetobacter was isolated, and the central line grew the MRSA. So we need to ascertain like which of the organisms could have been the cause of this sepsis and address the organism. If it seems like all of them could be the cause, then according to the antimicrobial stewardship, we should start with the broader antibiotic, and then when we arrive at the cultures, we can narrow down the spectrum. In this case, it was initially what was it? Urosepsis, the organism was MDR?
ESBL E. coli. Urine.
Okay, the ESBL E. coli, but later on the Acinetobacter was also there. So we can go ahead using a colistin based therapy for this organism, because that would cover the renal ESBL E. coli as well as this Acinetobacter which is there in the lungs, along with maybe high dose sulbactam for covering both of them. And then the MRSA, the line has been changed, and the antibiotic can be given for a shorter course if there is not much of bacteremia and the patient is stable.
Yes. Would you recommend giving combined both meropenem and colistin in this case?
Both meropenem and colistin would not be recommended, because the colistin along with the other sulbactam would cover for both the renal as well as this.
Yes, I would definitely agree with ma'am. Colistin with some sulbactam could be a good option, because Acinetobacter was
yes. There are new
recovered.
chest infiltration and all that, and that ESBL E. coli will also be covered with this.
Yes. And then I will ask our Madan Mohan sir regarding how can our pharmacokinetic and pharmacodynamic based dosing improves outcomes of these patients and reduce resistance in ICU patients.
Yeah. So traditionally we used to decide doses based on the half-lives of the drugs, but later this better understanding of pharmacokinetics and dynamics. So now how we prescribe dose has changed. Like now broadly they divide antibiotics into time-dependent killers and concentration-dependent killers. So there are drugs like beta-lactams which need to be above the MIC for the most of the time in a day, then they work better. So drugs like aminoglycosides and polymyxins, so they basically depend on area under the curve above the MIC or the peak concentrations. So they are concentration dependent drugs. So based on which drug you are using, you should decide how often you should give. Like for example, if you are giving meropenem, so better you give it for a prolonged period instead of after initial bolus. You should place it at more frequent intervals, or you should keep it as a continuous infusion. For aminoglycosides, you calculate the dose for entire day and give it as a single bolus dose. So in this way, not only they reduce the resistance, they also reduce the toxicity or side effects also.
Yes, sir. Well taken. Next question is to Dr. Radhika. What structural elements are essential for like implementing the sustainable antibiotics stewardship program?
To implement this antibiotic stewardship programs, there should be a multidisciplinary team
including ID specialists, microbiologists, physicians, and everyone. And we should develop some protocol and policies for the antibiotic stewardship program. And there should be regular rounds especially in the ICU for this ASP development. And this should be entered in the EHR, electronic health records, so that we can audit and we can we can give the feedback. And we should develop some I think this.
Yes. I would like to ask Dr. Mohan sir, when you consider non-infectious causes of infection, like fever, if this patient continues to have a fever, take it in a different case, when you will consider would you stop antibiotics, consider it as a non-infectious cause?
When the fever is there, it is not that always it is a sign of antibiotic deficiency and always it is infectious. There are several causes of non-infectious causes of fever. So when even the patient having high-grade fevers is hemodynamically stable, not responding to the antibiotics, and the other biomarkers are on the lower side and the cultures are coming negative, then we need to consider the other non-infectious causes, like it could be a autoimmune cause of fever or a drug-related fever. The other causes of fever can be then considered.
Yes. And I would ask Dr. Prasanna, resource constrained settings like tertiary, like these areas, we don't have MALDI-TOF, expect carbar. In these areas, how would you suggest clinicians when you ask them to de-escalate, or what is your approach in this resource constricted settings?
Yes, we can always try out an antibiotic timeout policy, which can be tried once you feel the patient is not having rising fevers. You have already started an empiric therapy, and if the patient is stable, stop the antibiotic for 72 hours and wait for the progress of the patient. That can be done. We do not need molecular techniques for everything. We still get regular culture also within 2 to 3 days in settings nowadays.
Okay, well taken. So, antibiotic stewardships consist of main commitment by the institutional heads and surveillance and tracking of the prescribing patterns, like what physicians are doing, that somebody has like an infection control team should track the previous antibiotic prescription and give feedback to the clinicians. It should not tie the hands of the physicians in prescribing timely appropriate antibiotics. It allows the clinicians to start empiric antibiotic choices, but some centers they might use pre-authorization if infectious consultant is available. Otherwise, some seniors, if have well knowledgeated, they can guide the initiation and formulatory restrictions and pre-authorizations, dose optimizations with the help of clinical pharmacologists, and timely appropriate de-escalation and education and training. This is the vital step, and measuring the outcomes. These are the vital steps in antibiotic stewardship. I hope if any audience, anybody has any questions, can anybody in panelists, anybody has any specific concerns?
For Sahu ma'am, in selecting this empirical antibiotics, we have many discussions, like whether we have to use, we always think likely pathogens and we go for any gram-negative or gram-positive and look at MDR risk factors like that. But we have some doubts, like whether we should select like bactericidal, bacteriostatic, hydrophilic, lipophilic, time-dependent, concentration. Is these all important in selecting empiric antibiotic?
Yes, like we should be, first of all, when a patient has a, like we can divide it into the syndromes, and accordingly, like if it is a pulmonary or we need to localize the focus of infection, and then according to the site of infection, we need to choose the antibiotics, like the aminoglycosides have good penetration for the UTIs. So if it is a urosepsis, then we can think about the aminoglycosides. If it is like a blood sepsis, bacteremia, then we need to consider seeing your antibiogram of your hospital. If there are too many carbapenem resistant bugs, like you are isolating your antibiogram, then you need to go for a carbapenem like CRE coverage outright. And then if the bug isolate comes to be a sensitive one, then you can de-escalate. Like if you are thinking that there is a line infection and you can appreciate there is a abscess around the line inserted, then it could be a MRSA, or if your antibiogram so then you can include a MRSA coverage.
So you will tell that we should know more about the risk factors and penetration, drug penetration.
Yes, according to the site of infection, we need to choose the drugs as well. Like if it is a skin and soft tissue infection or abdominal infection, you would go with the TG cycline. But if it is not in a bacteremia or in a urinary tract infection, you would not go for it. So all these things should be aware prior to choosing the antibiotic. Not only like seeing the culture report, if it says, even in the UTI, sometimes they report the TG cycline in the smaller labs, and you think it is sensitive, go for it, then it should not be there.
Ma'am, in combination therapy, should we use two bactericidal or bactericidal and bactericidal?
Those concepts are no more like valid. Dr. Arun was saying, like the bacteriostatic and the bactericidal, those things do not work that well these days, and synergistic effects and all that are also not seen. So considering a bacteriostatic or a bactericidal drug are not of much relevance these days.
Thank you.
In our audience, anybody has any concerns, like specific questions? If nobody has any concerns,
my question is to Dr. Lisa Sahu. We encounter a lot of hospital-acquired infections in our ICUs. Once day 3, day 4, obviously, if you don't get ventilator-associated pneumonia, then we would be surprised why he did not get. So, for Acinetobacter ventilator-associated pneumonia, which is carbapenem resistant, what is the regimen that do you prefer? Are you, in your practice, are you using fluoroquinol? If it is fluoroquinol sensitive, are you using fluoroquinol combination therapies, or going for polymyxin B-based therapies? Or in your practice, what you are doing, ma'am?
Usually most of our isolates would be resistant to the fluoroquinolones, and even if they are susceptible, we would not prefer using, because in our country it is a TB endemic country, and using the fluoroquinolones for this VAP would be using for like 8 to 10 days, and that would develop resistance, monger resistance. So fluoroquinolones we do not use. We go for a polymyxin based therapy with a high dose of sulbactam, and like if it is still not improving, then we may add on a TG cycline or a minocycline depending upon the susceptibilities.
That polymyxin B with sulbactam combination therapies, usually we use it for bacteremia with Acinetobacter. Is it good for ventilator associated pneumonia also?
Yeah, it does work well.
We can use that one. Which one would be better compared to polymyxin B with tigecycline or polymyxin B with sulbactam?
The recent IDSA guidelines suggest that the sulbactam based, high dose sulbactam based therapy should be used. So we prefer sulbactam, high dose sulbactam along with polymyxin, and if it is susceptible to, then we may add a TG cycline, and even we should specifically ask for the minocycline MICs. We just cannot extrapolate the TG cycline sensitivity to the minocycline as well.
Because in our experience we try to start it when it is sensitive to fluoroquinolone. We wanted to just see whether we can avoid polymyxin B for our patients, but really it did not work in my practice.
There is also a lot of in vitro in vivo discrepancies. That
we used for 2 patients, then we stopped it using.
We do not do.
Thank you, ma'am.
if nobody has any concerns, then we'll conclude the session. Thanks all for our panelists for giving their insights. So we'll conclude. Thank you.
Just be I request Dr. Radhika ma'am to give a memento to Dr. Vishal. I request Dr. Prasanna Lakshmi to give a memento to Dr. Sai Kumar. I request Dr. Mona Lisa to give a memento to Dr. Monisha. I request Dr. Madan sir to give a memento to Dr. Venkatesh. Madan, Dr. Venkatesh. Madan sir. ఇచ్చేసాను Dr. Venkatesh. Sandeep and Sirish. Please. Now I request Dr. Shankar to give a memento to Dr. Dr. Sandeep and Dr. Sirisha. Dr. Sirisha. I request Dr. Siva Parvati ma'am to give a memento to Dr. Sunita. We'll have a quick group photo if all the faculty can come on to the. I request Dr. Rakesh, Dr. Anil to come to the dais for a group photo. I request Dr. Hemant and Dr. Munikrishna to please join us in the dais for a group photo. I request all the delegates also to please join us on the dais for a group photo, please. I request Geeta Bhavani Garu. I request Saraswati Garu to come onto the dais. I request Shilpa Garu to come onto the dais. I request Kamakshaya Garu to come onto the dais. I request R. Sridhar Garu to come onto the dais. I request Sai and Gautam from the IT department to come onto the dais and accept a small token of our appreciation. I request Dr. Radhika ma'am to come on to the dais to join with us. I request Pradeep and Narsinga Garu of housekeeping in charge to come on to the dais. I request Varun to give over the mementos. Nursing incharges. I request all the incharges, Sharath, Amala, Vijay, Nirmala, Kirtana onto the dais to collect a small token of appreciation. Thank you for all your support. I request all the nursing officers, Swarna, Geeta, Sandhya, Mohit, Bhavani, Sushmita, Manjula. I request everyone to come on to the dais and please collect a token of our appreciation. Chandana, Laliita Priya. I request Praveen to come on to the dais. Dr. Praveen, please come on to the dais, and Dr. Rajesh, please join us on the dais. Dr. Hemant, can kindly please join us with the dais. Paramesh Pilchano. Dr. Kaushalya, Anita, Kirtika, Kumari, Laliita Priya, Chandana. I also request technicians Subramanyam, Guruvaya to join us on the dais. I request Parameshwar Reddy and Hema onto the dais, marketing in charge. Geeta Bhavani. ఇచ్చేసారా? I request Sai and Gautam onto the dais. I request Bhavana onto the dais. I request Sai and Gautam of the IT department onto the dais. I request Gautam to come onto the dais. As we conclude, let us carry